on Women was actually created back in 1992. We had legislation that was introduced and passed the Georgia legislature and was signed into law by the then Governor Zell Miller. The commission had 15 commissioners by statute, 5 appointed by the governor, 5 the lieutenant governor, and 5 the speaker. The statute actually laid out the focus and responsibilities of the commission. So what we did in the very beginning, the 15 commissioners came together and we traveled around the state of Georgia so that we could meet with the women of Georgia to explain to them, you now have a Georgia Commission on Women, and we wanted to know, what are your issues? What are your issues of concern? What would you like to see the Commission on Women focus on? And always at the top of that list was women's health care, as well as health care in general for all Georgians. At that time when the commission was first created, we were administratively attached to the Department of Labor. That gave us a home where we could actually, we had an office and they handled all of our administrative services. Later we were attached and moved to the Department of Public Health, which really fits right in with health care being one of our primary areas of focus. We now focus, we have what we call our pillars of focus on women's health care, sex trafficking, as well as maternal health for women of Georgia. We have worked to make sure that the commission reflects all women of Georgia and represents all women of Georgia. And in that, I'm referring to the diversity on the commission, from the diversity of race and ethnicity, from the diversity of the geographic location. We have commissioners representing from north to south, east to west, as well as Metro Atlanta.
While the past 30 years have afforded Georgia Commission on Women the opportunity to have many achievements across Georgia, there are two that I am particularly fond of. Our member and partner Juliana McConnell has worked tirelessly with our government affairs office and working with legislators throughout Georgia to pass legislation that has been important for nurses to really further the health of Georgia women. And then also Carla Jacobs, who has dedicated much of her life as well as hours within the community of training law enforcement professionals as well as hotel workers to really be that advocate for sex trafficking victims. While there have been many achievements, and we've grown leaps and bounds and learned so much in those last 30 years, we are hoping that we will go even further the next 30 years.
Huh? So we're not picking up any of their audio. I am. I'm listening to it right now. The camera doesn't pick up the audio. Their mics are picking up the audio. Yeah, it's not going through. I'm listening to it right now. Like I just heard her say, because it's on about a 30-second lag. I know. It's very faint. Like it should be crystal clear. Yeah. Right, let me add in. I can add in the room mic 1 second here. Yeah. Yeah. I mean, this is the signal coming from their microphone. Yeah. Okay. Do this. That one's.
For everyone.
That's right.
Every layperson who's heard the word health.
That's right.
And care.
That's right.
And put them together. And it's
Health
considered
care.
wellness. Health
I see what
care.
you did there. Wow.
Wellness.
That's good for early on a Friday morning for me.
Absolutely, absolutely. So our very first speaker today is going to be Bhavini Solansky. is the lead for the Georgia Families 360 Degrees program for AmeriGroup Community Care, a managed care organization that has been serving Georgia families since 2006
Wow.
and currently provides services to almost 600,000 members who
Wow.
participate in Georgia's Medicaid, Peach Care for Kids, Planning for Healthy Babies, and Georgia Families 360-degree programs. Today, she will be discussing how to be brave about mental health. And so we present to you Bhavini Solanki.
Hello, everybody, and welcome to the Women's Wellness Summit presented by the Georgia Commission on Women. I am so honored today to have been asked to come and speak to all of you. This is a very exciting time in mental health, and so I'm so pleased to be able to talk with all of you about being courageous about mental health. So I'm going to spend a little bit of time introducing myself, and then we'll talk a little bit about why I'm here today and get into the meat of what I want to share with all of you. So my name is Bhavini Solanki, and I currently serve as a director for AmeriGroup. I lead the Georgia Family 360 program. So you may know that AmeriGroup is one of the 3 care management organizations that serves Medicaid members in the state of Georgia. AmeriGroup is proud to serve almost 600,000 of these members. 30,000 of them are children and youth that are in the foster care system. They are youth that have been adopted out of the system, and then there are a few justice-involved youth. My team acts as a personal concierge service for families and members to help navigate them through what we know is a very complicated system of care. I am a licensed professional counselor. My background has been working with men and women in domestic violence and sexual assault situations. Prior to my role at AmeriGroup, I worked as a therapist in the community, working directly with these kids in Georgia who are in care. I worked as a therapist doing assessments, therapy, supervised visits with families, all of the things that involve child welfare. On a personal note, I am a proud mom of twin boys who are almost 11. And as you can imagine, they keep me very active. I also like to read and enjoy the outdoors. What I want you to know about me is, as a first generation Indian American, I had to work through a lot of my own mental health issues over the years. Assimilation into American culture at the age of 7 was a huge culture shock for me. I came to a small town at that time, small town Katy, Texas, a suburb of Houston, from Zambia, a country in Africa. And in addition to working through cultural ignorance, I really tried hard to fit in. I wanted to be like everybody else. As you can imagine, or may already know, in the Asian culture, high performance at school is basically a requirement. Anything less than is not acceptable. So although I did enjoy school and I did well, I wasn't great at every subject. And obviously there were distractions with friends and clubs and things like that. And if I think about it, I can really trace back signs of my own anxiety and depression to grade school, when things were starting to not be perfect with grades and my performance. In college, there was a lot of pressure from my family to finish school quickly and get married, because that's what life is about. Get married, have children, right? I alternatively wanted to have a career. That was my primary focus. And I wanted to make sure that I did not get married until after I was educated and had some confidence that I would be able to take care of myself financially in the future were anything to happen. And I wanted to fall in love naturally. I didn't want an arranged marriage as my parents were trying to situate for me. So all that being said, I ended up getting married at the age of 27. It was a slightly arranged marriage, long story for another day. I had my boys when I was 33, and then I divorced 2 years ago at 42. I have been in therapy numerous times over the years. The first time was during my graduate school education, when pretty much everybody was required to go to therapy after a certain class, when we're really starting to get in touch with our own emotions and address countertransference and things like that. Um, During those sessions, throughout all of the times I've been in therapy, I really worked hard to address concerns in my own family dynamics. Now, it's kind of a one-sided addressing because nobody else in my family has been in therapy. So I didn't take any medications though until the start of my divorce. And at that time, I had a real discussion with my PCP, who is amazing, and explained to her that I really needed to have my emotions in control during that time, for the sake of my own sanity, for the sake of my children, and for my ability to need to stay focused at work. And so we made a plan together. We chose a medication together. She monitored me closely on it, and it was one that we knew that I could wean off of really easily without a whole lot of side effects. Um, so I say all this to say that I think it's really important for us to be courageous about talking about mental health in ourselves, in the people around us, in things going on in the world, and addressing it is really critical. So we're going to talk a little bit about I'll have some more stories about my own experiences, the importance of using appropriate terminology, and then I have some great information to share with you about addressing health disparities within mental health. So when we talk about being brave about mental health, what I'm asking you to do is to stop apologizing for your feelings. We're human. We're all human. We all have feelings. There's no wrong feeling, right? There's no bad feeling. Every feeling is there for a reason. We should embrace it. We're reacting to the experiences that are happening around us and to us. What I am asking you to do is to start focusing on your thoughts and how they may be contributing to negative reactions to your feelings. So, for example, let's say you're sitting on the couch watching a movie with your partner, and they pick up their phone, they read a text on their phone, they respond to it, and then they turn the phone down with the screen down. You might think, oh, are they cheating on me? Did they just text somebody else? Or you might think, oh, we're watching a movie. I think they might have told somebody that they're busy and they can't talk. You can see how your thoughts are completely different in both of those scenarios, right? And either thought could really lead you down a completely different path. And either path is fine. If you go down the path of, oh, they're cheating on me, and you start to react to that, and then you get clues that are helping you recognize your awareness of, that's not where this should go. My mind is just racing. That's not what's happening. I have no proof. You have the ability to stop and redirect your thoughts. We can do that as humans. It's just making sure that you're aware that that's happening. And it's okay to switch gears. I think what's important is recognizing that when we're dealing with our thoughts and our reactions to those thoughts, you're really taking a leap of faith. And in life, we're constantly taking leaps of faith. We have no idea what's going to happen in the next 5 minutes or 5 hours or 5 years for that matter, right? But we still do our daily activities in a constant leap of faith. What I'm asking all of you is to really be brave about mental health and take a leap of faith about that and about our feelings, and not having to always feel like you have to hide them. So what I'm saying is, you don't have to go on social media and announce to everybody I have anxiety. Although if that's what you want to do, that's great too. What I'm suggesting is, let's try to stop sweeping our symptoms under a rug. For example, if your anxiety is heightened when a friend that you're meeting for lunch is late, then I think it's important to let that person know in a communicative relationship that you need information from them about their arrival time. If they're going to be late, how long they're going to be late, so that you can address that and you can calm your anxiety. If your anxiety heightens at a certain time of day, let's say in the evenings, I start to get, sundowner syndrome, and I really start to get lonely, and it would be really nice if somebody checked in on me. Let your loved ones know what you need during that time. Don't assume that they know, don't assume that they should know. And I think you'll be surprised at how many people around you are willing and able to accommodate to your needs if they just knew, and if you would just ask them, or share with them what it is that you need. The other piece I want to talk about is a lot of us, let's say if we went to a cardiologist because a physical showed we had irregular heartbeats. If I was told to go to a cardiologist, I'm most likely, because I'm a very compliant person, I'm most likely going to make that appointment, and I'm going to address whatever the findings are, and whatever my cardiologist tells me to do, I'm going to do. On the other side, I think with mental health, we see the signs and the symptoms of whatever it is, anxiety, depression, anger. And instead of going to see a specialist and to talk through it with a specialist, we brush it off as a weakness or a temporary thing, or it's just related to this situation. And I think we have to really start to remember and really talk and be bold about talking that mental health is a big part of our whole body health. Remember that physical health is the state of your body. Mental health is the state of your mind, your feelings, your emotions. They are completely connected. When one is off kilter, the other is affected, and vice versa. We work a lot at AmeriGroup with patients who are diagnosed with cancer, breast cancer, other cancers. And as you can imagine, when you get a diagnosis like that, and there may be people in the audience today who have gotten a really tough diagnosis like that, there are moments of sadness and loneliness and anxiety and all of those emotions that come with this unknown situation that's now happening to me. So you can see how that physical health and that mental health is completely connected. You can get treatment for the cancer, but if you don't address the other mental health symptoms, it's going to exacerbate your cancer symptoms, right? Your body needs to be growing towards 100% health in order to really get to that positive space. So think about that. So having hard conversations. I want to tell you guys a story about a physical that I had several years ago. And when the nurse initially came in to take my vitals, go through the list of questions she had and things like that, she said to me, clipboard in hand, "You're not feeling depressed, are you?" And went ahead and was starting to write down no, as she's making no eye contact with me, and had already assumed that my answer was going to be no. And a lot of things kind of went through my head at that moment as a therapist. And I was thinking, one, I've always been taught that when you go to see a doctor, you dress nice, you're polite, they are a figure of authority. And I feel like she was assuming that my politeness and my smiles and my positive interactions with her meant that I have no sadness or depression or anxiety going on, or that I wanted to address. And, I really wanted to know if she was prepared to assess me properly if I did tell her I was feeling depressed. And so I did have a conversation with her about the fact that I was a therapist, and I really felt like she wasn't asking the question in the best way, and the most effective way. And that I think if somebody were truly depressed or feeling signs of depression, they would not feel the ability to endorse those symptoms in the way she was asking it. And so I want to pause here and just say, our healthcare workers are so amazing. Everybody that's working in this field, not just in the last 2 years with everything going on with COVID, but way before all of that. The work that you do in that kind of frontline situation, not just in an emergency setting, but also in our primary care settings, our specialty provider settings, is critical. It's so important. So thank you. Thank you for all that you do. That being said, healthcare workers are in a really prime role, prime seat, to ask these hard questions, and utilize their expertise to really identify people that are struggling or are on the cusp of struggling and really are waiting for an outlet or an opportunity to kind of talk about how they're feeling. I feel that most patients, if you're going to see a physician, whatever kind it is, are ready to listen to recommendations that you make. And so if you, as a healthcare worker, are able to identify mental health early on, and encourage people to get help early, it's really the biggest step that we can take towards ending the stigma towards mental health. I think helping your patients to understand the importance of addressing their symptoms rather than ignoring them or minimizing them is going to be critical. And this is really where true integrated care happens. Thankfully, that nurse was very open to what I shared with her. And I don't know that I've seen her since then, but I'm hoping that she's kind of adjusted the way that she asks that question. So let's talk a little bit about how to break this stigma, because I think that's a really important area for us to talk about. So research shows that knowing or having contact with someone with mental illness is one of the best ways to reduce stigma. And whether you know it or not, you probably do know somebody who has been dealing with mental health. Individuals speaking out and sharing their stories can have a really positive impact. When we know someone who's dealing with mental illness, I think it makes it less scary. And it really allows it to be real and to be relatable. As people start talking about how they've been feeling and what they've been going through, it's things that we can all relate to. We may just have traits of that symptom and may not be a full-on symptom, but I think a lot of it is definitely relatable. And I've been so happy to see more and more celebrities here recently speaking out publicly about their own mental health challenges, as it really allows us to have this discussion in this social media setting. One thing I want us to remember is that for any of us who are around young people, and I think a lot of us are, whether it's your own children or just young people around you or your patients or students or whomever, they're watching how we are all reacting to these things. So I think it's important to make sure you're keeping yourself informed, and that you're open to open dialogue. So according to psychiatry.org and NAMI, who I love, NAMI is a great resource. There are some really great suggestions on how we can make a difference on how to reduce stigma of mental health and mental illness. So one, it's important for us to talk openly about mental health. Let's have discussions on social media. Let's have discussions at work when it's appropriate with your friends and your family. Let's talk openly about it. When you see somebody that's posting something that seems stigmatizing, make a comment, send them a private note, send them some resources, educate what the reality of the situation is. And let's not allow others to, continue on with that assumption, whatever it might be. As I said, NAMI is a great place for resources if you need some stats or you want to verify something that somebody has said. That's a great place to start. I think it's important to respond to misperceptions or negative comments by sharing these facts and experiences. Let's not be shy. I think it's important for us to learn together. Be conscious of language. People need to remember that words matter. Words really matter. Instead of referring to someone being a victim of mental illness, refer to them as someone who's living with a mental illness. Their diagnosis doesn't necessarily have to be a negative thing. Suffering is the connotation that somebody's not well and that they are unhappy. But there's a lot of people with mental illness that are able to live fulfilling, healthy lives. When I was on my anti-anxiety medication during the first 6 months of my divorce, which was a crazy, stressful time, my coworkers told me that I was the happiest and most productive at work that they had ever seen. Now, certainly the medication was a big boost to that, but me being in therapy was a big boost to that as well, because I was able to kind of manage everything that was going on in my life at a really stressful time. So there's that word of encouragement for you. So the next suggestion is to encourage equity. If someone is diagnosed with cancer or diabetes, we don't immediately think we should lock them into a facility. Instead, we give them a treatment plan. We encourage them to work that plan. We check in with them. We explain to our loved ones why our hair is falling out, or why we need to eat every couple of hours or test our blood. It should be the same thing when it comes to mental health. We need to encourage treatment where a professional can create a treatment plan. Going to a therapist is not a bad thing. Going to see a psychologist, getting testing done, going to see a psychiatrist for medication, those are not bad things. Those are steps on a treatment plan to get us to a healthy place. The next suggestion is one I hope that we already all know, is to show compassion. I would add also to that, don't make assumptions. Ask questions. Ask what you can do for them. Be honest about treatment. If someone needs to go to a facility for treatment, it's not any different than someone having to go to an emergency room for breaking a bone. We really need to start to equate those things as the same. The next suggestion is choosing empowerment over shame. Own your life and don't let anyone else tell you what you should and should not be doing. You are the owner of that. And I think it's really important for us to know that we know ourselves best. And that being said, if we're struggling with that, that's when getting help is really going to be important. So here's some great ideas or suggestions of things you can say when you're in a conversation with somebody and they share with you things about their own mental health journey. It's going to be really important for us to be supportive, to listen, to ask questions. And I think, you'll see on the screen, these are really simple things that you can say to somebody that will mean the world to them. So hopefully we can take some of these and use these suggestions. So mental health disparity. According to the APA, most racial and ethnic minority groups overall have similar, or in some cases fewer, mental health disorders than whites. However, the consequence of mental health in minorities may be long lasting. So let's get into that a little bit more. I'm going to read through some of these slides to you because this information I think is really critical and important for us to hear out loud. So ethnic or racial minorities often bear a disproportionately high burden of disability resulting from mental disorders. Although rates of depression are lower than Blacks and Hispanics than in whites, depression in Blacks and Hispanics is likely to be more persistent, as we just said. American Indians or Alaskan Natives report higher rates of post-traumatic stress disorder and alcohol dependence than any other ethnic or racial group. White Americans are more likely to die by suicide than people of other ethnic or racial groups. Racial and ethnic minority youth with behavioral health issues are more readily referred to the juvenile justice system than to specialty primary care compared with white youth. Minorities are also more likely to send up into the juvenile justice system due to harsh disciplinary suspension and expulsion practices in schools. I think these are all things that we have to really keep in mind when talking with our loved ones and people that are around us and misperceptions that are out there. Finally, there's a lot of differences in the types of services, outpatient, prescription medication, inpatient services that are used more frequently by people of different ethnic or racial groups. Studies show that adults identifying as two or more races, whites and American Indian Alaskan Natives, were more likely to receive outpatient mental health services and more likely to use prescription psychiatric medication than other racial ethnic groups. Inpatient mental health services were used more frequently by Black adults and those reporting two or more races. Asians are less likely to use mental health services than any other racial or ethnic group. Then the final thing I want to leave you with is really thinking about what the barriers are to care that are affecting access to treatment by members of diverse ethnic or racial cultures. Lack of insurance, underinsurance, mental illness stigma, and often that stigma is greater among the minority populations, as we've talked about. Lack of diversity among mental health care providers. Lack of culturally competent providers. Language barriers. Distrust in the healthcare system. And then inadequate support for mental health service in the safety net settings. So I know we talked about a lot of things in this time that we've had together today. What I want to leave you with is ask the hard questions. When you see something, you know, that phrase, and I don't know who created it, but the see something, do something, or see something, say something, I'm sorry. If you see a person in your life struggling with mental health, whatever that is, anger, depression, anxiety, sadness, OCD, whatever it is, ask questions, ask them what you can do, ask them to help you understand so that you know how to support them. Ask them what they need to be supported and understood and know that they're still loved. And I think for those of you that are healthcare workers, it's going to be really critical to make sure you're keeping yourself informed and educated. And check the way that you speak to people when you're asking some of these questions. You know, the story about the nurse is one that I have told a lot because it's one that really obviously impacted me directly. And it was in a setting where I was able to help rectify the situation. But a lot of other people who are not a therapist like me may not feel comfortable doing that. So know that you are all critical in really helping break this stigma. And we can do it in a very, very simple way. So let's do that for each other and for humanity. So in closing, I want to say that there's no doubt in my mind that these last 2 years, 2.5 years with COVID has affected everybody's mental health around the world. There's not a single living being who hasn't been affected by this. And I don't know that there's anything in our human history that can say the same thing. I think that we've learned that loneliness is a very real thing. We've learned how other people are struggling through stories that have come out and that we've been hearing. We've come to depend on others in a different way than before. We've come to learn how to communicate better through times where we weren't able to see each other or be close to each other. And I think that we're learning how to share our love better. And by breaking the stigma, we really will be able to do that in a whole nother way. So thank you all for listening to me today. And I hope that we all continue to be courageous about our mental health. Thank you.
Thank you so much, Dr. Salanti. That was some amazing insight on mental health, which you know is like literally one of our goals right now. It's so unfortunate that we're losing so many people to these challenges. So thanks to people like you for learning more about it, and hopefully we can save more lives and continue to advance the movement. All right, so now for our next presentation. Dr. Supriya Mirapalli is the medical director of infectious diseases at the Northeast Florida Physicians. So she's here to give us a little update on COVID-19. I think everybody knows what COVID-19 is right? Thank you. Welcome, Dr. Mirapalli.
Supriya Manapali, Medical Director for Infectious Diseases at Northeast Georgia Health System. Thank you again for inviting me to speak at the Georgia Wellness Summit this year. And I'll be sharing with you some information about the implications COVID-19 pandemic has had and continues to have on women's health. I have no relevant disclosures. I was hoping by the time I'm doing this talk, those arrows that are pointing up would be looking in a different direction, but here we are again. The cases are increasing, and but if you look at the numbers at a glance over the last 2 years, you see almost 83 million people have been infected with this COVID-19 virus, and almost close to 1 million deaths. And each number there represents someone's close family member, mother, father, sister, brother. So several families have been devastated by the loss this pandemic has caused. And while we're not seeing a steep increase in the hospitalizations with the new variant that is circulating, that is something we're closely monitoring as well. So one good thing, though, is that the vaccination rates have increased, and at least 82% of population in US 5 years and older have received at least one vaccination. And here again, a little bit more in detail, as you see that upward arrow, the cases are increasing in the last few weeks. And as we all know, since the beginning of this year, it was predominantly the Omicron. But in the Omicron, the lineage, which means, again, you can call it a subvariant that is circulating, or the BA2 and the BA212 lineages. And what we're seeing mostly with this are that causes very mild infection, mostly fevers, chills, body aches, cough, sore throat, some GI symptoms, and most are recovering with a mild infection, and the hospitalizations are not increasing steeply like we have seen with Delta. And if you look at the cases, we see here that the red bars represent the number of cases, and the blue bars are the deaths. While more cases were seen in women, you see here that deaths were more in the men. And again, when it comes to why more cases were seen in the women, again, it could be various factors. Again, women are the primary caretakers, caregivers at home in most families. So they have an increased risk of exposure there if they're caring for someone who is sick. And also just the changes in how our bodies react to the virus, and the immune response to the virus also varies between men and women. And there's several factors. There is this the genes expressions, the hormonal changes, all of them affect these. But what we did see is that, again, throughout the 2 years, we've seen that men tend to get more severe disease compared to the women, and the deaths are also more in men compared to the women. And if you see again here at the age groups, while the number of cases we're seeing more in that 18 to 29 and then up to the 64 years, those who are more, but the deaths are more again in the older population, those 65 and above are at highest risk of dying from the infection. But I really hope with the new variant, what we see are more infections, but most of them stay mild and people recover without requiring hospitalizations. And I'm sure you all have read or heard of reports where this pandemic is moved to the endemic phase, where the virus will continue to circulate in the communities, and then it fluctuates from being the high levels to the low levels. That's why if you look under the CDC website, also they have the COVID data tracker that talks about community transmission levels. So the virus in some ways is staying endemic in our communities, and the levels of it are varying again based depending on various factors. This is actually a study or data from early on in 2020, and what was observed in this particular study kind of stayed true throughout the pandemic, which is that among women, while the initial symptoms between those who are pregnant women and non-pregnant may relatively stay the same. Pregnant women are at highest risk of hospitalization, requiring ICU stay, or receiving mechanical ventilation or ECMO treatments. And again, this is something we observed throughout the pandemic. And one thing that's important that we have noted again, since the availability of the vaccine, is those who are not vaccinated, not up to date with the vaccines, are at the highest risk of having severe disease, getting hospitalized, or requiring an ICU stay. And these are the numbers I got from the CDC website. Total cases of COVID-19 reported from Jan 2020 to May 16. More than 200,000, and total deaths 297, and hospitalizations 32,883. Just from a week ago or 2 weeks ago, when I have worked on my slides, to now again, those numbers had slightly increased. So while it is true that the current variant that is circulating causes mild disease in the most, it's important to remember that pregnant women remain high risk of developing severe disease. So important to get vaccinated and stay up to date with the vaccinations. And just while we're talking about the implications of the COVID-19 pandemic, in women, just focusing on the pregnant women, in the next few slides, just want to share some data. In this particular graph, if you see, the data is from January of 2020 to May of 2022. And if you look at the number of cases, again, the highest peak was during the Omicron variant, as expected. But if you look at this next slide, the highest number of deaths were seen during the Delta surge, which was in 2021, starting from July and went on up to November of 2021. And we saw even at our health system, and I've heard from several colleagues, we saw several pregnant women admitted into the ICU, to the hospital with severe disease, and most were unvaccinated at that time. And again, this graph also continues to show that pregnant women are increased risk of ICU admission requiring mechanical ventilation or an ECMO treatment. And this one again, this in this particular graph, if you see from March of 2020, that's the time we didn't have any treatments. That's the time we didn't know how to treat the virus. The most important thing we were doing was isolation at the time. We did not have access to vaccinations, and treatments have evolved so much over the course of last 2 years that having the option to take oral treatments is really a huge advantage and improved access. While there is an infusion also still available against this variant, having access to Paxlovid or molnupiravir is I've been huge plus, thanks to all the research that went into developing these medications and making them available. And these medications are available so easily in multiple pharmacies at this point, and they should be there is no reason not to start treatment early to prevent progression. I see your admissions, if you saw here, again, there was a peak there early on, and again during the Delta surge. But with the Omicron, which we saw in the beginning of this year, while there were cases of pregnant women getting admitted, the highest numbers were during the Delta and the earlier surges in 2020. While I'm showing these graphs and talking about numbers, again, it's important that each number there represents somebody's family member. And it's really heartbreaking when we see someone young who is admitted to the ICU, very sick, and is pregnant, and as physicians we are struggling to save 2 lives and to protect 2 lives, and we really hope they make it. And having to make those hard decisions is really difficult on the family, on us as healthcare workers as well. And we have seen or we have gone through that several times during this pandemic. And if you look at the ages as expected here, the younger people who are up and about, it's really hard for them to stay at home, who are working, who are caring for others at home, are at increased risk of exposure. And most cases were seen in those age groups. And then when we look at pregnant women by race, ethnicity, here if we see most of the cases were in Caucasian, followed by Hispanic, and then African American. In our community with the earliest surge, we noticed a trend that most of the patients that were being admitted were Hispanic, and several from the same family. We also saw that a lot of them worked. We are in Gainesville, the chicken capital of Georgia, and we saw that several of them worked in that industry. So we did a lot of community campaigning for testing, education to raise awareness about mask use, monitoring of symptoms, getting tested early. So a lot of work and effort went into that in our communities early on. And again, while the vaccination rates have increased across the US, there is always that question that comes up: are the vaccines safe in women who are pregnant or planning to get pregnant? We all must be reassured that there is data from thousands and thousands of vaccinations that have been given. CDC continues to monitor the data. There's various safety monitoring systems in place, and they all have proven again and again that vaccines, the currently available COVID-19 vaccines in the US, are safe in pregnancy or those who are planning to get pregnant. And the vaccine itself does not cause COVID-19 infection because it does not have the virus in it, and they also cannot make anyone sick with COVID-19. We all may have heard of somebody who went and got the vaccine today, and then they develop the infection tomorrow, and that's 2 days later. That's most likely because they've already had an exposure before. And also, once you get the vaccine needs time, 1 to 2 weeks, for it to develop the immunity. So it's not failure of the vaccination or the vaccine causing infection. It's just that it's a coincidence where someone who got exposed developed the infection around the same time as getting the vaccine. Also, as we all know by now, any of us who've been vaccinated, after we get the vaccine, as the body is building the immune response, we develop some symptoms of some fever, some muscle aches, and that just indicates the body is developing the immunity, not necessarily COVID-19 infection. And as I mentioned here, both the three vaccines that are available in US, Pfizer, Moderna, the mRNA vaccines are recommended over the J&J vaccination. And the vaccines are safe in pregnancy, and several studies have been published showing that, and the monitoring continues. And it's getting vaccinations not only protects the pregnant woman, but also the babies. And there is data to show that vaccinations are safe, not just late during the pregnancy, but also early on during the pregnancy. If someone receives the vaccinations, there is no increased risk of miscarriage or any other effects on the baby or the fetus. And data shows that receiving the mRNA vaccine during pregnancy reduces the risk for infection, severe illness for people who are pregnant. So I think the most important message is that the vaccines prevent severe infection, vaccines prevent deaths, vaccines prevent hospitalizations, and vaccines also protect the babies for at least up to 6 months that we know, where the maternal antibodies are transferred. So the babies also are protected. And recent studies compared people who are pregnant and received an mRNA vaccine with people who do not get the vaccine, and studies have shown lower risk of infection from the virus that caused COVID-19 and in the pregnant women who got the vaccination. And again, vaccination during pregnancy builds antibodies that might protect the babies as well. And when the women who are pregnant receive the vaccination during pregnancy, then studies have shown that antibodies made from the pregnant person that received the mRNA vaccine were found in umbilical cord blood. This means that the COVID vaccination during pregnancy protects the babies also. And there was a study, a small study, that found that at 6 months old, majority of infants born to pregnant women who are vaccinated during pregnancy had detectable antibodies against COVID-19, compared to 8% of infants born to pregnant people who had COVID-19 during pregnancy. I know there is that debate about natural antibodies that we develop following natural infections, antibodies we develop following vaccination. While I humbly accept that the science continues to evolve even after 2 years, and the debate will continue, we have to recognize and accept the importance of getting vaccinated and the protection the vaccines confer to those who are at high risk. There is new data shows that completing a 2-dose primary mRNA COVID-19 series during pregnancy helps protect babies younger than 6 months from hospitalization during COVID-19. And in this particular report, the majority, 84% of the babies hospitalized with COVID-19 were born to pregnant people who were not vaccinated during pregnancy. It is true that most of the infections in children are mild, but still it's important that we protect the babies, and pregnant women getting vaccinated helps protect babies due to transfer of the antibodies. The other thing that, again, that continues to evolve and we all continue to adapt is the guidance. As we learn more and more about the vaccinations, their effectiveness, how long the antibodies last, the new variants that are coming into the play, the guidance, while it can get confusing from time to time, it is important to note that CDC, our researchers, are staying on top of it and providing us with the most up-to-date and updated guidance as things change. That is one thing about science. Change is constant and we have to update ourselves. And as it's important that women speak with their primary care physicians, OBGYNs, if they're pregnant, and seeing them to make sure they're aware of the most up-to-date vaccination schedule that is recommended by CDC, and follow that and stay up to date with the vaccines. It's not just with the first and the second doses, but also the third dose, the booster, and if they qualify also for the fourth dose. Again, extremely important to stay up to date with the vaccines, not just get the first 1 or the 2 doses. Studies based on, again, as I said, change is constant. We have to keep updating ourselves. Pfizer and Moderna, which are the mRNA vaccines, are preferred over the J&J vaccine for primary and booster vaccination. but J&J vaccine may be considered in some situations. Anyone 5 and older in US has access to the vaccination. We're still waiting for all the final approvals to come through for those younger than 5 years, but that may not be too far off because the FDA is meeting mid-June. I think it's 14th and 15th, and hopefully we'll hear more soon about vaccinations for the little ones under 5 years. And there also has been a recent approval for a booster dose for those 5 to 11 years as well. So please, again, talk to your pediatricians and stay up to date with the vaccination. That is the most important thing, not just getting incomplete vaccinations is not going to help protect us long term. The reason why mRNA vaccinations are preferred over the J&J is because of the possible causal relationship between the J&J vaccine and a rare and serious adverse event, blood clots with low platelets, that was observed in some following the J&J vaccine. It occurs at a rate of 3.83 cases per million J&J doses and has resulted in deaths in some. So if mRNA vaccinations are not contraindicated, those are the recommended vaccines. That's the Pfizer or Moderna. And when do we consider J&J vaccination? When we cannot get the mRNA vaccine. We had severe reaction after an mRNA vaccine dose, or a severe allergy to an ingredient in the mRNA vaccines, or if we would remain otherwise unvaccinated, because of limited access to the mRNA vaccines, or someone is aware of all the risks with the J&J, but still would like to get it despite the safety concerns and would otherwise stay unvaccinated. If not, then these are the scenarios to consider the J&J vaccination. I know initially the convenience of the preference of one needle stick, one dose was something that prompted or tempted many to pursue the J&J vaccination, but as we all know by now, that also requires boosters. I think this is one thing that makes me really happy to see, and I hope these numbers continue to increase. More than 95% of those above 65 years are vaccinated, and again, the numbers are more than 80% have received at least one dose of the COVID-19 vaccine. This is those 5 and above where the vaccines have been currently approved. And but it's not just getting the one dose. I know I sound like a broken record, but that is so important to note that it's not just getting the one dose or the second dose. It's about staying up to date with the vaccines. That is important. I've been also asked to briefly cover long haulers. While research is still going on about learning more about who develops this, why they develop this, and again, how to manage long haulers, because the symptoms that can be seen are so widespread and varied. Some of the long haulers have breathing issues, difficulty breathing, cough. Some have tiredness that stays on for months, and some have muscle aches, chest or stomach discomfort. Some develop heart palpitations or altered heartbeat, and some of them have developed like pins and needles feelings, GI symptoms like irritable bowel, change in taste and smell that lasts for several months, dizziness or lightheadedness when standing, difficulty sleeping, rashes, mood changes, changes in menstrual cycle, headaches, brain fog. The symptoms, this thing have been so varied. I know my mom actually, her post-COVID sequelae were alopecia. She lost most of her hair, and she had mild arthritis, and that flared up significantly to the point she now needs a joint replacement. So those were her post-COVID symptoms. But I've heard from my patients, family members, and friends that the post-COVID long hauler symptoms are so varied. So where they seek help really depends on what they are experiencing. I had to send some of my patients to a neurologist, some to the pulmonologist, some needed psychiatry help and cardiology. So it really is varied. But if someone has had COVID-19 infection, and or experiencing symptoms that are ongoing that they didn't have before, should not ignore that and should get tested and further evaluated so that that can be appropriately managed. What is some, so again, when it comes to women, this was something we were observing, but again, for studies to show that in this particular study, almost 75% from the Mayo Clinic, 75% of the long haulers were women. There have been other reports from across the world where in one study, I think it was 4:1, majority were women that developed the long hauler symptoms. And not only that, the symptoms were much more prominent and more symptoms were seen in women. Again, what is the reason for that? Is this related to the strong immune responses that women elicit during the initial infection, that as they progress to the long hauler stage, they do develop this type of autoimmune response that is longer lasting? Again, research is ongoing, but this is something also seen more commonly in women. We cannot ignore that. And studies have shown that when there is no test that can prove that your symptom is from long hauler, other than you have a history of COVID-19, there is no specific, like for COVID-19 acute infection, we would do a PCR test and see this, you have an acute infection. For long haulers, there is no go-to test that will confirm it is these patients have COVID-19 long hauler symptoms. It depends on that physician or provider's thorough history exam and tying all that information together to diagnose COVID long hauler patients. So again, very important that they are diagnosed and appropriate treatment started without any delay, because what we are seeing is that even those who recover from the acute infection, COVID long hauler symptoms are leading to many changing their life. It's affecting their lifestyle, what they do day to day. It's affecting their work. Many have either left the workforce or gone part-time or changed to a different job, depending. And this is having long-term effects on health, lifestyle, financially, and several aspects of our life. So important not to ignore these symptoms if anyone notices that even after they recover from infection, they are experiencing. And it was disappointing for me to read one of the studies actually, but this is not new. It's been observed with some other diagnoses as well in the past, that sometimes in women, these symptoms, if they're present, if they're complaining of some of the mental health symptoms, they could be ignored. But I think it's important, again, that providers take these seriously and not ignore them, and provide appropriate support and help and direction without ignoring any of these symptoms. And when it comes to the pandemic effects on women's health, we all have seen it in the last 2 years. Yes, the effect of the virus that causes the infection, effect on the family if it spreads to the others, then the long hauler symptoms, if anyone goes on to develop those symptoms. Some studies have shown almost that 20 to 30% of COVID-19 patients can develop long hauler symptoms. While we're still studying and learning more about this, it's not just the direct impact of what the virus does to our bodies if we get infected. There is so many things that have changed in the last 2 years, and that has affected our lives. Employment losses. Studies have shown that women were more likely to report employment loss than men, as well as actually foregoing work to care for others at home. And also in some countries across the world, I've seen reports of more women and girls dropping out of colleges and schools to care for others at home. And also gender-based violence has increased during the pandemic. People are staying more at home, lockdown, and there was no difference in vaccine hesitancy or uptake between men and women, but the impacts of the pandemic go beyond just the direct effects of the virus. And women in the role of caregiver, as in most of the families at home, also remained at increased risk of contacting the virus. And also, especially for women in healthcare, where they're juggling work and home, there's increased risk of exposure, exhaustion, mental, emotional, physical stress, burnout. Sad but true, we're seeing so many leaving healthcare for alternative industries or going part-time. And the impact of this pandemic has been really, really huge and has touched almost every aspect of our lives. And balancing work at healthcare facility, again, as we all know, healthcare facilities, through the surges, the workload has increased. And so trying to balance that and the chores at home has been a challenge, and increased risk of anxiety, depression, insomnia, burnout than their male counterparts has been noticed among women. So it's important that women take care of their not just physical health, but also mental and emotional health, seek help readily and timely when they need that, and not ignore this. I know we also tend to be tough for our own families, but we have to recognize that we have to stay healthy to take care of others. So important to seek that help timely. And lockdowns, as I mentioned earlier, there's been increased physical violence also reported during the pandemic times, but also in some areas, in some cases, it was the exact opposite, because maybe they had reduced access to seeking or calling for help due to barriers, because most people were staying at home. So again, that also reduced access to family planning services, leaving them exposed to unwanted pregnancies, health risks, school dropouts. Access to prenatal care also was affected. And while data shows that women, and I've mentioned this early on in the presentation, are less likely to develop severe disease from COVID-19 than men, they also are more likely to be diagnosed later. I think we tend to just push ourselves till the last drop to care for others, but that also means that even though most infections are mild in us, we tend to get diagnosed later. And for that reason, what has been observed in some studies is that once they were diagnosed, they came in very sick and they died earlier, suggesting that they may not have received care in a timely manner. So not just COVID-19, but any other medical conditions also delaying can lead to other complications. So it's extremely important that women take care of their health so that they are there to take care of others in their family. Studies and reports have shown that women with private insurance Medicaids are nearly twice as likely to have received a COVID-19 test compared to uninsured women. And uninsured individuals are less likely to seek a test out of the cost implications on that. And also, one thing we noticed is that throughout the pandemic, information access, it's so important. Not everybody is technology savvy, has access to the internet, can read, and we have to recognize these barriers. It's important to spread that awareness that testing is available at the public health or other sites readily, and vaccinations are free of cost. And also now that we have the medications available also, without any cost, the oral medication. So it's important that we spread this information so that women do not stay at home if they have symptoms out of fear of the cost implications of that. And I think the pandemic has brought to the forefront the importance of mental health. Not just, what's on the news, what's happening around us, what our families have experienced, our friends and families. it has affected all of our mental health, and we have to take that seriously. We cannot ignore that. And for some, it may be minor or moderate, but for some, it could be a major impact on the mental health. And delaying seeking help can lead to other complications and untoward events. So extremely important to recognize that and seek help readily. And what can we do? I don't know if there is a magic wand or there'll be a huge announcement that will say the pandemic has ended. Now is the endemic phase, but I think we're all kind of accepting that the virus is endemic in the communities now, and that the levels just vary from time to time. What can we do? Again, we have to be there to support each other. We stay up to date on vaccines, share the information, get tested early if you have any symptoms of COVID-19, isolate if positive, and stay up to date with preventive care, not just COVID-19 vaccination, but other preventive care, because this quote pretty much summed up what communities and countries and ultimately the world are only as strong as the health of their women. This is a quote by Michelle Obama, and I think it's just sums up everything that I wanted to say, that as women, we have to take care of ourselves to set that example to others and be there to take care of our friends and family. So that's all I have. And I'll pass it on to Melissa. Thank you.
Thank you, Dr. Manapali. That was so informative. Thank you for providing that information. My name is Melissa Timchak. I serve as the Chief of Staff to our President and CEO, Carol Burrell, here at Northeast Georgia Health System. And I have had the honor and privilege of working side by side with Dr. Manapali throughout this pandemic, now into the endemic stage, as you said. And we have been fortunate here at Northeast Georgia Health System to have your guidance and your leadership through this pandemic, and also your great wisdom and expertise and the ability to ask you all sorts of questions as we have gone through the last 2 years. And so I am thankful that you were willing to share this information with our audience today. And I would just like the opportunity to ask you a few questions. As has been our practice throughout the last 2 years, you have participated in numerous town hall meetings with our employees and have given us the opportunity to ask you a lot of questions ranging from all sorts of things. It's been pretty incredible to think about all the questions that have come up over the last 2 years. But I have a few questions and was really thinking as you were talking how fortunate it is for us to have you focusing specifically on women's health when it comes to COVID-19. We've heard a lot of information over the last 2 years about COVID-19, but it's really important, especially in this forum, I think, for us to talk specifically about women's health. So it was really interesting to hear you give that perspective. I have a couple of questions. Of course, I'm a woman, you're a woman, we're both mothers. And so a lot of these points are of special interest to us as we think about keeping ourselves safe as well as our families. So kind of going backwards a little bit in what you just talked about. Your last slide was about what can we do now? We're in this endemic stage, as you said. Unfortunately, looking like we are probably going to have to learn how to live with COVID in our lives, at least for the foreseeable future. And so you talked about a few of those things on your last slide around vaccines, staying up with preventive care. But let's talk a minute about mask wearing. You and I both work here in the hospital. We're still wearing masks when we're in patient care areas. So masks have not gone away for us in the healthcare setting, but we are thrilled that in office settings and in the community, if we're fully vaccinated, we're able to go about our lives without masks. But as you talked about at the very beginning of your presentation, we are starting to see cases rise, certainly in different parts of the country. Some cities have reinstituted mask mandates. So what should we do? I'm here living in Georgia. We're here in Gainesville, Georgia. I'm fully vaccinated and boosted. What should I be doing when it comes to mask wearing?
Yes, thank you for your kind words, Melissa. And yes, again, we're seeing that increase in cases, but most of the cases are staying mild. And I think the one thing we have to emphasize is if someone is very high risk, if they're immunocompromised and they're going to be in a crowd, they should be wearing a mask, especially indoors. And if you're going to be in a large crowd, mask guidance may change again soon, and depending on the community levels. But if we're going to be in a large crowd, our positivity rate now in our community is around 13%. In our health system, it can jump from 13 to 16% in 1 week. If we're going to be in a large crowd, it's still recommended, even if the event does not require it to wear a mask, especially indoors. And for healthcare facilities, we have not relaxed the mask guidance because we follow the CDC and the OSHA guidance. We're still continuing to require masks, but both patients and visitors are required to wear a mask. Yeah.
Right, right. And we should make that point. We are recording this on May 24th. So by the time our wellness summit is live, things may have changed. So this is as of today, May 24th. So speaking of that, I know everyone was very excited as we go to, there were even videos of people on planes celebrating that you no longer had to wear a mask on a plane. So I'm going to be getting on a plane in about 2 weeks. Would you advise that I wear a mask?
Yes, I would advise with where the numbers are going.
I thought you would. I thought you would. I appreciate it as a mother myself, and I know you are as well. And we've got children that span all the ranges of vaccination guidance. I appreciated the graph you shared because, as you said, it's a little hard to keep up with all of the different approvals for the different age ranges. So just again, for my own knowledge and for any of those that are watching that are in the same age or same group as me, I'm just going to go through my children. And you tell me if we're in the right spot. So I have a 15-year-old who turned 15. And she got her original vaccination when it was approved for that age group. She has now been boosted as well when that was approved. So she's up to date on her vaccines, right? For COVID-19. Okay, great. I also have a 9-year-old, soon to be 10-year-old. He received original vaccination when it was approved for that group. And I believe he is now eligible for a booster, correct?
That is true. That just,
he will soon be getting his booster, especially as he gets ready to go to camp. We're always thinking about others that he's going to be around. And then I don't anymore, although it makes me a little sad sometimes to think about, I no longer have a child under the age of 5, but I heard you say that has not yet been approved, but looks like maybe mid-June we could look for approval for under age 5.
Yes, their FDA is meeting, and just from what I have been reading, seems pretty optimistic. I think one of the reasons for the delay is children, they're not just, small adults. Their immune systems work very differently. So we can just, so they really looked into what's the right dose that elicits enough immune response with as minimal or no side effects, especially because we're talking about mRNA vaccines. And we have seen that in young men, especially, there were some reports of the heart inflammation or heart muscle or lining inflammation. While it's a rare event, to minimize that risk, that's why when the approvals came for the 5 to 11-year-olds, the dose was lesser than what was for the older teens. And for those younger than 5 years, that's why titrating the dose, getting it right, all of that, they took their due diligence time to make sure they get it right.
Okay, good. And that, to clarify, will just be from age 6 months up to age 5, right? Younger than 6 months are not included in this trial. So as you talked about, really the only way to protect a baby under age 6 months is for the mother to be vaccinated while she's pregnant, correct?
Absolutely.
And we do, and you shared with us that studies do show that protection passes from the mother to the baby.
Yes.
We see antibodies when they're born. Great. Regarding adults and vaccinations, because the only vaccines approved for children at this point are Pfizer, correct?
Mm-hmm.
What about for adults? We heard some information. You talked a lot about J&J, which was great. But also, what about Pfizer and Moderna? Can we mix and match those vaccines and boosters?
Yes, you can mix and match any of the vaccinations. And especially if someone got J&J as their first dose, it's recommended they go with one of the mRNA vaccines for their next doses.
Is there any
Yeah.
advantage to us mixing and mixing and matching between Pfizer and Moderna, or is there any advantage to that, or just stay on the same path or whatever's available?
They're all very good vaccines in preventing severe disease. I know that people have their favorites. Let me just say this. I know that there have been studies that have shown that the immunity from Moderna is longer lasting. So I have several in the medical circles, in my friends' circles who are not in medicine. Moderna is the vaccine they prefer because of that. But I tell them they're all really good in preventing severe disease. Actually, there are some who actually favor, because Moderna elicits that stronger immune response that stays longer, some of them post-vaccination felt for 2-3 days they felt like they really were down with fever, and so they have actually recommended some to go with Pfizer for the next dose because they had a strong post-vaccination symptoms. So they went with Pfizer. So they're all safe vaccines.
There's just some personal choices there about mixing and matching.
Yeah.
So speaking about the lasting effectiveness, so as I again think about my own personal life and how I'm navigating this. So my husband is 50, a little bit over 50. So a fourth dose or a second booster, I guess, however it's phrased, was recently approved for those over 50.
Yes.
And you may tell me this is wrong. You may tell me he should have gone out right away and gotten it. But as we sometimes think about the flu vaccine that we get year after year, sometimes those of us are trying to gauge the right time to get that flu vaccine as we think about going into flu season and wanting that effectiveness to last through flu season. So as you mentioned, right now in our community, our cases have been low. They're starting to go up a little bit, but were really low when it was first approved. So my advice to him was maybe we should wait a little bit on the booster until we maybe are getting closer to another surge so that we're sure that you've got good effectiveness going into that surge. Good advice or bad advice?
No, if it's approved and qualified, don't delay.
Okay.
If it's 4 months, if it's 4 months past that, the third dose and they qualify, my recommendation has been to just go ahead and get it.
Right.
It is true that we're still learning so much about this, vaccinations, how long the immunity lasts. But also, if we have seen how when these surges happen, either they can happen quickly or it's just, there's no need to delay. Even when it comes to the flu, that's something that comes up every year. While there is that theoretical concern that if we get it early, the immunity may not last till the end of the flu season. The recommendation is to go ahead and get the vaccine as soon as it's available for the flu as well.
Okay. Well, as I mentioned, we're about to get on a plane, so I told him to go ahead and get one as we get ready
good.
to travel.
Very good.
So he will get a second booster. You talked about long haulers. I had a question about that. Does the long hauler, do those symptoms typically appear in those that had severe infection, or do we see long hauler symptoms showing up in those that had mild disease, or maybe even was an asymptomatic case?
Anyone.
Wow.
Any one of them. Actually, one of the patients I had, that was the question we had, because he had some upper respiratory infection March of 2020. He had traveled to New York. We didn't have access to testing at that time readily, so he never got tested. And then he developed this spectrum of symptoms that didn't fit in anywhere. But we could never go back and prove he had the infection, except he had traveled to a state that was having an outbreak.
Wow.
I mean, he was symptomatic, but his symptoms were mild at that time. And actually, if we go theoretically, what we're also seeing is that those who have mild, especially women, most of them tend to have mild infections, mild to moderate, compared to men who tend to have more severe infections. The strong immune response can sometimes lead to the long hauler, that autoimmune immune response continuing for months. So and then with those who develop severe infection, who end up on the ventilator, what we're also seeing is that they may have scarring in their lungs, they may have muscle wasting, they may have long-term sequelae just from their prolonged hospital stay and the medical complications from the severity.
Wow. So that's really I guess, concerning that you could be a long hauler even though you did not have severe infection or may not have even known you had COVID at all. Wow. Again, another reason it's very hard to diagnose, I'm sure.
It's very hard to diagnose. I think if they never knew they had COVID, it's hard to know why suddenly they're having
Right.
some.
Right. So you and I had a very similar conversation for the summit last year. Of course, things were very different and have changed a lot. I do think that there were so many questions last year around vaccination and pregnancy. And it does feel like there's more acceptance now among those who are pregnant. Although having been pregnant myself, and I know you as well, you're always so concerned about what you're doing when you're pregnant and don't want to do anything that might harm your baby. You provided great information about the reasons why pregnant women should get vaccinated and why they are at such high risk themselves for their personal health. Are you also seeing, are we seeing, and it may be too early yet, are we seeing a correlation of those who had COVID and experienced miscarriage?
So we have seen some cases of those who had COVID infection when they're pregnant and experienced miscarriage. At that time, when we discussed with our OBs, they said that those numbers were not increased from what they saw with in those without COVID. So, but then we were clearly seeing a certain they were hesitant to say this is from COVID because these things, the miscarriage can happen without COVID-19 also, infection also. But there have been some studies that have shown that the COVID infection can cause in the placenta, in the villi, it can cause some thrombosis and some changes that can lead to fetal death. So the infection, not just COVID and these women actually had mild COVID. We're not talking about women who were on ventilator, who were admitted because their oxygen was low. They had mild COVID infection that they got better, and then they had a fetal loss. And I think during the last surge, over 2-3 weeks, we had several that experienced that, and we started looking into that more. It's been we always report this to the registry also, so that across the nation it's being monitored. But whether it's been concluded as related to, I feel from a medical standpoint, from what I have observed from discussing with OB colleagues, there is a causal relationship, whether it's been proven or not.
Wow, so more to come on that. I know our time is almost short. Quick question, you talked about latest treatments. So thankful to have so many good treatments available now. Monoclonal antibodies, is that still something people should ask for? I know there's over-the-counter medication. So the most important thing is just contact your doctor right away for treatment.
I think so. Contact the doctor based on their medical conditions and risk factors. They will recommend the best treatment.
And are there treatments even if you have mild symptoms, or do you have to have more severe symptoms for treatment?
No, we don't want to wait until they have severe symptoms.
Want to have that as well. Okay, well, I'm going to throw you a curveball as we end. Just because we've got you're an infectious disease expert, and it's on the national news right now. Do we need to be worried about monkeypox?
We were just talking about that in our infection control circles now. I hope not. I really hope not. I think this virus, it's high time this virus has behaved for some time. But I know that CDC is monitoring the situation. Like with any new virus threat, what we do is, the most important thing is we let our providers know, so we communicate with just to be on the lookout for that in someone presenting with a rash, fever, lymph nodes enlarged, because the last thing we want is something like this that can easily spreading to others.
And the good news with this is we have treatments, correct?
There are some treatments, but again, it's something like I have not seen a case of monkeypox in my career. I hope I won't see one.
Let's hope. Okay. Well, Dr. Manapali, thank you so much. We are so privileged to have your expertise here every day, and I appreciate you sharing it with our audience today, and especially the special focus on women and COVID-19. Thank you so much.
Thank you for the opportunity. Thank you.
Hi, my name is Dr. Tamara Thompson, and I will be presenting along with Shelley Ann Johnson, LCSW, Mental Health 101. Next slide. Part 1 will be fundamentals of mental health, and part 2 will be mental health self-care. Next slide. There is no health without mental health. This statement from the World Health Organization emphasizes how mental health involves everybody. Mental health, the way we think or feel about ourselves and what is going on around us and how we cope with the stresses of life, affects our sense of well-being as well as our physical health. In this sense, everyone has mental health, and good mental health is vital for learning in life. Within the realm of mental health, there are 3 spheres. We have biological, social, and psychological. One is never affected without the other. In our biological sphere, we have physical health, disability, and genetic vulnerabilities. Moving to the social sphere, we have peers, family circumstances, and school. And in the psychological sphere, we have self-esteem, coping skills, and social skills. If you pay close attention, you'll see where there are some overlaps between the 3. Drug effects fall between social and biological. Family relationships and trauma fall between social and psychological. And temperament and IQ fall between biological and psychological. Again, there is no health without mental health. And if we rock the atmosphere in any one of the 3 spheres, it can shake or quake our mental health. Next slide, please. Knowing that we all have mental health, we'll briefly talk about characteristics of good mental health. These are things such as using iMessages, being an active listener, using health skills such as stress management and conflict resolution, being optimistic, and expressing emotions in healthy ways. You're able to meet the demands of life, feel good about yourself, and feel comfortable with other people. Next slide. On the backside of that coin, we can see that we have characteristics of poor mental health, meaning emotions control behaviors, can be very pessimistic, cannot accept change, let stress control life, doesn't share personal feelings or have personal connections, aggressive and passive, closed-minded, and tends to use you messages and blames others and lets situations escalate. Next slide, please. So now that we all know we all have mental health, we don't all have a mental illness. So what is a mental illness and what's the difference between the 2? Mental illness is a pattern of thinking or behaviors that causes a person significant emotional pain or prevents normal functioning. An illness is a disease or period of the sickness affecting the body or the mind. Next slide. There are 4 major causes of mental illness. The first one is inherited traits, which falls in that biological sphere. Environmental exposures before birth, such as exposure to toxins, viruses, alcohol, or drugs. Negative life experiences, also known as trauma, and brain chemistry, hormonal imbalances, such as an imbalance in our serotonin. Next slide, please. There are also a lot of myths about mental illness. People with mental illnesses are dangerous or violent. They can't be trusted around children. They're caused by a personal weakness, or people with a mental illness are poor and or less intelligent. That couldn't be farther from the truth. Mental health problems are very common. About 1 out of every 5 people will experience a mental health issue in any given year. 1 of every 25 has a serious mental health disorder. These include anxiety, major depression, bipolar disorder, and even schizophrenia. Only about 7% of violent acts are committed by a person with symptoms of mental illness. In fact, people with serious mental health issues are 10 times more likely to be a victim of violence. Also know that mental health doesn't stay the same, which is common with a myth that's out there. It goes up and down over the course of our lives. Many factors can influence how we feel, and if any of these factors change, our mental health could change as well. Next slide. We'll take a quick moment and do an exercise called optical illusions. Same picture, different view. I'll give you 5 seconds to look at each slide and tell me what you see first. Slide number 1. Do you see a white columns, or do you see a male, 2 males facing each other? Next slide. Which word do you see first? Do you see good or evil? Next slide. Do you see 2 people facing each other, or do you see a vase? Next slide, please. Mental health is like an optical illusion. Often the outer appearance does not reflect the true person, which results in stigma, bias, and discrimination. And that is why so many individuals do not seek help. Next slide, please. Women's stress and mental health. Women's mental health is an important element in one's overall well-being and contentedness, as it maintains cognitive alternates, emotional sanity, balance of self, lives, and relationships. When one is mentally balanced and at peace with themselves internally, they're practicing very good mental health. Recent studies have shown that women are beginning to report more frequent and more severe symptoms of anxiety and depression. Also, when compared to men, women's symptoms have gotten worse over time. Women are more likely than men to report symptoms of stress, including headaches and upset stomach. Women are also more likely to have mental health conditions that are made worse by stress, again, such as depression or anxiety. We know that stress occurs when an event or stimulus requires us to change in some way. Stress is our brain's way of saying, I know I have to change, but I don't have to like it. Stress involves an imbalance between what is demanded of us and what we are able to cope with or respond to. Next slide. Stress, anxiety, and depression are a triad that many people experience in 2022. Anxiety is a general term for several disorders that cause nervousness, fear, apprehension, and worrying. Someone experiencing anxiety may suffer from panic attacks and fear in high stress events. The last couple of years have been filled with stress due to COVID, economics, civil unrest, and injustices. Next slide, please. Depression is an emotional disorder primarily involving sadness, dependency, and depression. Some signs and symptoms of depression include dejection, hopelessness, inability to feel pleasure or take interest. And when this happens, medical attention is needed. We can't just snap out of depression. Snapping out of depression is just as likely as snapping out of a heart attack. It is impossible to do. Next slide, please. Again, some signs and symptoms of depression include withdrawal from family and friends, drop in grades or work performance, change in eating and sleeping patterns, large weight gain or loss, unresolved grief over a loss, substance use, or difficulty concentrating, remembering, or making decisions, irritable or angry outburst. Next slide, please. But a clinical pearl that you can remember is self-care is essential to the soul. Self-care is care provided for you by you. It's about identifying your own needs and taking steps to meet them. It is taking the time to do some of the activities that nurture you. Self-care is about taking proper care of yourself and treating yourself as kindly as you treat others. Now we'll move on to part 2 of the presentation.
All right, everyone, welcome to part 2 of Mental Health 101. My name is Shelly Ann Johnson. I'm a licensed clinical social worker in private practice here in the state of Georgia. The main focus of my work is in perinatal care and so new and expectant moms and trauma. I also work with mental health facilities dealing with people in the height of their mental health crises. So these circumstances obviously inherently come with stress and anxiety. I don't want you guys to think that stress and anxiety is something that is terrible, right? It's normal. It's normal. We all experience stress. We all experience anxiety. It's our system's way of letting us know, like, hey, something is wrong. It's building some kind of awareness. The issue comes up when it starts to interfere with our everyday functioning, when we can't leave the house because we're so anxious, when we can't speak in a crowd because it's just so stressful for us. And these symptoms also can show up somatically, right? So they can show up physically in our bodies, like headaches, inflammation, and other illnesses. So I'm going to talk to you guys a little bit about some practical things you can do. Times when you start to feel so stressed out and so anxious, you're even having panic attacks to where you can't function. I'm going to give you some tools, some things that I've used successfully in my practice that have been very effective at helping my clients with the symptoms of stress and anxiety. So here we go. People often say, exercise, eat right, you know, this will help your stress and your anxiety, your depression, right? And that's good advice. But sometimes we're so deep in the throes of our mental health issue, whether it's anxiety or stress, that we're so depressed we can't get out of bed to exercise. We don't have the time because our jobs are so stressful, right? So what are some things that you can do that are practical that you can use to manage your daily stress and your daily anxiety? So I'll give you a few examples, and then I'm going to lead you guys actually in a couple of exercises that you can do by yourself. You don't need a therapist or anyone to do these, okay? So here we go. First thing you can do when you are feeling anxious is changing your environment. So you're in your bedroom, you're stressed out about all the things you have to do with work, your mind is going a mile a minute, and you're about to have a full-on panic attack. Go to the living room, change your environment, go outside, get some fresh air, get some vitamin D. Just being in a different environment will break up the monotony of what you're feeling, and it'll break up those symptoms of anxiety and stress. And while we're on the subject of going outside, something that I love to do, something that I encourage all my patients to do is earthing. So simply put, earthing is reconnecting your body, the human body, to the Earth's surface, to the Earth's electrons. We're so disconnected now with our shoes, we're on concrete, so we're not connected to the natural electrons. And we're an electrical system, right? We have energy, and all electrical systems are stabilized and they're grounded by the Earth. And so you just simply going outside, putting your feet in the dirt, putting your feet in some grass actually balances the cortisol in your body. It's been linked to better sleep. It reduces stress. It relieves pain, anxiety, depression, irritability. It can also actually effectively reduce inflammation in the body. So just going outside and putting your feet in some grass is an amazing stress relief, and is very good for you. Tons of studies on earthing, so you guys can check that out on your own time as well. And something that Dr. Thompson actually talked about a little bit is I statements. So another thing you can do is practicing a little bit of self-compassion. Sometimes we're so mean to ourselves when those parts of us come up that are anxious, that are saying, hey, Shelly Ann, I'm nervous. Your body is trying to tell you something. Your mind is doing its job. It's saying, hey, something is wrong here. And we're like, get away from me. I don't want to hear you. You know, you're making me uncomfortable. And anxiety is uncomfortable. But instead, practice a little self-compassion. Say, hey, I hear you. I know you're scared. And give yourself a little bit of love. Sometimes we're the meanest people to ourselves. My rule of thumb is if you wouldn't say it to someone you love, then don't say it to yourself. Because more often than not, you're actually hurting yourself. Let's see, the next thing that we can do, so this is a little bit of self-love, hug yourself. Next thing that we can do is active meditation. So I know that sounds kind of counterintuitive, right? So I'm gonna give you a little example of how this works. So a lot of times when we try to meditate, at least I know this was something for me, it was hard to shut my mind off, to even give myself the 5 minutes I needed to actually meditate. So some of us, when we say meditate, they're like, Shelly Ann, I can't, like my mind is just too active. So with active meditation, it's kind of like a, in between. So the way you do this is you, after work, your day is done, you've decided, okay, I need to relax, but your mind is still going. Go to a place where you can actually have some alone time, some silence, right? And then you can turn on some music, rain sounds, white noise, whatever kind of calms you down. And just put that on, have a pen and paper handy right next to you, and then write down everything that comes to your mind, whether it's work related, whether it's about your private life, your to-do list, whatever is coming to your mind. It doesn't have to be a long dissertation either. You can just make bullet points. And what that does is it clears your mind of it, because your mind really is just trying to help you. It's like, oh, Shelly Ann, don't forget to do this. It doesn't want you to forget. So when you put it on this piece of paper, it's telling yourself, okay, I have it on this paper. It's safe. It's not going anywhere. You're not going to get to that stuff until tomorrow anyways. So this will give yourself permission to kind of relax for the night and tell yourself that, like, hey, it's safe. It's on this paper. I'm not going to forget about it, but right now I need to relax. And believe it or not, guys, it actually works. It's pretty effective at getting your mind to just kind of calm down. So now that we've kind of gotten that out of the way, so changing your environment, earthing, practicing self-compassion, and active meditation, I am now going to lead you in a couple of exercises. These are ones that have been super helpful to my clients and to myself, actually. And they're easy to do. So I picked these because of stuff that you can do on your own at any time. All right, so if you would join me, if you're comfortable with closing your eyes, you can do so. If not, that's totally fine. But the first thing is deep breathing. So when you're stressed out, when you're anxious, what that is just your body is heightened. You're in a heightened sense of alert. So you're almost in fight or flight. For some of us, even if you're having a panic attack, that is what it is. You're in fight or flight. So your nervous system is alerted. So what you need to do is calm it down. And the way you do that is by breathing. And I know it sounds easy, but sometimes we forget to breathe, especially when we're actually having a panic attack or when we're scared. So you just sit with yourself for a moment, and you can do this. You don't have to have a special set time set aside for this. You can do this at any point. Any point you start to feel any type of anxiety or stress. So you just take a deep breath in and you hold it for a count. So you go 1, 2, 3, 4. You breathe in for 4 and breathe out slowly for 5, 2, 3, 4, 5. Again, breathe in for 4, 3, 4. You breathe out slowly for 5. 1, 2, 3, 4, 5. Again, breathe in slowly for 4. 1, 2, 3, 4. And you breathe out slowly for 5. 1, 2, 4, 5. Okay, and what you're doing is you're telling your nervous system, I want you to calm down. And this is biology, guys. It automatically calms you down. So it's nothing special that you have to do. The only thing that you have to do is just remember to breathe. Breath is life. So once you take your deep breaths in, slowly breathe out for a count, and it could be longer than 4, whatever you need. If it's 5, if it's 6, but just make sure when you breathe out slowly, you just do it for one more count. So if you're breathing in for 4, you breathe out for 5, etc. Breathe in for 5, you breathe out for 6. All right. And while you're doing this exercise too, just kind of imagine relaxing parts of your body that seem to be holding tension. So our face carries a lot of tension. So if you're feeling that tension in your face, just, relax your jaw, relax your eyebrows, these places in our body that we don't even think are holding tension, but they are. So that is one, deep breathing, super, super effective. It's very, very powerful. The breath is life. That's where all life begins. All right. So the next thing that I love, love, love to do is energy work. So it's about bringing good energy into your body and letting go of the tension and anxiety and stress that be holding in our bodies. We talked a little bit about somatic experiencing, right? So experiencing things in our body where parts of us are holding things. So whether we're holding sadness, we're holding anxiety, we're holding stress. So this exercise is super effective with actually letting go of these things. And it helps with the somatic experiencing that we get when we hold on to things in our body, because it's energy like anything else. If you're holding it, it doesn't go anywhere, and it will manifest. It will show up in your body in different ways. That's where we get panic attacks and anxiety. All right. So if you guys are with me one more time, we're going to go ahead and close our eyes if you're comfortable to do so. All right. We're going to take a deep breath in and just blow it out and try to relax as best you can. Now, in your mind's eye, we're going to do a little bit of using our imagination here. All right. I want you to envision a bright, beautiful light coming from the sun, whether that light is green, blue, yellow, whatever healing color is manifesting for you. For me, it's always this beautiful yellow light, whatever is comforting to you and comfortable to you. So go ahead and envision this light as we breathe in. So we're breathing in this beautiful healing light from the sun. And just imagine this energy is filling up your head. And we're breathing out any negativity, any doubt, any anxiety. We breathe in again this healing light. And now it's filled our neck and our shoulders are glowing with this healing light. We breathe out any stress, any tension we're holding in our shoulders, any pain, any depression, any sadness. We're breathing in healing energy. And now it's filling up our chest and our back, and our torso is filled with this healing light. We breathe out any doubt, any negativity, any stress, any anxiety. Once again, we breathe in our healing light. It's filled up our arms and our fingertips. Breathing out any stress, any tension that is holding. So calm now. As we breathe in, this healing light is filling up our pelvic area. We hold so much stress there. Just let it go. As you breathe out, you release the tension you're holding there. You release any anxiety, any pain, any doubt. Breathe in once again, healing, beautiful light as it covers your thighs and your knees. And you're breathing out any tension, any anxiety, any stress that you're holding. Breathe in again, healing, beautiful light. Now it's filled up your legs and your feet all the way to your toes. You breathe out any negativity, any doubt, stress, or anxiety. We're going to do this once more as we breathe in this healing light. Now feel our body is glowing. We feel so much lighter because now we have this positive energy inside of us, this healing light. We blow out any remaining negativity, any negative doubts, anything that's persisting in our bodies. And we sit in this healing. We sit in this moment of peace, knowing that we can only control what we can control. Whatever is left, we just have to let it go. Our worry is not going to change it. All we can change is us and how we react. All right, and when you are ready, you can open your eyes. Come back to this beautiful space that we're sharing. And I'm gonna leave actually my contact information here on this last slide. If you guys have any questions, if you need to reach me, if you need any additional resources or tips on stress management, I'll be more than happy to share what I know, because I love giving this information. So thank you so much for having me, guys.
Oh my goodness, I am blown away by the level of presentation that we have so far. So much information, so much insight. I know it's going to have a lot of homework to do. And I think we have a lot of work to do. All right, so we've got some incredible breakout sessions coming. We have some awesome information that is so much more to come in terms of these breakouts. Just so you know, you can get all of these breakouts at GeorgiaWellnessSummit.com. Or you can just go down on the page and stay right there in that. We've got mental health matters for women led by Sheila Carter. And we
in pharmacology, which I think I need the sleep health for sure, led by Emory University's own Kenneth Mueller. And we got a lot more. So just make sure you stay tuned, scroll down, click, do whatever, and get in one of these breakout sessions. All right. The person that I'm bringing to the stage now is quite decorated, and she's so humble with it. She's like, just keep it short. I'm like, I'm reading every single thing on this card. I should probably read more. But Susan P. Coppage is an American attorney and diplomat who has previously served as the United States Ambassador at Large to monitor and combat trafficking in persons, which we know Atlanta is the hub for human trafficking. She was nominated by none other than President Barack Obama and confirmed by the Senate on October 8th, 2015. In this role, she advised the United States Secretary of State and the Undersecretary of State for Civilian Security, Democracy, and Human Rights directly. And she formulates U.S. policy on human trafficking. I mean, the buck literally stops with her. As the head of the Office to Monitor and Combat Trafficking in Persons, she also held the rank of Assistant Secretary. Something tells me she has a little bit of knowledge that we don't, so we should absolutely be paying attention to her. So without further ado, I'd love to bring to the stage Ambassador Susan Coppage.
Thank you so much. Appreciate that introduction. And up on the screen, you'll see that I have retired from that ambassadorial role, but I'm still very active in anti-trafficking issues and matters here in Georgia and throughout the United States. My current role is as Executive Director of Georgia Legal Services, which has a very active domestic violence prevention program and farm worker rights program. I don't know if you've seen a recent case down in South Georgia where many farm workers were victimized by labor trafficking. So we'll talk today about both labor trafficking and sex trafficking. And I'm gonna start where I'm gonna end, which was with the human trafficking hotline, because I'm not gonna make you experts on preventing trafficking or identifying trafficking in the next 30 minutes, but I do hope to give you the tools to spot the issue and then to know what to do to provide trauma-informed care to people that you may encounter in your daily professions. So the Human Trafficking Hotline is up there. If you don't know specialized local law enforcement in your community that's been trained on anti-trafficking work, start with the hotline. The hotline will then refer you to the appropriate individuals throughout Georgia. That's what they're there for. I'm going to grab my clicker so I can start moving through the program. A base definition to start with, so we all know what we're talking about. Trafficking in persons is also called modern-day slavery, and it is the use of force, fraud, or coercion to exploit a person for profit. It does not involve transnational movement, and it doesn't even require interstate movement within the United States to be considered trafficking. Trafficking, when we first hear it, is considered a term of movement, but that is not required for present-day human trafficking. And this is the legal part, one slide on making you all lawyers today. I actually served as a federal prosecutor here in the Northern District of Georgia for 15 years and tried over 49 human traffickers while I was there. And the tools I used were with the federal law, which says it is illegal to recruit, harbor, transport, provide, or obtain someone by these means and for these purposes. So I like that, how I called it the prosecutor's toolbox. All those verbs made it a very broad statute. Harbor means provide shelter, provide housing. So these are tools that I used as a prosecutor that covered most of the actions a trafficker would take. The means required is force, fraud, or coercion, but very important asterisk, that is not required for sex trafficking if the individual is under 18 and is induced into commercial sex acts. The Georgia law mirrors this. The Georgia law also says if you're under 18, no force, fraud, or coercion is required. And fraud is another one of those really expansive terms that I liked a lot when I was a prosecutor. Fraud basically is lying to someone about what job they're going to be doing, what they're going to be paid for it, what the status of a relationship may be. And believe me, every trafficker lies. So fraud is always there for a prosecutor to use. And then the purpose has to be, as I indicated, for commercial sex or for labor or services. So that's your legal lesson for the day. And real quickly, what are the forms of human trafficking? Sex trafficking is what most people think of. A subset of that would be child sex trafficking. There's also forced labor, forced child labor. More internationally, we see bonded labor or domestic servitude. I actually prosecuted a case of domestic servitude here in the U.S. It was a woman from Nigeria who brought over a fellow Nigerian teenager to look after and care for her child. And that woman did not know that she was being trafficked, and she didn't know she had rights as a trafficking victim. So we do have domestic servitude in Georgia. And then another global form of trafficking is the unlawful recruitment and use of child soldiers. So human trafficking does happen worldwide, and you'll see that the bulk of it is labor trafficking globally. What we hear about more in the United States is sex trafficking, and I think it's because it's easier for people to grasp that and be horrified by it. But labor trafficking does occur here as well. And I mentioned that really this is just an issue spotting discussion with the people tuned in today. And I want to thank the Georgia Commission for Women for having me here at this wellness summit so that I can just raise this flag up and make it something that medical professionals will understand and maybe be able to identify in their daily work. Because there was a study in 2014 that said roughly 88% of trafficking survivors report accessing healthcare services during their trafficking situation. And of these, about 68% were seen at an emergency department. So oftentimes, some of the only contact that a survivor or victim at that time will have is with the medical professional. And frequently, a trafficker will not leave an individual alone, even for medical care. And it often takes a while, too, before the trafficker will even provide medical care. I have a case in South Georgia where the young woman was stabbed in the leg by her trafficker when she tried to leave. And she basically got to the point of passing out before he would take her to the emergency room. And then the story was she tripped down the stairs and fell on glass, and he never left her side. So she was not able to talk openly with healthcare professionals. But it's not just the presence of the trafficker, because sometimes when the trafficker's not in the room, that fear, that coercion, those threats they've given still exert control when they're not physically present. And there are also barriers to self-identification. People are afraid to speak out. They may be ashamed. They may feel guilty. They may not understand that in the U.S. healthcare system, you're there to provide help. They may have been told by a trafficker that you may get them deported, that you may get them locked up for things they've done. They may be very frightened. And I'll just pause for a moment and say, too, can you imagine, like, you're going in for some injury and you're just going to volunteer that this horrible thing is happening to you? No, it takes a while, and it takes someone with caring and empathy to identify what's going on. So who listening today might recognize trafficking victims? And it's really anyone in the medical services context. I'm not going to read this list, but it's obvious that all of these individuals are going to potentially encounter trafficking survivors. And I'll mention, too, that the Trafficking in Persons report that I headed, or the Trafficking in Persons office that I headed at the State Department, produces an annual report. And it looks at what is being done to combat trafficking globally. But it also has breakout sections where it talks about trends in preventing and fighting trafficking. And one of the trends that they've started to notice is that traffickers are using substance addiction to control victims, to control the trauma and pain that is felt from being trafficked, and even sometimes recruiting individuals from treatment and rehab centers. So we've had successful prosecutions in the U.S. where traffickers used drugs as a form of coercion and control. So that's just another area that we should be on the lookout for here in Georgia. So what are the indicators of sex trafficking? I mean, I mentioned briefly that trafficker being in the examining room with the victim. So evidence of controlling or a dominating relationship, signs of physical or sexual abuse, lack of control of their own money or finances, signs of drug or alcohol abuse, and inappropriate dress for the weather or the situation sometimes can be an indicator. These are just a few. There are many, many more, but I wanted to pull together some that might come into manifestation while someone's receiving medical treatment and help. So this is another longer list of things to look out for during interactions. And again, I tell people, imagine what it would be like if you wanted to tell someone, but you've never met this person and you're being treated for some sort of medical emergency. How are you going to get to telling them what's really happening to you? And again, that establishing rapport and establishing a relationship of trust can take a really long time that we don't always have in the medical context. But I think that empathy can come through, and if you're aware of what you're looking for, then you can perhaps ask the right questions to help identify someone who may be trafficked. Is the patient reluctant to explain what's going on or have inconsistencies when asked about their injury? Are they kind of not aware of their location, what city they're in, where they are? I frequently have found that traffickers move victims around to keep them discombobulated and establish a sense of where they are and who they might be able to go to for help. Does the patient have someone speaking for them? Do they show signs, as we mentioned, of physical or sexual abuse or untreated STDs? Does the patient exhibit fear, anxiety, depression, submission, tension, nervousness, or avoid eye contact? These are all, again, signs that they may be unable to speak out and not know how to seek that help. We talk about trafficking being an affirmative investigative crime because a lot of times the victims don't come forward. That's why it's hard to track and identify and why it's hard to combat. And so certainly with 88% reporting they go into medical treatment, go seek medical treatment at different places, healthcare workers are one of the frontline responders to this problem. You could also see if the patient is under 18 and if they've been engaging in commercial sex or trading sex for something of value. Again, very sensitive areas, but our medical professionals are frequently asking questions about sexual partners and sexual assaults, and I think that this awareness hopefully will help identify potential victims. I mentioned also that there's human trafficking on the labor side. So where might you encounter that here in Georgia? And this is just not comprehensive, but a list of some areas where trafficking may occur. And we have had this case in South Georgia where migrant farm workers were being trafficked for labor. And they may also show signs of physical abuse or malnutrition or an inability to really speak up on their own. And the organization that I head now is Georgia Legal Services Program. I am their executive director, a month in on the job, so I don't know everything yet, but I am learning about all the excellent work that Georgia Legal Services does. And one of the things they are doing is providing representation for some of these migrant farm workers. The U.S. legal system allows trafficking victims to stay in this country and work while they are seeking justice for the trafficking that happened to them. It's called a T visa, and it is something that Georgia Legal Services is helping these migrant farm workers obtain so they can keep working and assist law enforcement with the case. A lot of times in the migrant farm working situation or other forms of labor trafficking of non-U.S. citizens, the trafficker has said, you're going to be deported, you're going to get in trouble. The Nigerian survivor I mentioned earlier, her trafficker told her, they won't believe you, they'll lock you up, and when you're in jail in the U.S., you don't get a toothbrush. And that toothbrush threat really affected her. She was frightened about her teeth falling out because she didn't have access to oral hygiene while she was going to be locked up. So threats that may seem strange to us, understanding how our system works, can be very effective in controlling of those who aren't born in the U.S. In Georgia specifically, this is where you'll find a lot of immigrants working in these areas. So again, they can come into hospitals and emergency rooms for injuries as well and want to raise the awareness that there are other forms of trafficking beyond sex trafficking. And I mentioned farm workers, they were in South Georgia, and this victimization went on for years. It's a very large case. And for every case we find out about, there are 10 more that we don't know about yet. So we want to be, as healthcare professionals, I submit you want to be open and receptive to receiving these complaints and identifying these potential injuries that may be a form of. So how to respond? Obviously, you know the first thing you need to do is attend to any medical needs and treatment. But once the medical concerns and needs are addressed, try to speak with the patient alone. Try to ask questions that are open-ended, perhaps with a social worker at your hospital or a medical professional. Have you been forced to do work that you didn't want to do? Have you been forced to have sex to pay off a debt? Has anyone held your identity documents? And that can be a phrase that trafficking victims might not be familiar with. So break it down. Someone hold your passport. Does someone hold your driver's license? Why do they hold it? Not having access to your identification documents is a clear indicator of trafficking. Have threats or physical abuse been made to you about leaving your job or to your family? Frequently, foreign-born trafficking victims are controlled by threats made by their trafficker to their family members still back in their country of origin. And those threats may not be able to be carried out by the trafficker, but that's not the point. The point is that the victim believes their family is in danger and so is complying with the demands of the trafficker. Has lied to you about the type of work you were going to be doing. And some of the sex trafficking cases that I prosecuted for foreign-born victims, they were told they were going to be cleaning hotels or working in restaurants or working in nail salons. And of course, none of those things were true. And that goes back to the fraud component of the trafficking statute that allows us to prosecute for these crimes. So these are just a sample of questions that you can ask. And if the answer to all these are no, and you still feel like you have identified a potential trafficking victim, please refer to social services as applicable. If you do get a strong indication that someone is being trafficked, then please, again, call the National Human Trafficking Hotline, 888-3737-888. There's 24/7 access to that hotline and access to over 170 languages. And you can also use local resources depending on where you are in Georgia if you're familiar with specialized law enforcement contacts in the anti-trafficking area. But of course, I'm not here to have you violate any HIPAA or confidentiality restrictions. And the National Human Trafficking Hotline, while it can route you to the appropriate resources in your area, does not fill any mandatory reporting requirements you may have. It can, again, facilitate a report to law enforcement for you, let you know who that right person is. But very important that you abide by other regulations. I'm not overriding those today. I want to talk briefly about the evolution that lawyers and I believe medical professionals have reached with respect to approaching trafficking survivors from a victim-centered approach. Obviously, we talked about meeting any basic healthcare needs they have immediately, what they've come for treatment for. But you also want to reassure the potential victim that you're not going to take any action unless they approve of such action. You want to empower them and give them agency to make decisions. Because think about it, the trafficker has stripped them of all agency, of all ability to control what happens in their life. And giving them back some level of control is very important to building that trust and rapport relationship. Be really conscious of the language you use and refrain from judgment or condemnation. That's a strong term. I don't think anyone listening would do that. But it's really hard sometimes to not judge someone when you yourself feel like if you were in the situation, you would be able to get out of that or leave. But people, as we've talked about, have been broken down by threats to them or their family, by physical abuse, by the promise that they're going to earn some money. And the fact that an individual is earning some money does not mean they are not also being trafficked. The migrant farm workers I referenced were earning a living and had a lawful right to be here under an H-2 visa for doing farm work, and yet they were still being trafficked because they didn't have full control over their conditions, were not being paid what they were entitled to, and were subject to threats of deportation by their employers. So there's a sliding scale of control that traffickers engage in, and we want to be really careful not to express our judgment or put our strong personalities onto someone who's in this situation. By strong personalities, I always say it's really hard for some people who have been very successful in life to understand how someone could sit still for being trafficked. But you really have to approach this from the victim perspective, from a victim-centered approach, so that you see that this is not something that they chose, but something that a trafficker has very skillfully taken away from them. Remain sensitive to those power dynamics. You, as a healthcare provider, asking questions are the person in the position of power to that individual seeking care. So please be mindful that you want to give them, again, as much agency as you can to direct where the conversation goes. And obviously, healthcare professionals are trained to avoid this re-traumatization that can occur. So just raising these flags for individuals who I know can fulfill these suggestions that are really best practices for interacting with trafficking survivors. So I'm gonna wrap up where really we started, which is that what can you as an individual do? And again, keep that figure in mind. 88% of trafficking survivors will encounter members of the medical profession. So please continue to learn about trafficking, including its causes and indicators. Please continue to raise awareness in your community at local events. You can donate to local trafficking organizations. Georgia has a wonderful, fulsome array of anti-trafficking groups. And discuss with your local and state officials how this is important to you and how in your profession you want to be empowered to aid these individuals. You can check your own slavery footprint at slaveryfootprint.org, which shows you how your purchasing habits as a consumer can affect the global human trafficking fight. And again, if you suspect trafficking, you can call local specialized law enforcement, or you can call 911 or the National Human Trafficking Hotline. This has been a really quick and brief survey of what can be done in this area, but I hope that some of you are thinking as you sit here listening to this about individuals you may have encountered in the past who might have been trafficking victims, and what you can do going forward to spot these cases and route them to the appropriate officials. Now, not everyone that you encounter is going to want to report to law enforcement, but you can get them potentially counseling services or treatment services, or refer them to a psychologist or an anti-addiction center, anything to keep that interaction with the medical profession going, to build that rapport, and to establish that relationship of trust to give them the strength that they need to reach out for assistance. So thank you all for listening today. It was an honor to be here. Again, thank you to the Georgia Commission on Women.
Ambassador Coppage, we are so incredibly grateful, appreciative, and thankful about your presentation on child sex trafficking. We thank you for being here.
Thank you.
Your presentation was so insightful, and we now have a better understanding of what we can do to make sure that this issue is eradicated and children are saved.
Thank you.
So we will now introduce our next speakers.
I'm going to step off while you do that. Thank you.
Thank you for being with us. Our next speakers are Amy Boney and Naisha McDowell. Amy Boney serves as the Chief Executive Officer for Children's Advocacy Centers of Georgia. Amy has worked with those affected by child abuse, exploitation, and sexual assault for 28 years. Amy has been deemed an expert witness in 8 judicial circuits in Georgia. She is a member of the Criminal Justice Coordinating Council's State Expert Committee on Child Abuse. And then we also have Ms. Naisha McDowell. She is the director of the Commercial Sexual Exploitation Response Team, also known as the CSEC. It is a program of the Children's Advocacy Centers of Georgia. Naisha leads a multidisciplinary team of professionals who provide assessment and crisis intervention services to children and youth impacted by commercial sexual exploitation. We welcome their presentation this morning on commercial sexual exploitation of children. Absolutely.
Good morning or good afternoon, everyone.
It's on.
All right. So again, just sending greetings to everyone that's on the call this morning that's participating. We're so grateful to participate. I'm here on behalf of the Children's Advocacy Centers of Georgia CSEC Response Team. And today we're going to speak on an issue that some of you may be familiar with. The umbrella issue that we'll be talking about today is commercial sexual exploitation of children, but we're going to get a little bit more specific and speak on family facilitated commercial sexual exploitation. So let's hop right in. So we thank you so much for that beautiful introduction. We, again, are a program of the Children's Advocacy Centers of Georgia, and our organization serves children across the state. We have 52 child advocacy centers throughout the state of Georgia, and our 52 child advocacy centers are leveraged to respond to child sex trafficking in all 159 counties. We are a program that is supported and funded by the Criminal Justice Coordinating Council, and we are also supported by the Governor and First Lady Marty Kemp. Essentially, our organization is tasked with providing services to child and youth victims of commercial sexual exploitation. And so we're certainly grateful to share a little bit more about what we do, which will come a little bit later when Amy Boney, my CEO, speaks. All right, so let's jump right in and talk about the issue of human trafficking. So just defining the overall definition so that we're all on the same page, and then breaking it down into a few different paradigms. So many of you may have heard of commercial sexual exploitation or child sex trafficking, which it's often referred to as, but our organization actually breaks it down into 5 different paradigms. Our friends at Rights for Girls, which is an anti-trafficking organization in Washington, D.C., actually inspired this with their 4 paradigms. The first one is family facilitated exploitation, which we'll be speaking about today. And unfortunately, there are individuals across our country and throughout the world that exploit or traffic their own children. Some additional forms of trafficking that we'll also speak on briefly: gang-facilitated exploitation. And this occurs when a gang exploits a child as a means of initiating that child into the gang, or as a means of revenue for the gang to basically purchase food, shelter, and other resources for that gang. Trafficker or pimp facilitated exploitation we're mostly familiar with due to media and TV shows, and this occurs when a pimp or a trafficker basically targets a vulnerable young person and lures them into child sexual exploitation. Then we have survival sex, and this is a form of exploitation that does not always get as much recognition, and this occurs when a child exchanges any type of sexual act for some of their basic needs, and those basic needs can include food, shelter, it can even include love. And lastly, some of you may be familiar with technology-facilitated exploitation. And this occurs via the internet or social media, and it basically happens where a child is exchanging nude images or videos for some type of financial favor or financial need. And there's not always a trafficker involved in this type of exploitation, but there may be a third party who is profiting from or basically purchasing the images or the videos that the child is putting on the internet. So let's break down family facilitated exploitation a little bit more, since that's what we're here to talk about today. So when we talk about family facilitated exploitation, some of us may confuse this with intrafamilial sexual abuse. And there is a continuum, so sometimes they can co-occur. But with family facilitated CSEC, it's basically where there's a commercial element to that child's exploitation. The family member or someone close to that child may be exchanging sex or sexual acts with that child for some type of financial benefit. With intrafamilial sexual abuse, there may or may not be a commercial element. Oftentimes, if there is a commercial element to that child's sexual abuse, it may be used as a grooming tactic or a way to maintain that child's silence and secrecy. With both of these types of exploitation, however, basically it normalizes unwanted sexual acts, and basically it's an unspoken issue that's happening in many of our communities. And it is a form of abuse. Both are forms of abuse against children that need to be recognized and, of course, reported whenever possible. So you may be wondering, how prevalent is this issue here in the United States, and especially in the state of Georgia? And so according to the United States Department of Justice, 34% of child sexual abuse is inflicted by a family member. So when you think about the sheer fact that child sexual abuse is being inflicted by a family member at this number, we have to also understand that that may also be leading to some child sexual exploitation. In fact, our statistics are consistent with national statistics that 80 to 90% of commercially sexually exploited children have a prior abuse history or a prior sexual abuse history. So when we look at those statistics, we know that across the country, children are also being exploited and trafficked by their family members as well. The 2019 data report from the U.S. National Human Trafficking Hotline actually reported that a familial relationship was the second most common form of an induction into the commercial sex industry. So understanding that oftentimes it's not a stranger or a person outside of the family that's even introducing this child into exploitation. Sometimes it starts off as sexual abuse, sometimes there's a commercial element that leads to this exploitation, and so understanding that the familial unit can also be an entry point for some victims of trafficking as well. And then in 2021, in the state of Georgia, 20 to 25% of confirmed cases of commercial sexual exploitation were family facilitated. And as our organization continues to grow, we may even see some increases in that number, especially as we continue to spread the word around this type of exploitation. It's not always easily recognized, and we'll talk about some reasons as to why it's not always recognized and not always reported. So let's talk about some characteristics of youth that are at risk of family-facilitated exploitation. So a few characteristics we'll start off with are characteristics for youth that are victims of other forms of exploitation. So remember in the beginning, we talked about gang-facilitated exploitation. We talked about the trafficker, pimp-facilitated exploitation, survival sex, and technology exploitation. What we tend to notice, some trends that we tend to notice with these youth are they may be chronic, truant, runaway, homeless, or gang-involved youth. Also, they may be LGBTQ plus youth as well. These children are often involved in foster care or the juvenile justice system, what we refer to as dually involved youth, so they may even have both of these organizations or entities involved with their care. Additionally, they may have a substance dependence disorder or some form of addiction. Their friends or associates may be involved in their commercial sexual exploitation or may be involved in CSEC in general. So friends may be involved and may serve as recruiters. Additionally, they may have individuals in their life who are already involved in some form of sex work or trafficking. And then high numbers of suspected sexual partners are typically characteristic in some of these youth as well. Some additional characteristics to be aware of for our family-facilitated CSEC victims are these victims may be younger. So when we're talking about our other victims of CSEC, maybe gang-involved, survival sex, or technology-facilitated, typically these youth are a little bit older, between the ages of maybe 11 and 17. With our family-facilitated CSEC victims, they're often younger. In fact, some studies have found victims to be as young as 5 years old and even as young as infancy. And so I know these are startling facts to share, but we just want to make sure that anyone that has a family member is aware of this information so that you can better protect yourself and those around you. Family members may be involved in the illegal commercial sex industry, so the child may have parents that are already being exploited in some form or fashion, or they may be involved in sex work complicitly. These youth are also less likely to run away. Some studies have found that the children that are trafficked by relatives were less likely to report running away. Again, we have to think about the age ranges of these children. Oftentimes, they're a lot younger, and so they are completely dependent upon their caregivers. Additionally, they are less likely, it's less likely for these victims to have some type of substance dependence disorder as well. And so again, statistics and studies have shown that due to the age of these youth, they are less likely to report having some form of drug or addiction or substance addiction. Let's look at some additional characteristics here as well. So these children may have some form of child welfare involvement for neglect. And so if child welfare services is a part of this family's life, they may be a part of the family's life due to reasons of neglect. Additionally, they may be more likely to have witnessed domestic violence. So these children have high sort of ACEs or adverse childhood experiences. Any child that has some form of exploitation as a part of their experience may have higher ACEs as well, or adverse childhood experiences. They may frequently move or relocate. So this is another sign to be on the lookout for, especially for our direct service professionals. These children their families may frequently move across state lines or county lines to evade law enforcement or child welfare services. They're also less likely to be identified as CSEC victims by child welfare. Again, due to the nature of their exploitation, it is sort of conducted within the confines of the family. The child may not even be aware of what's happening to them, so it may make it less likely for them to disclose or report. One study found that half of the victims of family-facilitated CSEC were poly victims, meaning they had multiple abuse types. That could include they were victims of child sexual abuse, of neglect, of physical abuse. So also understanding that it typically, family-facilitated CSEC that is, it typically does not occur in a silo or by itself. There may be some other abuse types that are occurring alongside it. So let's talk about what the perpetrators look like so that we can also understand sort of their motives and some of the characteristics they may present. So typically, and this is a very unfortunate statistic, but typically the trafficker that is involved in the trafficking of a young person, especially in family facilitated CSEC, is the mother. And so one study found that the child's mother was the trafficker in approximately 64 cases. In Georgia, the child's mother was involved in the trafficking in approximately 25% of those cases. And so the statistics vary across the country, but typically the mother is the person involved in that child's exploitation. In cases where the mother was the trafficker, a second trafficker was involved in approximately 65% of the cases. And so maybe a paramour, a boyfriend, a partner, someone else that that mother is sort of connected with on an intimate level. In Georgia, an individual associated with the mother was the trafficker in approximately 30+% of those cases. And so there are a few different ways that the mother can present, her characteristics can present. One is being that the mother can be, of course, the trafficker, meaning she is the person who is exploiting the child for some type of financial benefit or personal benefit. Another presentation that the mother can have is mother as sort of the model or the groomer or the person introducing the child into that exploitation. And so this occurs often where maybe the mother is involved in sex work herself, and now she's sort of modeling this behavior for her child and grooming her and or him or preparing that child for some form of exploitation themselves. And then lastly, of course, we have that the mother could be just the drug addict or the person who's trying to seek some form of benefit, whether it be through her drug addiction, to involve the child in exploitation. So basically, the mother is exchanging sex with her child for some type of drug addiction use or benefit. So we like to provide some survivor testimony to really drive home the idea that this is happening, and it is happening in real time in many of our communities. And so this is a sort of blurb pulled from a youth who was participating in a study, and she basically shared, she, referring to her mother, was the one that introduced me to the life when I was 13. She had a drug dealer that lived right next door. He was my mom's drug dealer. My mom, just in other words, sold me to him for drugs. So he was a pimp. My mom knew everything that was going on, but didn't do anything about it. And so again, as you can see here, there are a few different things going on, a few different trends. One, the mother is sort of grooming the child, preparing her for this exploitation. And then two, mom is using her child as a way of meeting her drug addiction needs. Some additional perpetrator characteristics that we have here include the father as the trafficker. So this also occurs. One study found that a child's father was the trafficker in approximately 32% of cases. In the state of Georgia, the father was the trafficker in approximately 13 to 15% of cases. And cases that involve the father as the trafficker may involve the following sort of mentions or just concerns. So the child or the father may be grooming the child to prepare them to have sex with their friends. So we see that a lot, especially with child sexual abuse materials as well, or what we refer to as child pornography. And also, again, the father may be exchanging sex with the child or sexual acts with other traffickers. And then lastly, they may be selling or exchanging child sexual abuse materials or child pornography with other individuals. But of course, that's still a form of commercial sexual exploitation. And then other family members may, of course, be involved in that child's exploitation as well. It can be cousins, a grandparent, an aunt, or an uncle, or even distant relatives. So how are these traffickers and perpetrators basically trafficking these youth? What are some of the methods? And so children that are exploited by their family members may be exploited within the home or outside of the home. Traffickers don't typically have one method. We tend to notice that the child is typically in the home, which is why it's a little bit harder to recognize. However, it can occur in someone else's home. It can occur at a business. It really doesn't matter. So some of the methods, they may sell sex and sexual acts with the child within the family home. They may force the child to engage in street exploitation where they are out on the streets or around different businesses. They may transport the child to different businesses as well to be exploited. They may transport the child even to parties. We've seen it where different family members come together, they bring their children, the other family brings their children, and they sort of exchange sexual acts with those children. And then creating and proliferating child sexual abuse materials is another way that family-facilitated CSEC perpetrators also facilitate that exploitation. So consider this. When the family member is the trafficker, the exploitation is often normalized and accepted within the family culture, sometimes spanning generations. And so my CEO is going to come and speak to you all a little bit later. She has years of experience working within child advocacy centers and can attest to the fact that this often happens within generational sort of family structures. All right, so let's talk about the impact of exploitation, and I'm going to invite my CEO, Amy Boney, to talk a little bit about that. Absolutely.
Great, thank you. No worries at all. All right, thank you so much. So we're going to talk about the impact. How does family-facilitated CSEC impact our youth? So, well, still not getting to my slides. So that's okay. We'll move forward. When we're looking at our response in general with children's advocacy centers, we have 159 children's advocacy centers, or 159 counties that children's advocacy centers serve. 52 centers in total, well over 100 multidisciplinary team case reviews that we do throughout the state, and that brings together the disciplines from across the state that know exactly how to handle not only child sexual exploitation, but physical abuse, sexual abuse, the neglect of children. And honestly, those factors, the physical abuse, the sexual abuse, and the neglect of children are precursors to CSEC. So Children's Advocacy Centers for well over 2 decades has been able to assist in local communities across 159 counties, assist those families to avoid the further abuse of their children through commercial sexual exploitation of children. One of the reasons that children are so well kept in children's advocacy centers and the hope and the healing that we all want each of our children in this state to encounter is through CACs, because we have a one-stop shop with children's advocacy centers. Historically, children would do things such as this. They would tell a school counselor something had happened at home. That counselor would then make a report to the Department of Family and Children's Services, or that counselor would make a report to law enforcement. And then those investigators at separate times would come out and speak with the child, whether it was at the school or possibly even in their own home where a lot of the perpetration has occurred. Then that child would have to speak to attorneys separately, medical professionals separately. They would have to speak with additional counselors, investigators through the DA's office, hospitals, doctors, and nurses. By the time a child completes all of those interviews, you're looking at approximately 10 to 15 interviews that they've encountered with 10 to 15 different professionals. At one point in time, we began to realize that children's statements were changing. And when the children's statements were changing, it was not due to the inconsistency of the child's statements as if nothing had happened. It was due to the fact that they had spoken to 10 to 15 different professionals. Each of them had their own MOs regarding their investigations that they needed to complete, and it was not done in a victim-centered and trauma-informed response. And children's advocacy centers were able to bring that response to the table So now all of those investigations happen beginning at the CAC. Joint investigations are completed, and the joint investigations ensure that children are no longer being siloed into each agency. They are able to have a victim-centered and trauma-informed forensic interview. Once that interview is completed, the investigations are then launched, and all of those different agencies that I just discussed are now coming together. They come together to do a joint investigation to ensure that these children, our children, are not being overly interviewed in non-victim centered arenas. It has become a beautiful process, and over 20 years, the multidisciplinary teams of Georgia have come together and have truly made it work. It was really a no-brainer. It was really a no-brainer when we were applying for this, the grants that enable us to have funding to do our services. We are now the hub of not only physical abuse and sexual abuse, interviews and interventions and mental health modalities. We are the only state in the nation that has a fully fledged CSEC response for children that incorporates children's advocacy centers. We are very proud of that. We are very proud of our CACs as well as our CSEC response team that makes these very highly coordinated, well-staffed assessments move forward. And if anyone has any questions in the chat, we are more than happy to answer. Thank you so much for the Commission of Women who allowed us the time today to speak. Thank you so much.
Hi again. I'm hoping you guys aren't getting sick of me. I'm just being kind of intertwined in all of these amazing speakers, so you don't have to deal with me too much. But I am very excited to introduce a bill. I feel kind of important now. I don't think I've ever introduced the passing of a bill before. But this is House Bill 1013, HB 1013. Oh, I forgot to put my mic on. I thought it was on already. Sorry, guys, 1 second. Thank you. Introduction of House Bill 1013, Mental Health Parity. This year, a momentous health bill was passed. Huge, especially since we're in such a space of focusing so much on mental health. So this is a huge accomplishment for everybody involved. The Mental Health Parity Act will help Georgians specifically access affordable mental health and substance use disorder treatment for themselves and their children. And this is huge because we have never seen any kind of specific focus like this, specifically in the mental health space. It ensures that public and private health insurance plans will cover behavioral health equitably with physical health. Behavioral health and physical health. We focus so much on the outside, but if the inside isn't right, the outside does not matter at all, and I know you guys know that. So this next presentation is gonna discuss the work that went in to this bill and getting it passed, and how this now will help affect all Georgians equitably.
Well, we are here today to have an in-depth discussion on mental health in Georgia. And we are pleased to be coming before the Georgia Commission on Women and appreciate very much their interest in this topic. It's certainly a focus at the legislature, and that's kind of what we're going to get into. And my name is Linda Hamrick, and I am the lobbyist for NAMI Georgia. And I've been a lobbyist at the Capitol, not quite as long as Mary Margaret Oliver, one of our panelists, but close, not too far after her did I start lobbying. But I want to introduce our panel to you. And you heard just now that Mary Margaret Oliver is one of the panelists. Mary Margaret has been at the Capitol since 1987, Mary Margaret, I believe it is. She was elected to the Senate, then took a little hiatus and came back in 2003 as a representative in the House and has been with us and very influential. And she was extremely important this last session when we passed the Georgia Mental Health Parity Act. Secondly, Kim Jones is with us as the other panelist. Kim is the executive director of NAMI, the National Alliance on Mental Illness for Georgia. And she's also the mother of a child with mental health issues. And she serves along with Mary Margaret on the Georgia Mental Health Reform and Innovation Commission, which is the genesis of the language that came into being as the Georgia Parity Act. So with that, let's just get right into the discussion. And I am going to ask Mary Margaret the first question. Mary Margaret, obviously this has become the year of mental health in Georgia. And as such, there were a plethora of bills, mental health bills that actually passed the legislature this year. And I know in my years down there, I've never seen such a focus on mental health, a welcome focus and a serious dive into mental health. A lot of bills passed on mental health, including the Georgia Mental Health Parity Act, which was the very comprehensive mental health bill that we're here to really dig into today. I think the main thing that this act did, the Mental Health Parity Act did, was to, for the first time in Georgia's history, it enforced parity with mental health as it is serving physical health, surgeries and regular physical health. So that was a main consideration for us, and we were able to do that. I'd like to know from you, Mary Margaret, what was the difference this year from past years in the legislature? And why do you think that there was such a strong push, starting with the Speaker of the House authoring the bill and putting his shoulder to the wheel on it? What do you think was the difference this year, and why did we tackle mental health to the degree we did this year?
I think it begins with and ends with Speaker David Ralston. But there's some history before and during the session that's relevant to his leadership that I think people would appreciate. I think every member of the General Assembly that has any awareness on any level of what's going on in his or her district knows that mental health services, the lack of mental health services, is at a crisis state in Georgia. A little over 2 years ago, Representative Kevin Tanner, then Representative Kevin Tanner, convinced the Speaker to appoint a behavioral health commission on reform and innovation. And Kevin Tanner has been significant engine behind this movement that came to very strong product of passage without any dissenting votes, House Bill 1013 in the 2022 session. Kevin Tanner, a year ago, about 6 months after the commission made significant recommendations, and in 2021, we did pass 2 bills of the recommendation of the Behavioral Health Commission, a telehealth bill and a second bill that expanded the authority of marriage and family counselors, but there was left on the table many other recommendations of the commission. And Kevin Tanner, a relationship with David Ralston, convinced David Ralston to allow this commission and the continued leadership of Kevin Tanner to go forward. Beginning in May 2021 and through today, May 2022, I have been working on this bill in a very significant way. Kevin Tanner's use of his work group came forward with a draft of a bill in the last 6 months of 2021. And with Kevin Tanner and other members of his work group, including both you, Linda, and Kim, we began visits with agency heads all across Georgia and with legislators to begin to vet a bill, a draft of which we had probably by the fall. So there was an extensive amount of history of advocacy in the commission, within the commission, and outward from the commission beginning in 2021 that built a strong set of folks, particularly again, David Ralston, who believed it was time to make a commitment. The 1013 bill came into a very public discussion in the last part, almost a public discussion in the last part of 2021 in December and January. And then it was introduced with David Ralston being the #1 signer, which is very important, in January 2022. And then we began the work of the 2022 session, which was at work every single day, as the three of us know.
Yes, how we know that. Kim, I want to ask you a question, but before I ask you, I'd like for the audience to kind of recognize that as NAMI's executive director and as a member of the Behavioral Health Commission, you served as the spokesperson for all the advocates and all the advocate organizations in the state of Georgia. And I learned very quickly that advocates felt as though they were not really listened to that often, or their issues were not taken to heart. There were things that were not done that needed to be done, and they just didn't feel like they were being listened to. And this year that changed. I would like you to tell us, from your perspective, what was it like as the head of NAMI to be in the middle of this effort and during this session as an advocate and as really the leader of the spokesperson for all the advocates at the Capitol? What was different for you, and how was that experience for you?
Sure. Well, thank you, Linda, and thank you to the Georgia Commission on Women for having this summit today. Every spotlight that we put on mental health helps raise awareness, and so I can always have to start with a big old thank you. Goodness, Linda, it was incredible. As a mother of a child with a mental health condition who really could understand at age 9 when his mental health condition showed up, and he was also having reading difficulties, I knew that the number of beds determined in our system for the jail and our prisons is based on those two things, mental health and reading capacity by 3rd grade. And so I put 2 and 2 together and realized real quickly that here in the state of Georgia, being 51st in access to mental health care, that my son was doomed to fail. And there were several other sons, daughters that were already going through the process. So for me to see what happened this session was just incredible. It was overwhelming to see the bipartisan, bicameral support on both the House and the Senate side, something that is historic to a bill that's over 70 pages long to see happen. And I was so honored to be in the trenches with you, Linda, and with Mary Margaret Oliver and several other of our advocates to carry this bill through and make sure that it happened. And as Mary Margaret mentioned, you know, we started early as advocates, and we can talk about this a little bit later about what we did different this year as advocates. But I think, speaking to what Mary Margaret said, there is no one, mental health touches 1 out of 4 of us, and that includes our legislators. And so part of the secret sauce for us was finding out what legislators were touched and getting their constituents in front of them and advocating and making these stories real and heartfelt. Because once you hear what's happening to people, I mean, anybody would want to change that.
Yes. So, Mary Margaret, now we get down into the heart, the bowels of this bill. And so the question goes to you as our deep diver, especially. What do you say? What do you think? What do you see this bill does? How is it going to make an important difference this year in the state of Georgia? And could you go over a few of the major provisions that you see to highlight for the ladies that are attending this meeting so that they can understand a little bit about what the process was, what are the planks and the provisions, and so they can celebrate with us the passage of this bill?
1013 is a comprehensive bill that addresses many different aspects of our failing mental health system across Georgia. And it's the depth and the breadth of the bill that gives me a lot of hope that change is on the way. It's also true that the Commission on Behavioral Health, chaired by Kevin Tanner and supported by Speaker Ralston, we're meeting this month. We are beginning implementation strategies for the bill and beginning a long new set of tasks to make sure that our work is not put on a shelf somewhere. Section 1 of the bill creates the opportunity in the Insurance Commissioner of Georgia, following up on a federal act that was brought forward in the end of 2020 under the Trump administration, to make enforcement of parity, which has been a theoretical right of patients since it was passed by a federal Bush administration in 2008, a reality. There's specific tasks about obtaining data, about doing reviews of insurance policies, and the review particularly of a new consumer complaint process. All of those aspects are in the weeds of ways that enforcement of parity will become a reality. We also are going to enforce the federal law, which already exists, and I don't believe Georgia's in compliance with, that 85% of the premiums that go to managed care organizations, those treating foster care children and Medicaid children, that those premiums, 85% of them, be spent directly on services. That's called the medical loss ratio provision that we are enforcing in 1013. We know that workforce is a huge issue facing every professional, but is perhaps more crisis in rural Georgia and underserved areas of mental health professionals. We're creating a loan forgiveness program for psychiatrists and additional new mental health therapists in different categories of their licensure of $10 million, in excess of $10 million, to create incentives for mental health professionals to go to underserved areas. And for the first time, we are mandating that they take Medicaid. If they're going to take a loan forgiveness benefit and they're going to go to an underserved area, we have to make sure that they are collecting and participating in Medicaid. We find that we don't have sufficient data of health professionals in all the varieties of ways they serve the mentally ill population, and we're creating some new data resources in relation to that. We've had a good discussion and good progress on creating structure and funding for what we're calling co-responder programs. The law enforcement community was a very strong part of 1013 from the beginning. Law enforcement now is the first entity that responds on 911 calls that are in reality mental health crisis calls. And the co-responder program is where law enforcement partners with on actual 911 screening and 911 visits out in the community on mental health crisis. There's somewhere between 15 and 20 programs already operating in Georgia on this model of combining mental health professionals with law enforcement. And we are structuring that in a more positive way and providing funding for it, which includes a lot of attention to the transportation services. We have struggled with, and we are implementing in 1013, a new mechanism for mandatory outpatient treatment. The AOT program, outpatient treatment program, is going to be funded and set up in 5 different jurisdictions so that people coming out of crisis, out of jail or out of crisis psychiatric evaluations, will have additional oversight and additional services. We're creating a new match program. We're really reviving a match program for children in residential serious mental health services, to make sure that those agencies that have different ways of touching children, foster care children or Medicaid children, that we can provide them with a more seamless and actual placement opportunities prevent the reality that many of the children that Georgia is responsible for in the foster care system are in hotels every night for a lack of services. We are expanding the jurisdiction of the Behavioral Health Commission in a variety of ways in order to assist in the implementation of the AOT program, assist in the implementation of the MATCH program, assist in relation to a variety of discussions going on about difficult homeless populations and mental illness. Those are the main highlights of 1013. As you can see, I could go on, there's a lot more. I could go on, but as you can see, it's a very comprehensive bill with a lot of deadlines and a lot of future tasks that the commission will be following up on.
Yes, and with that, let me ask Kim, after hearing Mary Margaret go through, touch the top notes of all the different provisions that were dealt with in the bill. Tell us how the bill is going to affect the people that you serve, and what provisions of the bill do you think will have the biggest impact? And then to both of you, I'd like to ask both of you to kind of discuss for a minute what you think the importance of the makeup of the Behavioral Health Commission has meant. And by that, I mean, we had a lot of different types of people, a lot of different branches of the communities. And I think that had a big impact on the type of bill that came forth and the expert way in which the bill was crafted. So first, Kim, can you tell us a little bit about how it's going to impact the people you serve, and then speak to the makeup of the commission also?
Absolutely, Linda. I think, well, parity is the cornerstone of the bill. And what parity means is treating mental health at the same way that you treat physical health. And that is so important, not only just because of the act of having insurance companies do that, making sure that they are treating physical health and mental health equally, but it is the paradigm shift of how we think about mental health. And that is the real icing on the cake that I think a lot of people don't realize the shift that was in how we perceive and think about mental health, how it raises awareness, and that we no longer see it as somebody just not handling their behavior well. They may have a chemical imbalance in their brain, which is a physical part of your health. And so I think the parity portion overall, by far, for many, many reasons, was the cornerstone in helping us think differently about mental health, because we can't change a system unless we think differently about it and see it in a different light to make the right corrections to make it better. The other provisions that I think were really important were the law enforcement provisions that allowed a law officer, instead of arresting somebody who is experiencing a mental health problem and to be able to transport them, that a officer can now, if somebody is in a mental health crisis, they can reach out to a physician either by phone or telehealth and get somebody to help evaluate that person and take them to care, just like we do for physical health. We would never take somebody who's having a heart attack or diabetic insulin crisis to the hospital. To jail. But we do that all the time with mental health. Our jail systems have become our new institutions, for a lack of a better word, and we call that decriminalizing mental health. So that's another really, really important factor to the bill. I think the workforce and demographics and looking at where people are so we can find where we are lacking in equity for our workforce. There are very few brown or Black providers in our areas, and we need to make sure that we know where those shortages are and where our gaps are so that we can fill those, and we need the data to do that. So requiring our licensed providers to provide that data is a first step in trying to figure out how to fix our workforce issue. And then, of course, what we did for our children, we couldn't have done enough. Our children are in crisis right now with mental health. That match program will help people who are trying to get through the system, whether it's through foster care or if you have a child in crisis and you're on Medicaid. The match program will allow you to have access to several different agencies who can all sit down together and focus on your child and use their resources to get your child help. So that is incredibly important as well. And to your next question, I think all of the things I just talked about came about because of the diversity on the Behavioral Health Reform and Innovation Commission. I think the commission was put together in a way that it represented every aspect of our system. It represented advocates, it represented providers, psychiatrists, law enforcement, which unfortunately are the people right now who are having to interact with the people with mental health, and they should not be. That should be medical care, but unfortunately they are. So I think the diverse scope of people and experts that we had around the table for the Behavioral Health Reform Innovation Commission, from rural Georgia to Atlanta, helped make this what it needed to be to really move the needle for mental health here in Georgia.
Mary Margaret, would you speak to that also, working with the diverse group of people with different world views on all the different implications that mental health brings to Georgia? What was that like?
Kevin Tanner said in the beginning of the early meetings with the commission that he wanted the appointees by the lieutenant governor, the governor, and the House to be experts, people with expertise. And I think what was very unique about this set of discussions was that it was very expert driven, which is, I was the only politician in most of the rooms that I was in most of the times. And I think that gave it a healthier kind of discussion that was more reality based for people who are actually in the field. So the experts stayed with the project. That's the other thing too. They contributed, but people like Dr. Brenda Fitzgerald, she was chairman of a subcommittee on access with a, as we know, a exemplary, long professional, high-level career, but she was always willing to come to the Capitol, always willing to participate. We had some very strong commission members. Gary McGibbity from the Department of Education, always available to come, always available to participate. We had a real commitment, a real workforce to this effort. And as we began to see, I'm talking as a commission member, as we all began to see the commitment that David Ralston was making and the success of the way in which the bill was proceeding, we had 10 hearings. And almost every one of those 10 hearings was standing room only. And standing room only 10 hearings means that people are paying attention. And each time we had a vote in the hearing, each time we were getting very, very strong votes. We also were we adopted somewhere between 50 and 100 amendments to the bill through those 10 hearings. That represented a huge amount of participation, a huge amount of engagement. If Todd Jones and I were what Speaker Ralston called his co-pilots, we were the two legislators that kind of managed this bill through these 10 hearings. And every time somebody had a conversation with either of us in public or in private, and their language was then put into the bill, it created buy-ins. It created buy-ins of people who knew that we were listening and knew that we were improving the product every single day. The product being a very strong legislative bill.
Yes, I think I was very impressed with the commitment of time that Dr. Fitzgerald, Gary McGibbity, and we had three judges, including soon to be Chief Justice of the Supreme Court, that came to the Capitol to work on this bill. What we saw, I think, firsthand was the passion, the interest, and the commitment of everybody to fix this problem. So
and one of the things that came out of all that energy was, if they didn't know it before, they knew it this process. Average member of the General Assembly, average House and Senator has been increasingly highlighting contacts from constituents who are telling them chapter and verse about the problems of obtaining service for their loved one. Every single member of the General Assembly's perspective on the need for crisis mental health services was increased, and that led to a vote that had no votes.
And to that point, I think it was something that I had never experienced as a lobbyist, but at I think it was the last hearing in the Senate, which was coming to the close of the session and winding down to the final vote for this bill. Kim actually brought to the committee, as she spoke to it, pictures of family members or friends or somebody in their districts and the legislative districts of the people that she was speaking in front of. And in that room in the last few weeks or up until just a day or two before, each one of those legislators had a crisis that ended up usually with losing life in their district. It was very, very powerful and emotional. And those are the stories that were told that made everybody rally around that bill and give it that no vote. No, we had absolutely not one no vote, which is unheard of in a bill like this. So let's kind of pivot now to what's next. How do you see, or what do you think, Mary Margaret, let's go with you first, is the role of the Georgia Behavioral Reform and Innovation Committees? What is their role in keeping this momentum going? I like to say it almost with that powerful vote and that full support from the governor to the lieutenant governor to the speaker, and then every member of the Georgia General Assembly voting in favor of this bill. I kind of call it a rocket booster. We have a real strong boost going into the off session that we're in now and into next session. What do you see as the commission's role in keeping this momentum going, and what do you see the next steps are for the commission to consider taking? And then on Kim, after that, would you answer the same question, please?
Kevin Tanner and I've been talking since the session ended April 4th, and we have a meeting next week of leadership of the subcommittees and other team members to kind of chart out our first commission meeting post passage of 1013. And I believe that commission meeting has been set for June 9th, which will be available online for everybody on streaming, I'm sure, because our commission meetings have been streamed. We are outlining a very aggressive agenda. The bill, and one of the things that first of all we've prepared for each other to look at, what are all the timetables and deadlines that require X and Y and Z to happen? For instance, the bill includes a requirement that a prescription formulary be established. It had been set out in 3 different parts of the statute. Let's prepare a prescription formulary, meaning that consistent insurance coverage be required for certain psychiatric drugs. And in the bill in 1013, we place that obligation in one entity, the governor's Health Innovation Reform Commission, chaired by Grant Thomas. And in my conversations with Grant Thomas, I told him clearly, we're going to give this responsibility to you, Grant, and we have a deadline of January 1st, 2023. So we'll be checking back with you. That's just one example of things we put in the bill that we will be checking on. The new duties to expand the commission's authority to help more about the coordination of independent entities like the Match Committee and like the AOT. These will be assigned specific duties as defined as new duties under the bill. So there's a lot we're planning on doing. I've worked on this almost every day, but certainly every hour of every day during the session. And I'm really pleased to see that this work continues.
Kim?
Well, gosh, what are we going to do to keep the momentum going? Well, first of all, we are going around the state, myself and 2 other advocates, Mental Health America and Georgia Council on Substance Abuse, doing what we call thank you tours. Our legislators worked really hard for us for mental health, and we need to say thank you to keep them motivated and to keep them going. So that is definitely something that we are working on, making sure that we're going to our legislators' communities and educating them on the great work that their legislator did, and to let their constituents know what is in this bill as well. You know, there's a lot of great things that can be in this bill, but we got to let the people that use the services know what has changed so that they can help keep the implementation and keep accountability going. So those are the things. Also, Kevin's not yet, Chairman Tanner is not here to say this, so I don't want to take it from him, but he has coined this next year, or this next theme is the decade for mental health. So I think getting us all ready for this next session, really participating in these Behavioral Health Reform and Innovation Committee subcommittees and bringing our great ideas forward is what's going to keep the momentum coming and keep people engaged, and making sure that we do even better for mental health next year.
Any thoughts that either of you have for the Georgia Commission on Women? How can they be involved? How can they help us? Obviously, these are women that are influential in the state of Georgia. As a matter of fact, I'll just add right here that I was appointed to the freshman class in 1992. That seems like a long time ago. So I served on the commission, and I have to say that as the mother of a child that has suffered with serious depression, I am proud and honored that this step, when I come before my commission as a alumnus, I am proud that it's on this topic. So I know that many of us, many of the women on the commission know someone, have somebody that they love that suffers. What is it, Mary Margaret, that they can do to be involved or advocate, use their voice? Do you have any counsel, advice for them?
Well, I agree that there's some very powerful, influential women on that commission. And I thank you for your long service. I think that the more we discuss these individual cases that we're seeing in the news every day, and we discuss the opportunities to improve a system that we're not happy with, we have this is a daily news story of somebody's conflict with somebody else, frequently involving law enforcement, results in death, where the issues of the conflict are rooted in some way or another in substance abuse or mental illness. That's a discussion we need to continue to have in very specific ways across Georgia.
Kim?
Yeah, well, this is where we pull out our advocate hats and we get really busy. You know, first of all, I would ask all the commission members to please thank their current legislators. Just a quick email. It doesn't have to be anything, a tweet, something on their social media page that just says, thank you for supporting mental health. Let them know that we are grateful and appreciative of that. You know, all legislators want to answer to their constituents. So making sure that they know that their constituents appreciate mental health. The other thing that I would ask personally is, you know, every year is sometimes we look at the work that we do at the Capitol as a battle. And so every year we go into battle and we need support. And what we do as NAMI is we will send out advocates alert asking for our constituents to please, or asking the legislators' constituents to please contact their legislator to either vote yes or no or understand what's happening. And so that is really, really important, especially when we're down at the Capitol in the trenches and something isn't going the way that we need it to go, to have you call your legislator, forward on an email. And it can be as simple as sharing this presentation that we're doing right here and just saying, this was a great presentation, please take the time to watch it. It can be a like on something your legislator talks about. It doesn't have to be something big. Those little things, sharing, posting, tweeting, that mental health is important to you makes all the difference in the world.
Kim, I'm going to interrupt you because I always make this point when I'm doing advocacy training. most legislators hear from real voting constituents very seldomly. I think you'd be shocked. Some of the communication to me is from lobbyists. I'm spending hours with you today. Both of you I worked with a lot and really enjoy the working relationship and depend on the working relationship of lobbyists like you, but you don't vote for me. I know, and I tell people all the time, if you spend 45 minutes a year communicating with your House member or your senator, he or she's going to know who you are. If you write them an email today that says, I am your constituent and I live on X street and vote at Y precinct, because half the people that tell me they're my constituent are not my constituent. They think they are, but they aren't. So if you start your note with, I'm your constituent, I live on such street and I vote at such precinct, and I want to thank you for the mental health bill, that's going to take you 15 minutes. Thank you. That takes 15 minutes. And then after the session, another 15 minutes, I'm your constituent, I live on so-and-so, I vote so-and-so, and I really appreciate your help on blah, blah. Or, I'm sorry you couldn't be with me on blah, blah, but I hope we'll work together in the future. That's 45 minutes a year. And he or she is going to know exactly who you are, because that kind of attentiveness to a specific issue by a real voter is very, very rare.
Absolutely, I agree. And we tell our members, you know, even if you just make a Zoom video like this and just say it was important to me and mail it, that whatever is comfortable for you, just do it. And I loved what you shared, Representative Oliver.
So let's just wrap it up with final closing thoughts, comments. Kim, you want to start?
Yeah, I just am excited to be here. And again, thank you to the commission for sharing the information on this bill and about mental health. Again, every opportunity we take to do that. I'd also just like to ask everybody to be intentional about their own mental health. We're not going to change the way Georgia does mental health until we also value it like we do physical health. A lot of us make time to go exercise every day. We'll take time to take care of your own mental health as well. And then finally, I would just like to thank Representative Oliver here for this, and Linda for all your great work. We couldn't have done it without you, and just the commission again for having us. So thank you very much.
Mary Margaret.
Thank you. I'm excited about the work that's before us this year. I think that this is an election year where all the nation is looking at Georgia one more time, and all of us have an opportunity to participate in this important election year. And working on real issues that have real meaning to actual people is really the joy of politics. So I'm excited and I look forward to new successes.
And as a former commissioner on the Georgia Commission on Women, let me just assure you that the two ladies that I've been honored to work with over the last year were the engine. These two ladies literally worked day and night. We hardly slept. We became closer than sisters, and we would go into any trench together. I can tell you that it was nonpartisan. It just doesn't matter when you're talking about those you love with mental health and seeing the suffering that goes on, all the walls come down. So let me just say to the commission, it's a joy to be here. It's a good joy to bring this message of hope, because it is a message of hope. I think the speaker aptly said that one of the reasons that he wanted to bring, or was committed to bringing this bill, committed to putting his full weight behind it, was because he was heartsick at having to look in the eyes of mothers and tell them he did not know where they could go to get help for mental illness. And with that, I can tell you that these two ladies were the go-to people for the speaker. He listened to them, he counted on them. The women were very powerful in this movement, and it's an honor to be working with the two of them.
Thank you.
Well, we love you both, and look forward to the hard work ahead, and hopefully revisiting the Commission on Women to letting them know next year how the steps we've taken towards getting the system fixed. With that, we want to close and thank you for your attention on this issue, and many, many blessings to all of you out there. And thank you very much.
Bye.
Hello, Georgia Wellness Summit attendees. It is such an honor to be here with you today. My name is Dr. Daniel McKinney. I'm the current Assistant Dean for Clinical Practice and Relationships at the Johns Hopkins School of Nursing, and I'm the founder, CEO, and president of DMPs of Color. I'm pleased to share with you my presentation, Mission Driven and Legacy Building, the journey in leadership and creating a dynamic and successful organization. So a lot of the talk will be structured around my leadership journey in creating my nonprofit, DMPs of Color. So our objectives for the talk today will discuss leadership and wellness. We'll explore how to lead change, and discuss how to create dynamic and a successful organization. First, you must fill your cup. Leadership and wellness begins with self. And I know just the mention of leadership and wellness in the same sentence is somewhat of an oxymoron. However, when I was preparing for this talk, I wanted to put a nice opening quote on leadership, and all of them were centered around selflessness, giving your all to others, and centering service to all, and so forth and so on. And I'm thinking, wow, this is the messaging we're putting forth, that even in inspirational quotes, leadership is centered around sacrifice of self. I mean, we've got to change that. So the first act is finding time just to be. And today we're going on a trip to the beach. So get comfortable. Sit in a supportive chair. Relax your body by releasing any areas of tension, allowing your arms to go limp, and then your legs. Feel your arms and legs become loose and relaxed. Now relax your neck and your back. Release hold of your muscles all the way down from your head, down your neck, all the way down your spine. Breathe deeply into your diaphragm, drawing air fully into your lungs, and release the air. Breathe in again slowly. Pause for a moment and breathe out. Drawing a deep breath in and out. In and out. Become more and more relaxed with each breath. Allow your entire body to rest heavily on the surface, whether you're sitting or lying. Feel the wave of relaxation flow from the soles of your feet to your ankles, your lower legs, your stomach, your chest, your arms, shoulders, back of your head, your face. Now that your body is fully relaxed, allow the visualization relaxation to begin. Imagine you're walking toward the ocean. You can hear the waves. You can smell the ocean spray. The air is moist and warm. It feels pleasant. And a cool breeze is blowing across your body. You begin to walk slowly, bringing one step in front of the other in a slow, relaxing stride. Coming closer to the water, note the brilliant aqua color of the ocean. Walk out on the sand and note that it's very soft and powdery. Take off your shoes. Note the temperature of the sand. Hot, warm, firm. Listen to the waves crashing to the shore. Taking a deep breath and smell the clean salt water and sense of the beach. Gaze again toward the water. Notice it is bright, blue, green. Get caught up in the hypnotizing, enticing waves washing on the sand and then receding back toward the ocean. Enjoy the ever-repeating rhythm of the waves. And imagine yourself walking into the water, feeling the mist of the ocean cool on your skin, being warmed by the sun. And watch the waves wash over you, touch your toes, up to your ankles, as you continue to walk deeper into the ocean. Note how clear and clean the water is. You can see the white sand under your feet. The water is pleasant, relaxing. Temperature is perfect. Now take the time to enjoy the ocean for a few minutes. Now that you're feeling calm and refreshed, walk back out of the water and back onto the beach. Stroll along the water's edge, free of worries, no stress, just calm and enjoying this solitude time. You feel peaceful and relaxed, and allow all your stresses to melt away. And when you're ready to return from this short vacation, do so slowly. Bring yourself back to your usual level of alertness and awareness, but keep that feeling of calm and relaxation and feeling ready to return back to the day. Open your eyes, you can close them, stretch your muscles, become fully alert, refreshed and filled with energy. You can practice this visualization relaxation as often as you wish to provide a mental vacation whenever you need it. Visualization relaxation is a skill that can be learned. The more you practice, the more skilled you'll become and more effective it will be for you to relax so that you can just be and add some sense of mindfulness and wellness to your day in just a short 3 minutes. Just take a wonderful vacation. Welcome back. So part of filling your cup, you must ensure that you're grounded in your story. It's a way for us to connect with our authentic self and helps you and others understand your perspective on how you see and frame the world. This is critically important because this influences how you lead, and grounding yourself in your story that draws the greatest strength and inspiration, because this will serve as your leadership fuel, especially when moments of doubt creep in. My story briefly was that I was told by my guidance counselor that I would never have any advanced opportunity, no access to college, due to my circumstances of growing up in a single parent family household, being Black, and never scoring over 1,000 on my SAT scores. Thankfully, I had a track coach here, his name is Coach Bill Stearns, that saw my potential, and spoke to my strengths and gave me the knowledge that I could use those circumstances that my guidance counselor was boxing me in to my advantage to gain access to college. And so I took this advice and ran with it and went on to get my BSN, my MSN, and my doctorate, and on merit scholarships at that, and with various grants. So this is my family, my high school coach, and all the schools that I went to. So building your tribe. Mentors are the literal keys of success in life. That's it. That's the answer to the $1,000,000 question. I've been fortunate enough to have mentors throughout the various stages of my life. And a couple of key things to consider is choose your mentors wisely. Seek out those that inspire you. One point that I didn't recognize or realize was that you can have more than one mentor, and you should have a variety of mentors that serve different aspects of your life. Soak up their knowledge and wisdom. Experience is always superior to the books. So take notes when you're interacting with mentors or as you're building your tribe. Foster a connection. When you're building your tribe and connecting with mentors, it's mutually beneficial when you create genuine relationships that make the relationship much more fruitful, dynamic versus transactional.
I think that what happens with communities of color, and I can speak to my experience, you have the talent, you have the intelligence, but we just don't necessarily have the community, the network. We just need an opportunity. Once we get someone to basically sponsor us or provide us an opportunity, we take hold of it and we just go. I want it to be a place where we become the voice that elevates nurses of color that have their doctorates, and the significance that that carries is huge. When patients see providers that they can identify with that look like them, they're more likely to have increased trust. They're more likely to adhere to their patient treatment plans. They're more likely to be motivated to take care of themselves.
So remembering your why, again, adds to filling your cup. Mission-driven is the only way to be influential and effective. Know your why. Why do you aim to inspire? My why is building a community that creates opportunities for DNPs of color in order to diversify doctoral nursing practice. And this will advance progress toward health equity in all aspects of healthcare. In this snippet, I share some of my passion around my nonprofit and some of the whys as to why it makes sense to have a group that focuses on nurses of color with their doctorates within healthcare. And this collage is proof of a lot of folks that are in our community. This is the class of 2021, newly minted DNPs of color from different universities. And we highlight their accomplishments because just the significance of being a person of color with a doctorate, we are literally saving lives just by our existence. So leading change. The people who are crazy enough to think they can change the world are the ones who do. Me break. So feeling some degree of imposter syndrome at least once a day. And I know people have the committee in their brains that are always reciting, I have no idea what I'm doing, but I'm doing it. And so the phenomenon of imposter syndrome is real, especially in leadership, especially if you're what I call mission building, legacy building, and changing the game. And when you're infiltrating new places and spaces and trailblazing, this imposter syndrome sneaks up on you. And I looked up a couple of definitions, and I like the one that came out of a Harvard Business Review article where they describe it as a collection of feelings of inadequacy that persist despite evidence of success. Imposters suffer from chronic self-doubt and a sense of intellectual fraudulence that override any feelings of success or external proof of their competence. They seem unable to internalize their accomplishments, however successful they are in their field. High achieving and highly successful people often suffer, so imposter syndrome doesn't equate with low self-esteem or a lack of self-confidence. So finding ways to combat this through affirmations and surrounding yourself with your tribe that lift and build you up constantly is important. So the leadership keys, again, authenticity represents one's true nature of beliefs, true to oneself, to how you identify yourself. People want to know who they're dealing with and what to expect. Being authentic in every sense of the word helps foster connection through a shared vulnerability and strength. It also helps you to stay grounded because you operate in the energy of who you really are. And that makes life so much easier. It makes you so much more of an effective leader. The next key is accountability, which is the obligation or willingness to accept responsibility for your actions. Following up and closing the loop, completing tasks, foster trust and accountability. People want to know that they can depend on you, that you're going to get stuff done. And most importantly, transparency. So operating in a way that's easy for others to see what you're doing, how you're doing it. So fostering an environment of openness, communication, and accountability. People want real talk. They want clarity. They want honesty. And being transparency, again, fosters trust, which in turn creates connections and ultimately influences your impact and productivity. Get aligned. Your passion has to be your focus. And when you start aligning yourself with your passion, that's when fully alignment begins and you're able to establish your sense of self and center it around your vision, your purpose, and your goals. And for me, this was outlined here with my nonprofit DMPs of Color. So when you start aligning, you can start allowing, and allowing creates room for your talent and your expression of your passion. And people will be attracted to that. And before you know it, you'll have an entire following wanting to help build, create, contribute to the success of your passion. Mobilizing the people, choosing your team wisely and understanding that people will come, but utilizing them according to their talents and matching them up in the areas of the mission that resonates with them the most. And this is by far the most effective way to maintain engagement and productivity. No one wants to be assigned to things. Talk to your people, connect with them, find out what part of the mission excites them and what skills or resources they want to contribute. Diversify your team. Diversity is so important. I know this is a buzzword that's been buzzword for today, yesterday, and all the days, but diversity and being intentional, not just on the surface, but visual, from experiences, geography, education, influence, social capital. This will help substantially enhance the innovation, creativity, and help your organization thrive, especially when there's diversity of thought. Building communities. So focusing on how to create the organization, excuse me. Identifying a problem. So with my organization, it was critically important to identify a problem so that I can start shaping the mission, the vision, the goals, and how to build from there. So it's critically important to find that problem. And in this case, the lack of diversity in nursing at the doctoral nursing practice level, and examining the evidence and creating the case that proves the need and solves the pain point of this problem. So again, just showing more data as to why the lack of diversity is a problem in nursing, specifically in doctoral nursing practice, more data. And so representation matters, a diverse workforce matters, and there's so much power of inclusion and belonging. And again, speaking to the validity and the credibility as to why my organization has been impactful and influential. So looking at facts and validation, combine all the facts and create your stance as to why your organization is relevant and its impact, and the impact and how it will make to solve the problem you've identified. So just kind of recapping, letting your passion become part of the solution, finding ways to lay the foundation, so focusing on your mission, vision, goals, collecting, creating space for the right people, your right tribe, you're celebrating your trials and triumphs, navigating the paperwork and politics. So we have to get through all of that when building organizations as well. So creating opportunities, focusing on the impact. And for us, our impact is inspiring nurses, empowering professionals, and transforming nursing practice. Again, digging deeper into impact. So define and document your impact. Details are in the data, and the data quantifies your impact. Your impact fulfills your mission, and your mission will help build your platform for you to get money. No money, no mission. And so this is just a snapshot of some of the things that we do to impact within our organization. Leadership and building dynamic organizations can be difficult, but it is extremely rewarding. So as I kind of come to a close, how are we mission driven? What is your mission in life? If you don't know, I encourage you to reflect on it. Legacy building. What will be your legacy? What will people know you for? What contributions will you make? How will your leadership in the organizations that you're building or influencing or being a part of will make an impact for others? And so in closing, I'll leave you with this quote. You can only become truly accomplished at something you love. Don't make money your goal. Instead, pursue the things you love doing and then do them so well that people can't take their eyes off of you. It has been a pleasure to share this time with you. Please get in contact with me. My name is Dr. Daniel McKamey, and I can be found on Twitter at Dr. McKamey. And feel free to email me anytime. Thank you again, and have a wonderful rest of your summit.
I'm just putting this other one on as well. It turned up. I'm seeing that. 1 second.
Not be able to fix something for lack of resources. But our challenges are fixable, but we have the resources. We have the legislators, we have the experts, we just heard from them. We have the money. So but there's a miss, there's a disconnect.
We do have all of this. And, as you and I were talking, just off to the side, the one thing that I think is extremely important, because we have the speakers, we have the resources, we have the legislators, we have leadership that's involved. What we need is togetherness.
Collaboration.
Collaboration. And we have to find the ability to understand that when we galvanize, when we come together, when we break down walls, when we are operating not within silos, but together, we can get so much more done.
That's right.
Together.
That's right. And when we get it, because clearly there really is only one agenda, right? There's one agenda, and that agenda is advocacy and forwarding the movement to make Georgia a better place for women and children, right?
That's absolutely correct.
There's one agenda. So if we all just, to your point, galvanize around that.
There's one thing that I like to share all the time. Is if we want to have a healthy world, a healthy society, we first have to start with healthy women.
That's right.
And healthy children. We do not have healthy communities, a healthy state, a healthy country, and we're not strong globally if women and children do
Always.
not get what they need,
That's
because
right.
they're the backbone
I mean,
of
it starts
society.
with us. I mean, literally, we kind of, you know what I'm saying here. We do it all. I mean, I'm saying like, we definitely need men. I'm not saying that. I'm just saying like it kind of starts with us.
Yes, so we give birth to nations.
That's right.
We give birth to nations.
That's right.
And women and children need to be protected and cherished at all costs. So
That's right.
today's discussion has been phenomenal.
Yep.
To be able to highlight that.
Yeah.
And really and truly, child sex trafficking is a topic that's very near and dear to my heart, because I am not a mother, but I do a lot of mothering. I
Yeah.
have 10 godchildren.
Wow.
My husband and myself, and they're really expensive.
Do you have dogs?
No.
Okay. No pets?
No.
Okay, I was just checking.
No, and I like to share with people that I am my husband's very expensive baby, so he deserves a lot of awards for the fathering, the mothering, and everything that he
That's
does in
right.
between. But something that my husband and I discuss a lot is for our godchildren and all the children that we mentor, how important it is to pour into them.
Right.
And there are 5
right.
things that I like to share when we're talking about the upliftment of children, because children in our society need to have the agency to be able to advocate for themselves.
That's right.
And I like to share my 5 C's, but sometimes I get them confused. I just
Okay.
shared it with you.
You did.
So maybe you
I
can
have a
remind
couple,
me.
I have a couple in my head. Do you want me to start or you want to start?
Go ahead and start.
Courageous.
Courageous.
That's a good one.
Okay.
Confidence.
Confidence.
Okay. You take the next one.
Competence.
Competence.
Competence. Caring.
Caring.
And compassion.
Compassion.
Yes. All of that is
The 5
needed.
C's.
The 5 C's.
Y'all got that? The 5
5
C's.
C's. And all of those things are needed to help build the child who is self-aware, that has agency. And, I want to take it a step further.
Okay.
Michelle.
All right.
Because
Michelle.
a birdie told me that not only are you an amazing speaker, the hostess with the mostest, that you are not just a media mogul, but we need to add author to the list, the very long list, the scroll of
I will send-
accomplishments.
Her check is in the mail, friends.
There you go. The scroll of accomplishments. You are an award-winning author that focuses on the topic that's near and dear to me, children.
Yeah.
And I would love to share with everyone today, someone dropped a copy for me.
Look at you.
Michelle's latest work, Raising Significance. Michelle, please tell us about your book.
Yeah, well, first of all, thank you for that. You are very kind. I have a whole team of people that makes that long scroll available. So if it were just me, I would be, flabbergasted, but it's not. There's a lot of people that we don't ever see that help me a lot. So I just want to make sure I give thanks to them. So the book is about raising significance, right? And for me, the difference between success and significance is, success is about us, right, in our immediate circle, right? How do we affect our families and the people closest to us? You get the great job, the 2.5 kids, the dog, husband, wife, you know what I mean? White picket fence, all that stuff. You're a success. You're successful. But significance is when you use your success to affect others. It's a level of empowerment that all of us literally could have, but we don't execute upon. And I believe that the world is in shambles right now because we have a lot of successful people that are completely okay with being successful, and they don't want to push to rise to that level of significance. And that's why I say raising significance, because the book really is about 8 tenets that we can use to instill this stuff into our kids early. They won't have to guess or try to decide whether or not they're going to be significant. It's in them already, and they're going to be bred for it. Now, let me just say, I always give the disclaimer. I'm not a child psychologist. I'm not a psychiatrist. I'm not a child expert. And my kids are not perfect, although they might think that they are. But these are just a few things that we've come up with that will help us instill confidence.
Competence.
Yeah, and specifically this confidence piece I think is so huge because when children are being victimized or assaulted, they have to have the confidence to say no or to come say, hey, Dr. Nelson, someone's doing this to me. Right? It all stems from a sense of self, like you mentioned earlier, and this confidence piece. So like I said, these are just things that kind of help with that at a very early age that you can do. And I mean, if you're raising significant children, then theoretically we would have significant adults.
That's right. Communities.
Communities, absolutely.
A state, a country.
Country and a world.
Exactly, because most certainly we want to instill in children now that they are global citizens.
That's right.
That they are not just operating for themselves. And their significance can most certainly be tied to their ability to think outside of themselves, to expand and contract and be flexible, and to also pour into communities as they have been poured into. Michelle, we really want to be able to tell about the 8 tenets, but we need them to go out and get this book.
Well, I think I might know where you can get her.
Where would that be?
That would be authormichelletaylourwillis.com. All one word, authormichelletaylourwillis.com. It's right on my website, michelletaylourwillis.com, and you can just click on buy now or pay now, and you can get the book.
Phenomenal.
And thank you so much for the kind introduction. I really appreciate it.
Absolutely. So you've heard it here, folks. If you want to raise children that have the 5 C's, that take agency and advocacy seriously, that understand that this world that we live in is a well. Not a well that you consistently draw from, but one that you are also responsible for pouring into.
Look at us. We're so on the same page with this. We're not even trying. We didn't rehearse this.
No.
But this is what happens when you have people who are aligned, the same agenda, the same vision, and who are working intentionally, collaboratively.
Exactly.
Yeah.
So I just want to also thank our last presenter, Dr. Danielle McCamey. Shout out to Danielle McCamey. She's the CEO of Docs for NPs, or no, DNPs of Color. DNPs of Color. She is the CEO. And we thank her for her presentation, which focused on going from becoming a clinical CEO to becoming a not-for-profit CEO. Okay, so that is very important for those of you out there who want to start your own businesses and you want to focus on how to support other individuals who have their own businesses, nurses that have their own businesses. So we want to make sure that Danielle understands that we absolutely value her.
Yes.
So I want to go ahead now and I want to introduce our next speaker. And after I read her introduction, I'm going to make her blush a little bit. I'd like to present to you Major Anna Sanchez. Major Select Anna Sanchez has worked in healthcare for over 36 years, and she's only 37. Get that? She is currently the coordinator for the Sexual Assault and Response Program at Dobbins Reserve Base, Dobbins Air Reserve Base in Georgia. She serves as a subject matter expert in military sexual trauma. She delivers a full spectrum of resources to the service members. In her civilian capacity, Major Sanchez delivers excellent advanced practice care at the VA hospital in Atlanta as a psychiatric mental health nurse practitioner in the emergency department. And how do I know that she delivers excellent care? Well, I taught her myself.
The student becomes the teacher.
The student becomes the master.
The master.
And I am incredibly proud of Major Anna Sanchez. She actively volunteers and engages in the community to decrease barriers in mental health and to increase access to mental health. Here is our next esteemed presenter, Major Anna Sanchez.
All right.
Thank you. Thank you, Dr. Nelson.
You're most welcome.
I appreciate the introduction. I appreciate everybody in this room. I appreciate also the folks that are out there. So I'm Major Select Ana Sanchez for short. I am a dual certified family health nurse practitioner, psych nurse practitioner, but my passion is in the field of mental health. So thank you, Ms. Janessa Smith. I appreciate you for inviting me to come over here and speak. It's an honor. She's also a veteran military service member who served our country. So kudos to you. Thank you. So I will be speaking to you about Georgia women and healthcare. So my objectives are to define what mental wellness is, what is the cost of mental illness, and the barriers that we face, that our patients faces. I will also touch upon military health, women's health, and what is mental health first aid, and what you can do as our providers or healthcare allies, and what you can do to help destigmatize and increase the access, okay? So raise awareness and support and make mental health a good wellness for Georgia. So let's begin. So what is mental wellness? Per the National Institute of Health, it is the ability to carry out daily activities, relationships, and be able to bounce back from adversities. The United Health Foundation said that it's the essential for overall positive health and well-being. Global Health Wellness Institute said that it is an internal resource that we have in us so that we can think and feel and be connected and be function and be able to have that legacy that Dr. Nelson and Ms. Michelle was talking about, have that significance in our community. So on the other side of that spectrum is, what is mental illness? Mental illness can be derived as being mild to moderate to severe emotional disorder, right, that we can see. It limits the person from to be able to become a full person, to be able to become productive. And ultimately, one feels like a burden, and that is serious mental impairment. So let's look at our statistics. What is the cost of mental illness here in Georgia, or in the United States for some of these statistics? It's the 10th leading cause of death. Suicide is. This is according to NAMI, Georgia. NAMI is a great organization. If you don't know who NAMI is, you have to be an ally with them as well. In 2019, look at that number, 225 billion. That's big. We've heard so much from our speakers today that 1 in 5 adults had experienced mental illness. That's 43.8 million people here in the United States. 1 in 25 adults have experienced that serious mental illness where they cannot function. There's a severe impairment in their lives. As a veteran, as a military service member, 18 to 22 veterans die by suicide. So I will talk to you a little bit more on that later on. And the loss of productivity. We all work in our communities, in our environments. 44 billion loss of workplace productivity. That is huge. So we are all affected in this. Here are more statistics of the cost of mental illness. There's about 20 million people who have experienced substance abuse disorder. And that can be a whole range from alcohol to illicit substances, right? So be aware of that number. Coming out from this pandemic, and now it's an endemic, we are still experiencing this this dilemma for our patient population, even for our family members, if you can take a deep look at your families and your communities. 50.5% of adults have co-occurring mental illness. Again, that impairment, right? Look at the numbers for schizophrenia. Look at the percentage for those who have bipolar disorder. and that major depressive disorder. And sometimes that MDD can be a mood spectrum, right? It can be a whole range. Last bullet point on this slide, I want to hone that. Mental illness, we're the last one in our nation. Ranks last for access to mental health care. That's not good. So we got to think outside the box. What can you do to increase that access? How can you pull your patient in? How can you bring your families, your coworkers in so that they can access mental health? Okay. Again, cost of mental illness. We have heard this earlier in one of our speakers, that women are more affected with mental health. About 51.2% receive mental health services. This is the women, we're talking about the women here. Again, the frequency, it's persistent, it's severe mental distress. About 14 days in a month, that is significant. That will lead to poor health outcomes. Higher prevalence of those who have mental illness are the smoking incidents, right? Alcohol use, substances, unhealthy diet, lack of exercise. What you can see from this is that the prevalence of these behaviors leads to chronic diseases. That can be diabetes, that can be cancers, cardiovascular diseases. So it's not just the mental health that we're looking at, it's the chronicity of the mental health that affects the chronic diseases. Again, that link of mental wellness and that physical health. Social welfare, we have seen this from all speakers today. Food insecurities, all the housing insecurities, insufficient sleep. Our children are affected, our communities are affected. That leads to poor mental health, risky behaviors, there's this disability and the suicide. Lots of homelessness in our population here in Georgia. 25% to 26% homeless adults in the shelters. 20% are in prison, and a lot of our patient population that have mental illness are in prison. Is that really the place for them to rehabilitate? Probably not, right? 70% of youth have mental health condition in the juvenile system. We've talked about that earlier with mental illness in the families and in our communities from the previous presenters. COVID mental stress. We will not get back to that baseline soon. We're just seeing the trends right now of what has occurred or what is still occurring, and it coming to light now. And there will be more research to come. This is according to a study at Harvard University where 42% responded increased depression, increased mood disorder, increased anxiety. So what happens then? Death, economy, interrupted social circle, that impairment. Okay? So barriers to mental wellness. This is now a reinforcement of what the other speakers have talked about, right? As a nurse practitioner, I will advocate for the nurses, the nurse practitioners. We in Georgia do not have independent practice. So you will become our ally to help us have that access in Georgia so that we can increase that well-being for our patient population. There's so much stigma, there's so much discrimination. In our race, ethnicity is very affected. We have seen that during this COVID pandemic, right? Shortages of mental health providers. So what did I do? I had to think outside the box, right? I created a nonprofit organization for veterans. I also have a telepsychiatry that I am working, that I'm doing now so that patients can come and be seen because there's a lag in support. There's embarrassment, there's fear, cultural beliefs in our very own cultures. We have talked about that earlier during our first presenter, where it's not even accepted to even talk about our emotions, right? financial barriers due to these lack of access, barriers to mental wellness. We cannot be productive citizens if we don't have the support from our communities. There's no affordability in transportation. How can we go to the clinic? So if you, as the mental health provider or the family nurse practitioner or the doctor, trying to get the patient out in the community, when you're discharging them, where are they gonna go? Do they have access to transportation? How can they go to the mental health, right? Do you have bus passes? Do you have taxi vouchers? Those are the things that you have to think outside of the box when you discharge patients. Lack of anonymity. There's that embarrassment. How can they go about seeing their providers, right? Okay. So I'm gonna now talk about symptoms of suicide because all this impairment has been happening. So what can you see as a provider, as a family member, as a coworker when you see these things going on in your patient or your family members, right? There's the depressive state, that anxiety. With the depression comes that sleep that are not good, right? Insomnia or hypersomnia, where they sleep 12 hours and they are not being feeling rested. There's that irritability, that agitation. There's a feeling of guilt as well, hopelessness, helplessness. That is key when you're assessing your patients or your family members so that they can seek mental health. Poor concentration, forgetfulness, right? I cannot think. I'm ambivalent to what's going on. I cannot make decisions. There is also that appetite changes. Is the person eating more or eating less, right? That's psychomotor retardation. I am just so slow. I cannot think. Or I am just so angry that I have my fist like this, balled up. Those are the signs and symptoms that you've got to look out for. Pacing, when your family member is pacing or a patient is pacing, that means there's something going on there that you've got to take care of. Ask. Are you having thoughts of suicide? Are you having negative thoughts? Do you have plan? Do you have an intent, right? Do you have access to firearms? We've got to think of these things. Is there past suicide attempts? Was there past self-injury? That is important to know. Do they have that gun on hand? Is it locked? Is it there by the bedside? Now, I know that's a right for all of us to have that gun access, but as we have seen, it's not working for the folks in our communities because this access to firearms, it's killing a lot of children, killing a lot of patients, killing a lot of our friends and our families. So ask, history of suicide, that makes them having a higher risk. Is there a family history of suicide also? That is very important to see because if there's family, is that their coping mechanism? What have they done, right? That genetic predisposition. Again, I've talked about that risky behaviors of substance use, alcohol use, driving really fast, not thinking of the results of their behaviors. We talked about the hopelessness and helplessness. That is important, right? Are they linear in their thoughts? Are they thinking forward? Are they future-oriented, like next month I'll be doing this? Or they cannot think because they're so wrapped up in that negative thoughts of suicide. Isolation. Have the person been isolated that they've gone to this abyss now that they don't want to talk to you? They're not bathing, they're not brushing their teeth, they're not taking care of themselves. Those are signs of depression. We've talked about the pacing, the agitation, and giving away their belongings, writing a letter to their family, social media. We have seen those as well. Okay, as a military service members, I gotta skim through this so that you can at least have a feel, because they are there. The veterans are there, our service members are there. We are a lot, there's about 1 million people currently serving in the United States population. I'm sorry, 1% is serving currently. So what makes the service members different from your regular folks is because members go to deployments, they go through training, and during these deployments, you gotta ask them what they've seen, what era of the war they've seen, right? What humanitarian operations were they in? Did they help somebody in Haiti? What did they do? What was their MOS? What was their jobs in the military? They're away from their family for a long period of time. Now, for Air Force, it's between 4 to 6 months. The Marines and also the Army, they deploy longer. National Guard, that's the same thing. They're being called on. Currently, right now, we have a lot of folks in Europe because of what's going on in Ukraine. So when they come back, what have they seen? What have they experienced? Gotta be aware of those things. So, in the military also, we have a very rigid ranking system. So do as you're told, or else it's not a good thing. MST, military sexual trauma. Higher rates of depression for our service members who experience that. And it's an honor to be the SARC at Dobbins right now. I was the SARC Sexual Assault Response Coordinator when I deployed in Korea. So that is key. You gotta listen to the themes that your member is talking about. When there's MST or military sexual trauma and the mother or the female becomes pregnant, there's a higher risk for the mother not bonding with their children. I've, numerous stories, the lived experiences of our members. So be aware of that. Again, the military also has a very masculine culture, and we do not want to be perceived as weak, right? We're strong. Men don't get sexually assaulted in the military, but guess what? How many members of the population in our military are males, right? 1 in 4 women are sexually assaulted, 1 in 6 males are sexually assaulted, but that's the tip of the iceberg. We only hear the tip that report about that. Military cultures, the branches, very different from Air Force to Navy to the Army to the Marines. So there you go. All right, let's get back to women's health now. I just wanted to skim that military portion to let you guys know about it. So, but even though it's military sexual trauma, now we're talking about our sexual trauma also in our civilian population. Kind of the same things that women experience or males experience as well. But since we are focusing on women's health, this is what I'm gonna hone on. Women who have experienced sexual trauma can have numbness. They can have intense emotions, panic attacks. They have decreased concentration. They cannot think clearly. There's impairment. A lot of people who experience trauma can reach out to the bottle and drink because I want to feel that relaxation, because they're the heightened alert, right? That fight, flight, or freeze response is always there. So I'm gonna drink, I'm gonna forget about it, I'm gonna self-medicate. So you as the provider have to be aware of those things that they're doing. Ask, okay? We've talked about the difficulties in relationships. So if they have difficulty in relationships, then that means it's gonna be not so good because they're gonna isolate. They're not gonna talk to their families. And there's detachment as well. So, talking about women's health, look at this. Ruth Bader Ginsburg. She's a feminist. She's a wonderful female, and women's rights are essential part of the overall health and human rights agenda. We have to be trained on the equal dignity and the ability to live in freedom of all people. Because if we as women don't have health, we cannot fully be able to function, okay? Lot of in the news, reproductive health freedom. What are we doing about it? Are you an advocate for women? You need to be advocating for all women, okay? Because if we have reproductive freedom, we also have family progression. We can go educate our women. We can be productive in the workplace. We can have jobs, and that legacy, that significance in the community is important. That is the legacy that we have to build, okay? So, Dr. Nelson, take note. Okay, gender violence, we talked about this earlier. Okay, again, I am reinforcing what you have heard. Domestic violence has increased, and it's a leading cause of injury in the state of Georgia. Look at that, girls and women, 15 to 44. Family violence, intimate partner violence, teen dating. Increase in violence when women are pregnant. So ask those questions to your patient. Do you feel safe? You know, are you being pushed? Are you shoved? Are you being coerced, right? Those are the things that you have to ask. 1 in 6 females aged 15 to 44 has been sexually assaulted. Another number there that's out there. In 2005, I know this is an old number, 127 victims of domestic violence have been killed by their abusers. These are the partners, the significant others. Physical violence, sexual violence, the isolation. Economic abuse, we've seen that, where our children, the women are being pimped out because of that economic that benefit for the pimp to the person, right, to the female. Okay, women's health, as we have talked about, it causes depression, anxiety if we don't have the support, if there's trauma, if there's sexual violence, if there's intimate partner violence. We have seen what inequity will do for our women. The environment, we have to be aware of the environment of our women and children. If the environment is not conducive to learning, if it's not conducive to advancement, then there will be low education, and the cycle kind of repeats itself, and we don't want that. We have talked about restrictive laws for reproductive health in the women of Georgia. I know this is a Bible Belt, but we gotta think of what's right for our patient population. We gotta understand also the hormonal fluctuations of women. I gotta throw that out there, especially during pregnancy, PMDD, perimenopause, and menopausal. Again, there's a lot of things that's going on in the female body that we gotta be aware of. Okay, more on the statistics. You guys probably have seen this number where Black women in Georgia typically makes 63 cents for every dollar that a white male makes. National figure, it's kind of the same, 63 cents. That's not a good thing, right? Latina women in Georgia makes 49 cents out of all the dollar of the white male. Single moms in Georgia. How many single moms do you know? Are you giving them support? 39% of single mothers in Georgia, here in our state, live in poverty. National figure is 35.6, so we are higher in that number, and that's not a good thing. 11% of women in Georgia, 65 and older, live in poverty. So those, for all of us in healthcare, we are Taking care of our adults, our older adults. So 11% of them are living in poverty. COVID-19 pandemic, again, I am going to reinforce this, that women of color, people of color have been disproportionately impacted by COVID-19, and we are still here, okay? 7.8% of women in the reproductive age in the state of Georgia is uninsured. So that means they're not coming to the healthcare providers. They are just going to the emergency room if in case they are in dire emergency, and that's not good. We gotta be in the preventative state, right? We gotta be prevention. 17%, I'm sorry, in Georgia reported not receiving the health care they need. Not good. So we gotta be advocates. We gotta be allies to our patient population. Generational poverty, the cycle of poverty, not one single factor, but it's a whole range of factors that are causing this generational poverty. We looked about the educational access, pay equality, inequality, the environment, and we need to have that access for physical health as well as mental health because they are linked together. What do you do for mental health first aid? This is critical, okay? Mental health first aid is like CPR, right? We do CPR when we are having an emergency, when someone is having an MI or whatever the cause is, right? We have to assist our members, our patients, our families when they are in this stress that's overwhelming. So we have to have early intervention. Again, I've talked about prevention. Preventative piece is very important. Assess for suicidality. Don't give any judgments. Listen. Look at the themes when they're talking about. What is the theme? Are they hopeless? Is it the shelter, the lack of shelter maybe that is causing them distress? Is it the intimate partner violence? So you gotta think of that. Encourage them to seek professional help. And also protective factors. Ask them, what have they done in the past that had made them more resilient so that they can pull that in their current situation. Again, look at the protective factors, their recovery, AA, NAMI, all the helping agencies out there for community mental health. Use their strengths, use their resiliency, spirituality. That is a good thing. We got to use that. And of course, peer support. Call to action for you. You need to be having that listening ear, okay? Non-verbal language. Don't be like this. Be open. Show your hands. Show that you're open to listen to them. Do your mental health screenings, your PHQ-9, your GAD, your mood disorder screenings, all of these things. And then refer them, refer to a psych mental health nurse practitioner like me, to the social workers that had come earlier, to professionals, to peer support. That is important. Be empathetic. Okay, let's be political. Let's vote let's give our voices and be able to vote so that we can tell them what we need here in Georgia. Okay, be positive role models. Let them know what we need. Provide contraception so that these women can not just bear children, but be productive a little bit more so that they can be able to feed their children, they can work, they can be having that sense of self, that they're confident in our state, because that will be, all of us are gonna be affected if that's the case, okay? Increase their resources, access to mental health, access to mental wellness, also to their physical health. Be a mentor, educate, be an advocate, be an ally. Inspire other women as well. Talk to them. Be politically attentive of what's going on in your community. and give them the wraparound services. Okay, we've talked about stigma reduction multiple times during the day. Start conversations about mental wellness, be open, right? I statements, let them know what they can do as well. Okay, wellness maintenance, we got to have that mental, the spiritual, the social pillar, and that physical wellness, because if one is not working well, then the other pillars is not gonna work. Georgia Crisis Line, Veteran Crisis Line, gotta know that. Please take a picture of this and share it with your patient population, to your families, or even to yourselves. This is my email address. This is my phone number. You can contact me anytime. Questions? Thank you so much. I appreciate you.
Good afternoon. My name is Catherine Paradiso. I'm a doctor of nursing practice. I'm also an assistant professor and the graduate program coordinator at the College of Staten Island, which is part of the City University of New York. I'm privileged to be an adult and psychiatric nurse practitioner, and I'm here today to talk to you about the opioid epidemic, harm reduction, and the nurse practitioner role. Addiction is a disease. So a person doesn't have opioid addiction, alcohol addiction, they have a disease of addiction, and what the choice or what the person is addicted to can vary. So we know people can be addicted to alcohol and drugs and gambling. They can also be addicted to sex and technology now, which is a new thing that we're seeing more of. And I say laughingly that you could be addicted to shopping, but in truth, anybody can be addicted to anything. When it comes to opioid addiction, there's no boundaries of gender, race, class, or socioeconomic status. I live and work with patients who are addicted to opioids. I'm, again, fortunate that I can use my adult and my psychiatric nurse practitioner certificates and licenses to treat those patients. But in the community where I live, we have everybody from, poverty to filthy rich, and our patients cross that gamut accordingly. Every race, every class, it doesn't matter how much money you have, where you live, who you are. We see people with opioid addiction everywhere. And it is a huge problem in the community where I live, but it's a problem everywhere in the country. And I'll get into a little bit of the data later on. When there's opioid addiction in the family, there's a lot of chaos in the family, a lot of chaos in the house. It can destroy any life, any family, any person's finances, and it really can destroy a community. In addition to lost productivity at school and at work, the family conflicts and family violence leads to health problems in the other family members as well. So it's not a disease of one person, it really is a family disease. Because these people lack judgment, they may also engage in unprotected sex. So we do see a lot of STDs and, unfortunately, a lot of unplanned pregnancy. We also see motor vehicle accidents. A lot of patients come to us from the court where they're arrested for driving under the influence, or have an accident and a person is injured, or they commit a crime, and they are diverted to our program, which is, I forgot to tell you that I see patients in the YMCA Counseling Center for Drug and Alcohol Abuse, and patients are diverted to our program from the courts all the time for crimes that they may have been arrested for while using. In the case of homicide, I don't believe that we get those patients. They usually do, they usually are incarcerated because they are documented obvious harm to other people. And then, of course, there's a very high rate of suicide among people who are opioid addicted. The Diagnostic and Statistical Manual of Mental Disorders is the book that the American Psychiatric Association publishes, where all of the diagnostic criteria for all of the behavioral health disorders are listed. This book is very friendly to primary care. You've probably used it if you're a nurse practitioner and you've had to diagnose anxiety, depression or post-traumatic stress, but also in the DSM-5 is opioid use disorder. So the DSM characterizes it or defines it as a problematic pattern of opioid use leading to clinically significant impairment or distress. So that's the definition of it. But there's criteria that have to be met before you can make a diagnosis. So the diagnostic criteria are that two of the following have to be observed within a 12-month period. So in order to confirm the person as having opioid use disorder, which is the proper word for opioid addiction, opioids are taken in a larger amount over a longer period than was intended. So the person, this is an example of somebody that takes an opioid for pain, thinks they're going to take it for a couple of weeks, and all of a sudden is taking it for a couple of years. There is a persistent desire or unsuccessful efforts to cut down or control opioid use. Opioid use leads to intense cravings, and the cravings are only quelled by taking an opioid. And that is why it is, just like cigarettes or alcohol or anything else, very difficult just to stop cold turkey, or really almost impossible. I've never met anybody who could stop opioids that way once they were diagnosed with opioid use disorder. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover. So this is the person that has to go out and find it, has to find a way to pay for it, has to sneak to use it, and has to recover from it the next day. Opioids can be pills. It can also be heroin. A lot of times the person will start with, oxycodone pills, and they'll progress to heroin, snorting, and then eventually be taking it intravenously. So all these things take different amounts of time. They progress over different periods, but it's the time issue that's addressed in this criteria. Cravings, I mentioned. Recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. Here, parenting obviously becomes a problem. We do see sometimes, administration for children's services involved because parents get reported if they're stoned while caring for their children. So, there are times when other agencies get involved, but basically it's the inability to fulfill their role obligations in any walk of life. More criteria here. Continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. Important social, occupational, or recreational activities are given up or reduced because of opioids. Recurrent opioid use in situations in which it is physically hazardous. So driving, operating machines, going to work, all of those things. Construction and anything, so that basically is a nice way to say the person's stoned at work and driving. Continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused by or exacerbated by the substance. So this refers to the person kind of actually knows that they have a problem, but they haven't really been able to seek help. They haven't, help is voluntary, right? You have to check yourself in. So they haven't done that. So that refers to that one. I have to say, in many of these, many patients, I see almost all of these present. But there's always more to the story, right? How does the person get addicted, right? And the pathway in to many people getting addicted in the past was pain management. Once the awareness was raised, let's just go back in time. There was a period of time where providers were told that if they didn't manage their patient's pain, they were horrible. Pain became the sixth vital sign. I'm sure you've all remember or heard about that part of medical history. And people received opioids willy-nilly, all right, and then became addicted very quickly and then couldn't get off. And there is a movie called Dope Sick on Hulu, and there's a book called Dope Sick, and then there's also a book called The Empire of Pain. I would really encourage you to watch that or read it because it's a story, it's a true story about how the Sackler family knew that the opioids were addicting, put out false evidence that they were not addicting, and encouraged doctors and nurse practitioners to prescribe them. So a lot of people were addicted and a lot of lives were lost because of that. Once that awareness came about and the prescription drug monitoring systems went into place, providers became more aware of and prescribed opioids less. A lot of states have requirements for doctors and nurse practitioners to get educated on opioid prescribing and pain management. So less people are getting them for pain management, but there are times when it's necessary. So that's one way that people have become addicted, through chronic pain. Stigma obviously is a consequence, and of course death is the worst consequence. But the stigma is serious because a lot of times people associate drug addiction with, a homeless person in the street, when it could really, it really is everybody. Everybody in society can be drug addicted, and so many people are. And people just like me and you that have jobs as nurses, doing whatever they're doing, drive nice cars, have nice stuff, whatever, are addicted. And you don't realize it because it's very well hidden. But it's really a pervasive problem in America. There's a lot of peer pressure for younger people, right? So take this pill, smoke this joint, but I have had grown people, grown adults come for rehab and say, yeah, I was about 30 and we were all out and we were all using all the time for recreation, and they didn't start using until they were in their 30s, which is, kind of at a point in life where peer pressure really shouldn't be as serious as it apparently still is. And that goes to lifestyle, right? People who are out partying, people who associate with other people who use, are likely to use. Another thing that is very important in the environment is oftentimes the person's partner introduces the drugs to them. So it could be a woman or a man being introduced by another woman or another man to use. I use, it's fine. Let's just get stoned tonight. I mean, it's really common when people start using from their romantic relationships. Marijuana actually is a gateway drug. I know there's been some controversy for that, but every one of my patients says that the first thing they did was smoke, and they will tell you that they felt that that led them to want to do other things, because the relaxation and the feelings that they get when they smoked, they wanted more and more of over time. You also have cannabis receptors in your brain that, become, I don't want to say tolerant, but, people get used to the high that they get from marijuana, and they want more. There's also coexisting, and this is a really serious condition, a real serious contributor to opioid use, is when the person has coexisting behavioral health problems, almost always of anxiety and post-traumatic stress, they're more likely to use. And I have to say that 99% of my patients, abuse is so prominent in this population. It could be abuse from childhood, but it could also be recent past abuse from a romantic relationship, or a relationship at work, or any relationship where the person is really abused by another person and traumatized and unable to negotiate that abuse or manage that abuse at the time it's happening. So it's really, and then post-traumatic stress sets in, then anxiety and stress, is associated with that, eventually can become panic. So to cope with all of those things, people turn to opioids. So that's a very, very, very common issue with people who have opioid use disorder. The comorbid conditions highly contribute to use, and they also pose a barrier to treatment. Because if somebody has anxiety, depression, I mentioned child abuse, but it's called, adverse childhood experiences. So that could be death of a parent, it could be death of a sibling, it could be an illness the person experienced as a child. Anything in their childhood can give a person post-traumatic stress disorder, eating disorders, and then we also know serious mental illness, bipolar, schizophrenia, those types of diseases also can contribute to use, but they also pose a barrier to use, right? The person sometimes has these behavioral health conditions. They're so prevalent that they're not able to actually go and seek out help and engage, and when you go for help, person has to engage, right? They have to participate, they have to take the medication, they have to show up for appointments. There's a lot of responsibility with being a patient in a drug rehab program. So sometimes these behavioral health conditions, if they're not treated, they actually are a barrier. On the last line here says MICA, which is mentally ill, chemically addicted. This is very common. You know, again, the patient has other illnesses and they're also chemically addicted. And if both aren't treated, neither one will get better. That sounds very easy to say. You will know it's not that easy to do, right? Depends on the resources in the community. Mental health resources in many places really aren't as strong as they need to be. There's 4 opioid receptors in I wrote 4 opioid receptors in the brain, but 3 really are prominent with drug use: alpha, mu, and kappa. The opioids can change the brain stem, which is an area that controls automatic bodily functions and depresses breathing. It can change the limbic system, which is the amygdala and the hippocampus. And that's where emotion and emotional distress occur. And so again, the motivation to use to really reduce the feelings in that part of the brain, calm them down, make them feel more relaxed, make them less bothered by the thoughts of trauma or whatever. Opiates can block pain messages transmitted by the spinal cord, and that again, we said the original pathway into the use. So before we had a COVID epidemic, we had an opioid epidemic. And it was classified as an epidemic reaching national emergency status in 2017. But when you think about how long this has been going on, it probably should have really received that classification long before that. Health and Human Services then, as a result of the emergency, listed 5 national priorities. 1 was to improve access to treatment and recovery. 2 was to promote the use of overdose reversing drugs, which is Narcan. We're going to talk about that in a little while. Another is to strengthen our understanding of the epidemic through better public health surveillance. Another is to provide support for cutting edge research on pain and addiction, because if we could find a non-opioid that could treat pain just as well, you would never again have to prescribe opioids for pain, right? And advancing better practices for pain management. There was legislation with financial support attached to every single one of these priorities, but the prevalence remains extensive. Now, 2017 was not that long ago, right? What is it, 5 years? But even before that, we were really addressing this, you know, in terms of the government, right? Financing things in states and local governments. And the epidemic just keeps going on. In 2018, there was 67,367 overdose deaths. 2019, it rose to 70,630. In 2020, in 1 year period, and the period was measured in May, 81,000 deaths. And then 1 year later, 100,306 deaths, which, you know, of course, you could blame on the COVID epidemic, but that's only a part of it. There's also a lot of non-fatal overdoses. So these are just the deaths, right? If you then factored in how many people overdosed, it's really not known for sure, because some people get receive Narcan. So that overdose is not recorded. If the person's not brought into an emergency room, it's not recorded. So you could be in your living room, overdose. Somebody in your family can give you Narcan and nobody will ever know you overdosed. And this happens. Patients will tell me, I was Narcaned 5 times, you know? So, you know, these are the people that have passed away from this. Sometimes before they pass away, they've had multiple overdoses. And with the fentanyl now, there's all of a sudden where I live, I don't know about every place in the country, but where I am, there is no heroin anymore. It's all fentanyl. And this is what the patients are telling me. So they're a little more frightened because fentanyl can kill you quicker. If the person overdoses from fentanyl and they don't have a pulse, which happens faster in fentanyl than heroin, you can't reverse it with Narcan, the person dies. So they're a little more scared now. So we're all of a sudden seeing, you know, more and more admissions, thankfully. The legislation attached to initiatives was the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients and communities act, or also known as the Support for Patients and Communities Act in 2017 and 2018. A lot of money was put into those initiatives, and the Comprehensive Addiction and Recovery Act, called CARA, of 2016, and the Drug Addiction Treatment Act of DATA, right, called, that's the acronym is DATA 2000. That is where there was legislation put in place again for treatment, for recovery, for prevention, and for treatment services. But, we're still seeing so much more. Money is not always the answer. A lot of times it really is the full community awareness. I think having more people aware of prevention is ultimately going to be the answer. We have accepted uses of opioid, which is pain management. We have coexisting behavioral health problems, and I mentioned marijuana before. There's also THC and kratom, which, kratom is something that people can take as a pill or smoke. And now with over-the-counter kratom and cannabis, that is THC. So you could smoke marijuana, or you could take, the CBD oil, and it's the same thing. Up here in New York City, marijuana was legalized for recreational use. So you can't step 2 feet without smelling it. It is absolutely everywhere. Even driving in the car, it's everywhere. All right. So you see within a month how many people were smoking that we didn't even realize, and smoking under the influence now because they're not getting stopped. Nurse practitioner will see patients who are addicted to opioids in primary specialty, obstetrics, gynecology, urgent emergency schools, or anywhere. It is a complex issue. You have to treat the comorbid conditions because polypharmacy can rapidly become a secondary problem. So issues of depression and anxiety are often treated with multiple medications, but the symptom control of those are, again, a secondary problem. So these things have to really be cared for before you're ever going to get anywhere with the opioid use disorder treatment. Same thing with pain management. If the person has chronic pain and they're taking opioids illegally, you have to manage that pain. Something has to be done for that pain because that's going to just continue to drive them to use. The CDC did issue guidelines for opioid prescribing in chronic pain. And there's 12 recommendations, and they're essentially grouped into 3 categories. One is determining when to initiate or continue opioids for chronic pain. Another is opioid selection, dosage, duration, follow-up, and discontinuation. So there's guidelines on that. Another group of guidelines are how to assess risk and address harms of opioid use. Opioids for pain management should always be avoided except in select circumstances. And that really is oncology pain and things that are really where the addiction is really not going to be a big problem, but the pain is more the problem. When acute pain appears to be becoming chronic, which happens all the time, person hurts their back. Back is like number one, but person can hurt anything, knee, hip, anything. And, they're in acute pain, and then all of a sudden that becomes chronic. It doesn't go away. It's still there. That person within a few weeks really should be referred to a pain specialist because there are interventions that can be done to relieve the pain. But a person should never be left in pain. We all kind of agree on that, but the management is critical. So, whenever possible, we encourage the use of a non-opioid analgesics before even considering an opioid. Cognitive behavioral therapy can be successful in addressing the emotional discomfort associated with chronic pain. Remember that pain does take a huge physical toll. If anybody has ever had pain or watched a person in pain chronically, it really takes a toll. So it's not something you can just leave. Opioids for pain management, again, we said should be avoided except in select circumstances. Nurse practitioners really have a social responsibility to become part of prevention. And awareness is really important, right? Awareness is part of education with serious messages in places that count. So social media. Think of our daughters and all the young women whose lives we touch. They really are vulnerable. They need to really understand why it's so important to not pick up. That is a real important thing that, women everywhere should really be teaching younger women everywhere else. Remember, I don't know what everybody's memory is about the tobacco addiction, but there were really very dramatic television advertisements that showed what it was like to die from lung cancer or emphysema or what it was like to try to live with respiratory disorders, really dramatic, horrible, graphic, advertisements. And that was used to dissuade people from smoking. And I believe that it did work. We also then had other things like, Chantix and Wellbutrin and nicotine replacement therapies. We have some things like that for opioids, which we're going to go over later. But that type of awareness, that type of very dramatic awareness can really dissuade use. Adequate pain management, of course, we mentioned, but if you're treating a person for pain, understanding the nuances of pain, what is acute, what is chronic, what is musculoskeletal, what is somatic. So you really can figure out what is needed to be done for the patient in terms of pain relief. So it helps assure the adequate prescribing of the adequate medication. Pain has to always be investigated. It can never be ignored, but non-pharmacological therapies are recommended for musculoskeletal, anti-inflammatories, hot and cold packs. Something that's very, very, very helpful is physical therapy. And exercise, things like that. But if you refer the patient who has musculoskeletal pain to PT, and it's a good PT, they'll work with them on things that they could do independently. This, of course, is really, again, talk about barriers, right? Insurance companies don't often pay for the amount of therapy a person may need. So again, assuring that the person is going to a therapist who's going to really work with them and help them manage their pain after a few sessions. During primary care visits, a nurse can take a thorough assessment, which will be more likely to capture each person's risk. In social situations, we see pain, trauma, psychiatric, all these things should be really assessed. Assess the patient's social situation, their pain, their trauma, mental health, all these have to be really included in the assessment. And also very, very, very important is the family history of addiction. We do see many families, many people where all the family members use something, all the family members use opioids. Often they're introduced to opioids by a parent or a sibling. So those family things are super duper important because it's not only genetics, it also goes to lifestyle, it also goes to environment. Oftentimes the person really can't get better unless they're physically remove themselves from the family. And that, causes a whole other set of emotional issues. There's some red flags for potential use, which we just said: personal family history of addiction, trauma, a diagnosis of PTSD, anxiety, and depression also fold in there. A lot of times those three things are one. The person has anxiety and depression from the trauma. Another red flag is a spouse or a partner who uses and requests for opioid to relieve pain. There's screening tests that you probably do, the PHQ-29 to identify depression and the GAD-7 to identify anxiety. There's the CAGE, which is the alcohol use screening. But there's screenings, I'm sure you've used all of them in primary care to really determine if a person is at risk. So what we use for opioid addiction, and actually really all addictions, is the screening and the brief intervention and referral to treatment. So whatever screening tool you're using on your EMR or in your practice, you use when you find the results, if the person screens as a high risk for opioid addiction, or really even any addiction, you have to use your judgment. You can't just use the tool, but you use your judgment with your full assessment, your physical exam, your person's history, all of the things that we've mentioned up to now, your full assessment, along with the other risk factors: where they live, where they go to school, what other things do they talk about. All those things, along with the screening tool, can lead you to a diagnosis, right? You determine that a person is at high risk or actually has opioid use disorder. You can do what we call a brief intervention and referral to treatment. This is an evidence-based approach to identify people and engage them in treatment in a very short visit that you would have in primary care. So you identify the risk early, which allows for intervention. It should be part of every primary care person's toolkit. The substance abuse screening up here in New York, it's really routinely completed in every primary care visit. So the patients can screen low, moderate, or high risk of becoming addicted, and recommendations really are based on I have women's here, but it's person's risk level and the drugs they're using. Good communication shows an interest in the patient's life and struggles, acknowledges the patient's reasons and perspectives about using. Once you get the screening results, you have to assess the patient to see if they're really ready to stop. And this is the number one hardest thing. A lot of times, it's like everything else in psychiatry. The patient has to be the driver and make the decision that they want to get help, that it's time for help. So you have to assess their readiness. Sometimes they just aren't ready to let it go. And could be, you're not most likely not going to find out why they don't want to let it go on a primary care visit because you just don't have the time. But you have to assess if they do. A lot of patients, a lot of women particularly, are afraid that their children are going to get taken away from them. So that's a motivator for them. So back to, you see the next thing is motivational interviewing. That is the next step. You interview a person and you try to focus. It takes some practice, but it's a patient-centered way to interview to determine if the person wants to change and why they think a change is beneficial, and you explore options with them. So you have to kind of find out what's the motivator, right? Are they motivated to keep using, or are they motivated to stop using? And whatever you see on the screening and part of your history, that's really what you talk about, what's motivating them. And the focus is to try to get them ultimately to go for help, right? So once you do that, you have other things you have to do. If they are sexually active, you really need to counsel them for birth control. This is for men and women. If they're using intravenously, you should really screen them for HIV and hepatitis. If you live in a community that has needle exchange programs, you can send them. Early identification and treatment of behavioral health conditions should be integrated into care, treating anxiety and depression. And the APN provider must consider initiation of treatment and take steps to secure an appointment with a behavioral health provider when possible. That's referring, right? So on the referral, you have to know what's available in your community. Shared decision-making, that is a model of care where the person and the provider make a decision together. So if a person's willing to get help, but they don't know where to go, talking to them about, do you want inpatient? Do you want outpatient? Like working with them and figuring out the best solution once you identify that risk is present is how you would use shared decision-making. And then if you have social services or behavioral health providers in your network, in your neighborhood, near the patient's house or wherever, you really want to try to get them into services that are convenient for them, because we'll know that when you see a behavioral health provider, it's not a 15-minute visit, it's a weekly hour. So they have to be able to get that into the rest of their lives and facilitate the access, meaning maybe, make appointments for them, have appointments for them when they leave, have your staff work with it, whatever it is that you can do to facilitate access. Now, medically assisted treatment is medication that can be given in primary care office or in a drug treatment program. It lowers the potential for a fatal overdose, so that we call that harm reduction. So the priority goal is to hopefully have the patient not use so much that they harm themselves, right? So that's number one, first and foremost. Then the other goals, prevent pregnancy, stop using, take care of the rest of your physical health, reduce the violence and conflict in the family. All of those things become goals that the patient identifies and works on themselves. But the priority for you would be to do whatever you can to make sure the patient doesn't harm themselves, right? So the harm reduction is important. It's important for you to know what harm reduction, things that are available in the community for the patient. Okay, so harm reduction is a proactive, evidence-based approach to reduce the negative personal and public health impacts of behavior associated with substance abuse at the individual and community levels. Most significant substance use and overdose epidemic ever is happening now. It's not getting any better. You could blame a million things. It doesn't matter what the reason is. It's each individual's person's reason, why we look at why that person is using and what you can do to help them stop. And then for nurse practitioners, I personally believe it's our social responsibility to participate in anything, any way that we can on the prevention side. So this is there's a pandemic going on with COVID. Whether it's over or not doesn't matter, because we've seen a proliferation of highly potent synthetic opioids containing fentanyl at the same moment when the COVID pandemic occurred. So again, doesn't matter what the reason is. There was over 100,000 deaths, last year. There's probably going to be more than that this year, because it just seems like we're just seeing more. But fentanyl is fatal, right? And an overdose of fentanyl is often fatal. So it's really important that we look at harm reduction at home and in the community. So the 4 pillars of harm reduction strategy is accepting that if people are using, we have to accept this, all right? Because you're not going to be able to stop all these people from using. So we accept people in our neighborhoods are using, people in our families are using, our schools everywhere. Let's make the use at least safer. The goal, of course, is abstinence. But the other part of harm reduction is to meet the person where they are and address the conditions of the use along with the use itself. So here's some goals and strategies for all 4 of those pillars. The first is to reduce the spread of sexually transmitted and other bloodborne infections, including HIV and viral hepatitis. We mentioned that there's often a misstep in judgment, and unplanned pregnancies and these STDs are prevalent. This is a very prevalent problem, so it's part of the pillar of harm reduction to increase knowledge around safer sex and sexual health. And that is, again, access to PrEP, HIV and viral hepatitis treatment, access to condoms, but comprehensive sex education. And if your client is a woman, there are many options for birth control that she may just not have gotten around to because she's very busy with the rest of her life. And then this, of course, is a priority problem. So you may be able to get her engaged with, intramural IUDs or intradermal transplant or a NuvaRing, or something that, she doesn't have to take every single day, but can, really reduce her risk of getting pregnant. I have to say that in my patient population, my women are all okay with that. That's kind of, I hate to say covered, but that hasn't been a problem. It's been a problem in the men. Almost all of my men have within a year or two gotten a woman pregnant. So, they have to be counseled as well. So you have to make sure you really talk with them about that. And you're not going to most likely ever meet their woman, right? Reduce overdose deaths and early deaths among people who use substances, including alcohol, increase knowledge around safer substance use. So we have had syringe and needle exchange programs. I don't know if you have them in all of your communities, but here you can, if you are using with needles, you can go drop your needles off and pick up clean needles. And they just also approved for safe injection centers. So you can, if you are using intravenously, go to an injection center, inject safely at the center and hang around there for a while to make sure that you're not overdosing. There's nurses. I really don't know the details of how they're going to be operationalizing that yet because it was just passed. But the goal is to keep people from dying from opioid use. And then once they get into a center where they're using, a safe injection center, there will be people there to facilitate or assist them into abstinence treatments. And then there's the naloxone and overdose education kits so that overdose can be reversed, and those are prescribed and given to people who use and their family, as well as, first responders, but the lay people have them now up here. Another goal is to reduce the sharing of substance use equipment, improve physical health, and reduce, therefore then reduce the use of the spread of infectious disease. So again, the clean needle programs up here have worked, medical care, including wound care, because there's often injuries, especially when there's been violence. So caring for those things. And again, just like we've been doing now, using masks, social distancing, and vaccines. I'll tell you, I can only speak to my patient population. But my patients, almost all of them are not vaccinated. They're not working, so they haven't had to worry about their jobs, most of them anyway. But when I've asked them, why won't you get vaccinated? They're afraid of the vaccine. It's very interesting that they're afraid of the vaccine, but they're not afraid of the fentanyl and the heroin. it's an interesting thing to think about, like how this drives their lives and what other, things that they're kind of concerned about. They vehemently will not get the vaccine. That's been, and I know it because we ask our patients, and then we have to mask and have plexiglass and face shields and every other fool thing for the last couple of years. I'd like to let that down myself a little bit when I'm talking to a patient, but no, they're fully comfortable with a plastic bag over their head instead of taking a vaccine. Medication-assisted treatment is use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Medications used in MAT are approved by the FDA, and MAT programs are clinically driven and tailored to meet each patient's needs. So we're going to talk about those medications now. We have buprenorphine, Sublocade, naltrexone, Vivitrol, and naloxone. So the first was methadone. This was a drug that started to be used after the epidemic in the 60s and 70s. It's a controlled substance too. It's a full receptor agonist, which means that it activates the receptors in the brain. So the patient thinks they have, or the patient has, because methadone is an opioid, have opioid, but it's controlled, so it keeps them from wanting to use. It relieves all the withdrawal symptoms, it prevents cravings, and this way the person can stay sober. So their desire to use is quelled by the methadone, but they are not stoned. So they can go to work, they can conduct themselves and their family and have a full life. It's administered, though, only through a licensed opioid treatment program, and it's regulated by SAMHSA, and the programs have to meet federal and state guidelines. It cannot be prescribed in an office setting, and the programs also have counseling, peer support, treatment of other conditions. The risk of diversion is great, right? So yeah, they have to have processes in place to prevent the person from diverting, but methadone can be bought in the street. Okay, abuse and overdose potential is reduced if they're in a methadone program. So it's not just methadone, it's the whole program. It can be used in pregnancy. It can't be prescribed in primary care, but you should know where the treatment programs are in their communities, as many people have recovered through a methadone program. Other resources available through these programs are an important part of treatment. That's the behavioral health thing I mentioned. So remember, there's recovery and sobriety, right? So if a person takes methadone or any other drug and they're sober enough now, they're not stoned, they're not running around crazy, spending half a day looking for their next dose. They're able to think more clearly when they're on one of these drugs. They can then engage in the full comprehensive program of treatment, which is therapy, which is peer support, which is counseling, which is family counseling, which is getting their medical problems taken care of. So it's very nice to be sober and not craving. But recovery is different from sobriety, right? So sobriety means you're not stoned. Recovery means that you're actually working on the issues that drove you to use. You're working on all your problems. You're working on improving your family relationships. So really the first goal is to get them to stop using illegal, dangerous, harmful substances. The second goal would be to get them to stop using anything. And then of course, to have a full life back. Buprenorphine is a partial opioid agonist, but it works as an opioid. So it's the same thing as methadone, but it's weaker. When compared with the antagonist or blocker, when combined rather with the antagonist or blocker naloxone, it's known as Suboxone. So it's an opioid, right? Buprenorphine is an opioid, and it's combined with naloxone, which is the Narcan, which is the antagonist, and that keeps the person from being stoned, allows them to be sober, and it reduces the cravings. This does not have to be given. This can be given in any medical office, unlike methadone, where they have to go and get it every day. You give them a prescription for a month, they can take it every day for a month, keeps them sober, and it is a really good drug for that. It does, however, have a problem with diversion. If a person is taking, 8 milligrams twice a day and only needs 8 milligrams once a day, they can sell the other 8 milligrams. So we have to do UDS, we have to do, urine screening. We have to really judiciously prescribe it. For my program, I monitor them very closely. But, people get this in prison, it seems to be everywhere. So they'll come in and they'll say, oh, I'm on Suboxone, I'm on street Suboxone. I want to now become totally, I want to go into recovery. I want to get it legitimately. I don't want to talk to these people anymore that are in the street. And, that's how I know, and that's how they, patients tell us these things, what's really going on with the Suboxone. So we know it's diverted. So you have to have things in place in your practice to prevent that from happening. So it should be combined with counseling. Again, I mentioned this multiple times already. You have to treat the coexisting behavioral health problems. It can be administered in an office setting. The person has to be in moderate withdrawal, though. You have to give it to them when they're starting to crave. That's the appropriate time. And then the prescribers have to have the 24-hour course to get the data waiver. A data waiver means that you've been, you're accepted into the group of people that can prescribe buprenorphine. It reduces the cravings. They cannot get high no matter how much they take. It has a ceiling effect. So it doesn't produce the feelings of opioid use, but it reduces the risk of misuse and side effects. And again, I mentioned before, it allows for continuous sobriety and the person can focus on healing. Before benzos and buprenorphine are contraindicated to be prescribed together, but we see people come in already addicted to benzos that they're getting prescribed from somebody else. So before co-prescribing, you have to ensure that the patients are appropriately diagnosed, that they really have opioid use disorder, and they really have whatever the benzos are being prescribed for. I consider alternative medications and non-pharmacologic treatments to address anxiety and insomnia. Every one of our patients actually gets a full psych consult. Ensure that other healthcare providers prescribing benzos or other substances are aware that they're taking buprenorphine so that you can coordinate care and minimize risks associated with concomitant use. Many of them want to see 2 different providers. So you have to really work together for the benefit of the patient. You have to take measures to confirm that patients are taking their medications as prescribed, that they're not diverting or supplementing. So again, that's why we do the tox screen, because we see what else they're taking. Here's how to get the 24-hour training course if you want to access that. And more information on Suboxone can be found at this website. Sublocade is the extended release Suboxone. It can be prescribed in an office setting. It's available only through a restricted program called the Sublocade Risk Evaluation and Mitigation Program. It's an intradermal injection that's given, and it's extended use, so it lasts a month or longer. The goal of the REMS is to mitigate, the REMS program is to mitigate serious harm or death could result from a person actually taking it themselves. So the REMS assures that it's only being administered by a nurse or a doctor, and the patient can't take it themselves, because if they give it to themselves intravenously, they can easily expire. It's a 300 milligram dose for 2 months, and then a 100 milligram dose. So it's a lot of Suboxone. It falls into a reservoir in the person's stomach, and that's how it's slowly released. But it's a lot of Suboxone. So if a person accidentally injected themselves, they probably will pass away. So that's why there's strict release on who can get it. I'm going to have that here. The certified healthcare settings and pharmacies cannot distribute, transfer, loan, or sell. And here's more information available on Sublocade and the REMS program. There's always a risk of hepatitis, hepatic events in this patient population. So before you give them anything extended use, you have to really monitor their liver function tests before and during treatment. And you also have to understand that if they're dependent on any opioids, there's a withdrawal, right? So verify that they're stable on Sublocade, on Suboxone, before you begin to give them Sublocade. Intravenous injection, I mentioned this causes a serious risk. The other thing is that the Sublocade forms a mass if it becomes in contact with blood and body fluids. So it can make an embolism. So it could actually kill a patient. Occlusion, tissue damage, thromboembolic events. If any of this gets into the bloodstream as a pile, it could cause fatality. Injection site reactions are pain, erythema, pruritus, abscess, ulceration, and necrosis. And neonatal abstinence syndrome, of course, if a person is pregnant and they're on Sublocade, the baby will be born with NOWS, but it's expected and it becomes treatable. Naloxone is Narcan. This is the life-saving drug that restores normal breathing. It can be given as a nasal spray or as an injection. It's easily administered, and the lay public can be trained to take the naloxone. So it's pretty easy and has saved a lot of lives. These are the labels for naltrexone, which is not naloxone. Naltrexone is a different drug. It's a pill. It's taken once a day, and Vivitrol is the extended monthly injection. So naltrexone, when I talk about naltrexone, I'm talking about both, right? Opioid antagonist, it fully blocks the receptors in the brain. It can be given by mouth or injection, and by extended release, it's a 28-hour injection. It eliminates cravings, prevents relapses. So it's a great drug because it totally blocks any desire to use. In order to have this used properly, the person has to be completely detoxified from opioids. So they have to abstain for 7 to 10 days. If you give a person naltrexone and they have any opioid in their body, they get an abrupt withdrawal. These drugs interact and they cause what's called a precipitated withdrawal. It can be a very serious condition requiring hospitalization. So we always make sure before administering that there's no opioids. So that could be with urine or serums preferred, to assure that there's no opioid in their body before starting it. It's not addicting, so it presents no problem of abuse or diversion. It's not a controlled substances, can be prescribed anywhere. You do have to check the liver enzymes though before administering it. And you have to start with 50 milligrams once a day, the oral preparation, to make sure the patient can tolerate it. And then they can transition to the extended use if they want. A lot of patients prefer the pill because they have more control and it's short acting. They could go off it if they have another health problem. Vivitrol is the long acting, it's once a month. And once you take something, it's in you for a month. The injection sites can have some reaction, pruritus, tenderness, induration, swelling, bruising. And they're more likely during an accidental subcutaneous or adipose layer injections. It's an IM injection. So if it goes into the subcu or the adipose layer, the person's more likely to get a reaction. Both preparations should be part of a comprehensive management program that includes psychosocial support. Our patients often go to the AA meetings. Even though we have NA meetings, a lot of them prefer the AA meetings because those have been around longer, and they find that the sponsorship for alcohol is more effective for them than the narcotics. But they have options, and some go to both. But they have to be going to something, because that's part of MAT, medication-assisted treatment is assisted, not just the treatment. With Vivitrol, again, there's a risk of hepatotoxicity, so the liver enzymes have to be evaluated. It cannot be used in pregnancy, and the full product information is there. Patients have to understand the danger of opioid use when they're on Vivitrol, because sometimes they're on Vivitrol and they decide they want to use opioids. They don't feel the craving, they just decide they want to use it. So they wait for the 28 days to go by, and then they take the same opioid that they used to use. Now their tolerance has come down and they can overdose. Some of them try to surmount the blockade and take more than, because eventually you can overcome the block, but there's so much then the person will overdose. So they're vulnerable to a relapse overdose when the naltrexone is waning. After a month is over, they don't have any left in their body. That's when they're vulnerable to a relapse or an overdose. That's the dosing interval, right? So we have to make sure that they keep their appointments. That was something we take responsibility for. Should they use the previously tolerated dose? I mentioned that a fatal overdose could occur. Should they try to surmount the blockade? Again, the same thing. So if they take a large enough amount, it can be fatal. They have to really understand the risks of this. So when they commit to taking it, their responsibility is to come every month and to not attempt to get high. They should also have some Narcan on hand so that other people know how to administer. Encourage them all to carry Narcan. The daily or extended release versus the oral is, again, the patient's choice. There's more controlled use with daily, more control with daily use, a better, a shorter half-life. They can stop it whenever they want. But it's really, some people who tend to relapse want the Vivitrol because it protects them for a month, and it really keeps them from overdosing. So that's my presentation. Thank you very much for inviting me. This is my email address, and I'm available for any questions by email, telephone, or Zoom. And it was very nice to do this presentation. I hope you will learn something. Thank you very much.
I'd like to thank the Planning Committee for the opportunity to present this morning. And my name is Richard Lamphere. I'm the lead instructor for the Georgia Nurses Association Resuscitation Center. And today I'm going to present on heart-safe communities. I do have a couple of disclosures. I'm the lead instructor for the Georgia Nurses Association, and I'm also an instructor trainer for the American Red Cross, and I do provide CPR first aid training. Today's objectives is we want to learn the signs and symptoms of cardiac arrest, learn the primary prevention of cardiac arrest, learn secondary prevention of cardiac arrest, and then talk about the chain of survival. First, the chain of survival, just a quick refresher. Early recognition, and this is from the American Heart Association, early recognition and call 911. So what does a cardiac arrest look like? Second is CPR, quick CPR, early defibrillation with an automated external defibrillator or an AED, and then effective advanced care. And then we want coordinated care in the hospital. So make sure that the patient goes to the right hospital for the right type of care. So let's talk a little bit about primary prevention. And there's some key warning signs, especially in pediatric patients and also in young adults, that could lead to sudden cardiac arrest. I just want to clarify, there's a sudden cardiac arrest is different from a heart attack. A heart attack, we'd like to say that that's a plumbing problem, so the coronary arteries get occluded and prevent the blood flow going to the heart tissue. That can cause a cardiac arrest, but a sudden cardiac arrest is more an electrical disturbance in the electrical pathways of the heart, which causes a sudden collapse, usually without warning signs. A heart attack usually has some type of warning signs, and we'll talk a little bit about that. So key warning signs is exercise, emotion, startle, seizure, syncope. So when people are exercising, they could have symptoms, usually head symptoms. They feel dizzy, faint, or they can suddenly collapse. And then exercise chest to shoulder pain or shortness of breath. And when I'm talking to coaches, I always like to explain, when you see a running back or a wide receiver running with the offensive or defensive lineman, it may not be that they're slacking. Their heart rate could be elevated because of a heart condition. And so when they try to kick it into second gear, they're not able to. So that may be why they're getting shorter breath or they're complaining about chest pain. It's not because they're out of shape. It could be a cardiac condition. So I always like to remind them to think about that, just not to dismiss it. And then sudden, unexpected, unexplained death before the age of 50 years old of natural causes. We don't think there's anyone should pass away before the age of 50 of natural causes. So really think about your family history. So any cousins, uncles, grandparents that passed away before the age of 50, say from a single car accident that wasn't related to drug, alcoholism, falling asleep, they may have went into cardiac arrest before they ran off the road, and that's what caused the car accident. And also think about any drowning victims. There's some cardiac conditions when people jump into water, their heart can go into irregular rhythm, and that can cause the drowning. Their heart stopped, and that's they proceeded to drown. So sometimes they'll be listed as a drowning when really it could have been their heart condition. And those are genetic conditions that can be passed along to other family members. So think about those and think about that in your family history. And really know your family history. Does anybody in your family have any problems with their aorta or cardiomyopathy or channelopathies? And I always think about my sister who called me about 7 years ago and said that she needed to have heart surgery. And I said, oh, really, sis, what for? And she told me that she had this thing, it's called bicuspid aortic valves. Usually in the general population, someone who has bicuspid aortic valves is about 1 to 2%, unless your sister or brother or family member has that, then the percentages of you having that, of me having that, goes up to about 28 to 29%. And I said, you know, how long have you known about this bicuspid aortic valve? And she goes, oh, about 8 or 10 years. And I thought to myself, well, that'd be good information to share with your siblings. So after I hung up the phone with her, my next call was to the cardiologist to get tested to see if I had bicuspid aortic valve. I did not, but that's one of those things that I'd like to share with people, is that you really need to know your family's history. And then another thing to think about, when are children getting their ECG screenings? So we can do a simple EKG test, their primary care, you know, talk to your primary care providers about this, if this is something that your child should have. And there's some organizations that would do mass ECG screenings at local schools and other centers. So you may want to be on the lookout for those and really talk to your primary care physician about ECG screenings and pre-participation physicals, and also really talk about and dive deep into your family history, because those are some of the things that can put children at risk. They're very rare conditions, but they do happen. So it's really important that we can prevent them from a primary perspective before it happens. Next, I'm going to talk about secondary prevention. So what do we do if somebody has a cardiac arrest? This is really what we want to talk about, and this is how we can help keep our communities heart safe. And so what do we do when this happens? This is a basketball player by the name of Hank Gathers. He went into cardiac arrest during the NCAA tournament. And when he did, there were some things that didn't happen. One, they thought he was having a seizure. So CPR wasn't started immediately, and there wasn't an AED placed until he got to the ambulance. At the time, this was back in the 90s, and at the time, there's a famous incident or a picture of this in Sports Illustrated. The team doctor actually had the AED in his hand walking next to Hank as he was being taken out to the ambulance. So there's an AED there, but it wasn't placed until he got to the ambulance. So we really want to emphasize CPR. So anybody can do it. We all have the tools. We have our hands that we can press hard and fast in the middle of the chest. And one of the things that we know, there's about 4 reasons why people won't do CPR. One is, I'm going to hurt somebody. You can't hurt them no worse than where they're at. People think they're breaking ribs when they're doing compressions, but really what you're doing, it's like your knuckles cracking. And so that sound, when you push down on the chest, because of where the rib cage is set up, it pops and it feels like that, especially if you're the first person to start doing compressions. So don't be worried about that. The other thing is, you know, I'm going to do it wrong. People think they're going to do it wrong. You won't do it wrong. The only thing you do wrong is if you don't respond. And then people think they're going to be sued. We're all protected by the Good Samaritan Act. So, you know, you're protected by that as long as you're doing what you've been taught to do, or doing it to the best of your ability. And now with telephone CPR that was passed during the Georgia legislation, that 911 operators will help coach you through doing CPR. So don't be afraid. You're not going to hurt anybody. You're going to do it right, and you're going to be protected by the Good Samaritan law. So then I want to talk a little about automated external defibrillators, AED. And this is the third link in the chain of survival. So I want you to think about, in your facility, so your place of work, your place of worship, any gyms that you frequent, any community centers, your children's schools, your children's athletic leagues, but more, and also your children's practice facilities. I always think about going up to Gwinnett, to one of the football centers, and they have this beautiful football field, you know, spent millions of dollars on this football field. And I was talking to the director of football operations, and I kind of knew the answers to these questions. So I asked him, do you have an AED? He said, yep, we have one right here in the concession stand. I said, you know, we play football on Saturday mornings. We start at 8 o'clock. We play into the dark because we have lights on. I said, that's great. And this beautifully manicured field. And I said, well, how about CPR and AED? He said, well, we have an ambulance here for football games. We have parents that are doctors and nurses. They know how to do CPR. I said, those are, that's great. And then the next question I knew the answer to, because I said, now, where do you practice? I knew they weren't practicing on this beautiful field. He said, well, you go down the road, you turn left, and we practice at the old soccer fields. And I said, where's the nearest AED there? And he said, at the concession stand. Practice fields are probably a quarter mile away, maybe a half mile away. So I asked him, I said, how many knee surgeries have you had since you played at Georgia and played in the NFL? And he said 3 or 4. And he said, I understand. He said, we need to have an AED closer to the practice fields, or we need to have that portable AED that we can take with us. So it's so important. We assume that these things are in place, but when you think about coaches that are coaching our rec leagues and our little league players, they're really the parents that are able to get off work at 5 o'clock, get dinner made, get the children fed, and then get to practice by 6 p.m. They don't necessarily think about what can happen in these medical emergencies, and especially a cardiac emergency. So it's really important to make sure that your children are practicing and playing someplace that's prepared to respond in a cardiac emergency or really any medical emergency. These are things that you can use for any medical emergency. If somebody has a seizure, somebody breaks their extremity, breaks an arm or breaks a leg, gets a concussion or a head injury. So these are things that you can put into place that will really help in any medical emergency. So this is what an AED looks like, and it's going to deliver a shock. It's real simple, but a lot of times people think this is what's going to happen. It's not going to be like that. It's not like in the movies where they jump off the bed, 3 feet. It's going to deliver a shock, and it's going to convert the heart back into a normal heart rhythm, as long as we get there quick enough. And that's so important. Early intervention is so important. This is what it looks like when we open it up. This is what some people think it's going to look like when they open it up. So I don't want you to be afraid of using the AED. You do not have to be medically trained to use an AED. All you have to do is turn it on and follow the prompts. It's going to tell you to place the pads. It's going to tell you to clear the patient, make sure everybody's clear. It's going to tell you to press the shock button if a shock is advised. So some AEDs will automatically give the shock, will deliver the shock, will say shocking in 5, 4, 3, 2, 1, shocking, everybody clear. And then one thing I want you to know that if you turn an AED on, if the power's up, it can deliver a shock, even if it says low battery, it can still deliver that shock. So still use it to the best of your ability and to the best of what that AED is capable of doing. So it still has a couple shocks, even when it says the battery is low. But this is part what we'll talk about next. This is part of the emergency action plan. Who's checking the AEDs? Who's making sure the batteries are replaced? Who's making sure the pads are replaced when they expire? There's about a 2 to 4 year shelf life before these things expire. So we really want somebody to be the champion to be able to follow that. But this is, it's so important to deliver the shock as soon as possible, because early defibrillation, for each minute that passes, survival rates drop by about 10%. So it's so important. Put the pads on. It's not going to shock anybody who doesn't need it, but it will save a life to the person who does need a shock. So important to put the pads on immediately and listen to what the AED tells you to do, what the prompts say. So let's talk about the EAP, the Emergency Action Plan. So this is really where everything comes together. CPR training comes together. The AEDs, you have one in your building, you have one in your car, you have one at the practice field. So now how are we going to put these? We know they're great to have, but without a plan, they're just sitting on the wall, or somebody else knows CPR. So it's real important to have a plan. have a plan in place. And some of the things to think about is, one, what equipment do you have? So do you have an AED? After this presentation, I want you to check in work, church, or place of worship, schools, athletic leagues, the swimming pool, the community center. Is there an AED there? How many are there? Can you get to it? Is it locked up in the coach's office or the athletic director's office, or is it locked up in the school nurse's office, or is it locked up in security? Is it accessible? And then make sure there's a budget for replacement pads and batteries. And then think about the buildings. What's the building name? You may remember it as, the old Coca-Cola plant, but now it's been changed, or the old church, the Methodist church that is now a new building, or you may know, you can tell 911, what's the address of where you're at? So important. And then, do you have access? Can you get into the building from outside? You want to make sure that you have somebody that has access to that AED? Like this scenario I talked about, the AED being at the concession stand during practice. Is somebody there with a key to be able to get into the concession stand, because they're usually closed during practice? They're available for game days, but who has a key to be able to get to the AED if you need it? And then, are there elevators or stairs? I remember going to the Coca-Cola building and talking to some of their executives about having a heart-safe building. And we looked around I think we're on the 23rd or 24th floor, and we looked for an AED. There wasn't one there. The nearest AED was at the entrance on the first floor. So how long is it going to take security to get from the first floor to the victim up on the 23rd or higher floor? Where are the AEDs at in your building? I know they have emergency bypass keys that they can take the elevator directly up to the floor if they need to. But think about the time that has passed. You just saw that illustration of survival rates in the time of shock is being delivered. So one, you have to recognize a cardiac arrest. And when it happens, you're going to have that initial pause. Is this really happening to me? Two, you're going to have to start CPR. You're going to have to call 911. You're going to have to activate. You're going to have to call security and get them there. They're going to have to get the AED. And so all these things are seconds that are delaying time to shock. So important. And then think about EMS access points. Is there any construction between you and the nearest ambulance or nearest fire station? So think about that, when you go to work. I went past a road the other day, it was completely closed. So if I needed 911, I'd have to tell them that that road's closed. You're going to have to go around and come back to the back of the building. And then, are there any locked gates? Can they get through security? Can EMS get through security? Can they get into any practice fields or football fields or anywhere that you're at? Kickball leagues, softball leagues. What's the nearest place for that ambulance to get to the victim? Are the gates locked? Can you get them in the back door? And I always, think about soccer Saturday or football Friday when we have soccer games in Little League. A parent goes down or a grandparent has a heart attack and goes into cardiac arrest. If you've been to a soccer game on a Saturday, parking spots are at a premium. How is EMS going to get through that parking lot? Is it better to get them around back to where they can get through a gate to the victim? Or are you going to fly somebody out? Where's the helicopter landing pad? I know that's designated usually by the 911. When they get there, EMS gets there, or police or fire gets there, they'll find a landing zone. But think about these things as you're planning these venue-specific emergency action plans. I just want to show you this is the PepsiCo plant in Warner Robins, Georgia. About 5 years ago, they called us and said that they wanted to have some CPR instructors there. They wanted 6 people to have CPR instructors. This is the main entrance to the plant. And actually, it's bigger now. I believe this field has been expanded into more of the plant. I think it's about a mile square, but this is the entrance to the plant. You can see the parking lot. So most people would put an AED here, but how are you going to get that AED to this back section? So how many AEDs do you have? You know, here you can see the trucks back here. How many AEDs do you need to cover this area? And we say we want the shock off in under 3 minutes. So if you need somebody to take the AED from the front entrance to that back parking lot, it's going to take more than 3 minutes to get the first shock off after somebody collapses. So where do you want to strategically place your AEDs? How are you going to get them to the victim as soon as possible? And so it's so important to really do a site assessment and see where the AEDs need to be. You can cheat a little bit. If you have a couple AEDs, maybe put one here. It covers this building and then it covers this building, or maybe one over on this side or in this building. So it covers these areas that you can get a shock off in under 3 minutes. And then the other thing I want to talk about is, how about remote? What are you doing when you're having Zoom meetings? You know, just for example, this meeting. What happens if somebody has a medical emergency during a Zoom meeting? You know, what do you do then? Are you thinking about that? You know, whether it's school, whether it's work, or whether it's your family members that you're Zooming with. What happens if somebody goes, you know, if you see somebody slumped over at their desk or they grab their chest and suddenly collapse? What are we going to do? How are we going to get to that person? So are you talking to your staff about online emergencies? And then how do you know where that participant's location? Are they at home? Are they in a pod? Are they in the office next door to you? You know, do you know where they're at? So it's so important to know the location. Do you know that location's address? How are you going to call 911 and say, hey, my coworker is at, you know, 123 Main Street. It looks like they're having a medical emergency. Can you go there? Is there another family member there that you can call and say, hey, go check on them, because they may be in the office, you know, spouse may be downstairs working in another office. They don't even, you know, they don't hear each other. So is there a plan in place to be able to contact somebody to check on that person? So important to have the plan in place before you have to use the plan. I always say it's too late to Google it. You don't have time when a medical emergency happens. And what steps have you implemented for online medical emergencies? You know, can they call somebody? Do they have that number that they can call? You know, have you talked to them about a medical emergency at home, to where who's going to meet 911? You know, have the front door open so 911 or unlocked, so when fire or police get there, they can come in. You know, what are you going to do with pets and dogs? You know, do you have a dog? Do you need to put them outside? Do you need to put them in the bathroom so it's safe for the medical people to come in, or the police officers to come into your house? So these are some of the things that you really need to think about. And I hope and pray you never have to use them. But if you are ever in a situation where there's a medical emergency, I want you to be able to have a plan in place to be able to do that. So how do you communicate a medical emergency? What's your communication plan? So we have this person at work recognizes a coworker that collapses, or you see them collapse when they're online. How do you recognize that and get 911 there as soon as possible? So do you have a cell phone? Do you have a landline? If you call from a landline, they know that the address is going to show up on the 911 operator's side. So how do you get that ambulance to that victim as soon as possible? And then do you have an internal emergency response team? Do you know what to say? You know, my coworkers collapse, they're diabetic, you know, what do I do? And then, you know, can we get 911 there as soon as possible, or your internal emergency response team there as soon as possible? So think about that. You know, what do the emergency responders need to bring with them? So that's why it's so important when you're communicating a medical emergency to really be clear, concise, and think about what you see, what you hear, those types of things, to be able to communicate it. And then when you're building your team, think about your first responders. Who's going to be on your first responder team? If it's at a business, if it's at a place of worship, if it's at a community center, And I always tell people to think about a couple things. Who has who's been involved in medical emergencies before? Does anybody have any military training? Are there any EMS, paramedics, or EMTs or nurses? Who's had that training before? If you're in a school, is it the teachers? Is it the PE teacher? So somebody that's seen some type of medical emergency. If you're on a construction site, who's able to stay calm during an emergency? Who's seen blood before? Ask these questions when you're building a team. Are you afraid, do you faint at the sight of blood? Do you faint at, when you're getting your blood drawn? So really think about those things, and, think about your custodians in your buildings. So those people have easy access to the entire building, and they know the shortcuts to be able to get there. So it's real important to really utilize some of the people that you may not be thinking about. It may not be the supervisors, it may not be the executives. Those people may not respond during an emergency, a medical emergency. They're able to lead a team, but sometimes, those are the people that faint at the sight of blood. So be careful and have these open, honest conversations with each other. Who's going to respond? Who's going to get the AED? Do you feel comfortable, being with us during a medical emergency? Some people say yes, and some people say no, and it's okay to say no. That can be the person that can go out and meet the ambulance at the front of the building to get them to the victim as soon as possible. They can help escort the EMS services or police to get the person there as soon as possible. And then what type of training do you have for your first responders? What are some of the special circumstances? So, think about some of those things. If it's at a pool, you have to get that person out of the water. If it's at a park or lake, get them out of the water, dry their chest. You can still use an AED as long as they're out of the water and they have a dry chest. And then think about, some of the other special circumstances using an AED. Do they have a hairy chest? Are you going to need to shave it or cut the hair? You have to remove clothing. And we know that men are twice as likely to have CPR performed on them in public than women are. So it's so important to talk about that. You can start CPR through the clothing. When the AED gets there, you have to remove the clothing to put the pads on the chest. It has to have good adherence to the skin for it to work. And can you incorporate this with your fire safety training or your HR training during, the initial onboarding of a new employee, during new employee orientation? Can you do that? Can you talk about those things? This is what we do about a medical emergency. And when you think about a corporate culture, what better type of culture than you can have than thinking about your employees' safety and well-being, and really to give this life-saving training that they can take back out into the community and take back home to their family and loved ones and their friends, to be able to recognize, what you're doing for your employees, empowering them to help save a life. I think is really a bold statement as to the type of culture you have in your building, your place of business, or any place that you're at. What does it look like? When somebody suddenly collapses, there's two things that will throw you off. One is gasping respirations, somebody gasping for air, snorting or snoring. We'll breathe up to 3 minutes after our heart stops. There's enough oxygen in the brain to continue the respiratory drive. It's not normal respirations. It's gasping, it's snorting or snoring. So don't let that throw you off. And the other thing that will throw you off, especially in children and young adults, is seizure-like activity. So Hank Gathers, the basketball player that we had a picture of in the beginning, it looked like he was having a seizure. His arms and his legs would twitch and shake. We're not really sure if that's lack of oxygen to the brain, or it could be a lactic acid buildup in their muscles. So you get a cramp or Charlie horse, you hold your leg stiff or you hold your arm stiff until it passes. Well, if you're unconscious in cardiac arrest, those muscles may contract and make it look like you're having a seizure. A sudden collapse is a cardiac arrest until proven otherwise. There's only one thing that will make somebody suddenly collapse, and that's a cardiac arrest. If somebody's fainting, they usually slump down because the body is trying to get blood up to their brain. So don't let a sudden collapse throw you off. It's a cardiac arrest until proven otherwise. And then it's really important to respond. So immediately respond, tap and shout, are you okay? Are you okay? Check for breathing, normal breathing. If it's not normal, or if you're not sure, start CPR right away. And then what type of equipment you have. So what type of AED do you have? So what's the specific brand? And I like to point out this pad system right here. You can see it's like a Z. So this, a lot of AEDs just have single pads that go on once, top right of the victim, low left of the victim on their chest. But this one has this pad system, and this area right here actually gives real-time feedback for CPR. But if you practice and get trained on these types of pads during an emergency, when you open this up, you see this and you've never seen it before, it's going to throw you off. It's going to delay you getting those pads in place. Where is your box alarmed? Do you have good signage to show where the AED is? Who's replacing the pads? And then what's in your first aid kit? Do you have scissors? Do you have a razor? Do you have gloves? Do you have wipes? So what's in your first aid kit that's attached to the AED? Very, very important to make sure that equipment is maintained and up to date and that you have it available in case of an emergency. That AED may sit on the wall for 8 years. You haven't used it in 8 years, but then that one day, that one moment in time, somebody collapses and you got to go get that AED. You want to make sure all this equipment is there. And remember, anybody can use an AED. You don't have to be trained on it. You just turn it on, turn the on and off switch on, and listen to the prompts. It's going to guide you through it. And then here's an example of a cardiac emergency response plan. These are some of the things to look for. So what's the building location information? What's the building name and address? Who's on the cardiac response team members? You can put those members. We recommend that you designate if you're at an office building or school or someplace where you're in person, you may want to put some type of sign out on the side of the door. We don't want you to put a red cross or anything like that, just something that the internal people know what it means, that these people are on my first responder team. I can go to them and you can tell a coworker, go to, Betty's office and get her. She's on the first responder team. I'm calling 911, go get her and activate the emergency response team. And then sudden cardiac events can vary greatly. We know that you have the faculty, staff, the team members have to be ready to perform. Immediate action is critical to successfully respond to a cardiac emergency and really any medical emergency. And then we want you to practice, assign tasks, who's going to get the AED, who's going to go meet the ambulance, who's calling 911, who's the responders coming to do CPR, and emphasize early CPR. The person who sees the person going into cardiac arrest or finds a victim on the floor, they can start with hands-only compressions as the first responders get there. They can remove the clothing, put the AED on, but really emphasize early CPR, because when you're pushing on the chest, the heart's pumping. When you stop, the heart stops. So it's so important. And then debrief afterwards. One of my favorite examples of doing an emergency practice drill is, we'll put a mannequin down somewhere, and then the first person that comes by, will say, hey, I need help in here. We have this person laying on the floor. I don't know what to do. What do you do? And that's usually, that's my favorite time, because that person will say, they'll put their hands up and say, I'm not on that team. And that's when I'll say, you are now. So what are you going to do? Who are you going to recall? How are you going to activate your response? So, people work well when they have a task, when they know what to do beforehand. And then I tell people to bring an AED to every emergency. I'd rather you have it there and not need it rather than send somebody back that needs it, when you need it. So I want to try to delay, take away any delays to get that first shock off. And then debrief, really make sure that you're debriefing and going over what went well, what can we improve upon, those types of things. I remember, doing a practice drill. It took 8 minutes for that AED to deliver the first shock. So we said, what went wrong? So when the person went to get the AED, the cabinet was real hard to open up when they tried to open it. And so they came back and they said, the cabinet's locked. And the team member said, no, the cabinet's not locked. You have to pull hard. So on all of their AEDs, because of that drill, they put a little sticker on there that says not locked, pull hard. So that's, they learn that though in a drill rather than learning that during a true emergency. So that's why it's so important to do a drill. We do fire drills at work. We do, those types of other drills, inclement weather drills. So those are really the things that I want you to be able to practice. If you can't do it in person, at least a tabletop practice drill. And it only takes about 10 to 15 minutes to do one of these drills. It doesn't involve the entire staff or the entire school or the entire team. It just really takes that core team and have them practice what they're doing. So basic life support, identify the emergency, call 911 or the internal first responders, early high quality CPR, make sure that the AEDs are publicly available, and then advanced care and post-arrest care. So these are some of the things that we need to really emphasize. It's basic, but it's very, very important. And it's very stressful during a true emergency. So, we want people to be able to respond that may not have any medical training. So that's why it's so important to get them comfortable, get this information out and be able to do this. I just want to show you a case study real quick. So this happened going on 7 years ago. So a 17-year-old female was playing volleyball. She went into cardiac arrest. Now I want to warn people, this is very graphic. It's a very graphic video that shows an actual cardiac arrest in real time as it's happening. So I just want to show this video. And then I'm going to talk to you a little bit about what happens after the video, what that timeline of when things happen. So you can see it really was a well-organized team. And this is the timeline as to what happened. Her dad gave us the video. to let us use it as training purposes. So I really want to go through this timeline with you. So at 0 seconds, she grabbed her chest. 3 seconds, she hit the floor. So it was a sudden cardiac arrest. There wasn't any warning signs as far as when that was happening. There were some warning signs early on, some of that pain, syncope, some of those things that happened as we found out afterwards. At 16 seconds, a bystander tells someone to call 911. They didn't think a 17-year-old girl fainted. There was a cardiac arrest until proven otherwise. At 32 seconds, the AED arrives. And then at 56 seconds, CPR was started by a certified athletic trainer. Now that's almost a minute of recognizing a cardiac arrest and starting compressions from a trained medical professional. So that's what I'm talking about. When these things happen, is it really happening to me? So I think that's one of the important takeaways, is that we really want to emphasize early intervention because it's so important. The AED pads are put on at 1:43, a minute and 43 seconds. Defibrillation was delivered at 2 minutes and 11 seconds. So we got it delivered under that 3-minute timeline that we're really emphasizing trying to get to. And then CPR was discontinued at 3 minutes and 27 seconds. ROSC, I don't know if you saw that on the video, ROSC is return of spontaneous circulation. So her heart started to beat normally again at 3 minutes and 27 seconds. So that's how quick it happens. And then you saw the ambulance get there. And I think the timeline that ambulance got there was around 10 minutes. So she was, back awake, talking to people by the time the ambulance got there, because they had that team in place that had practiced these drills and really emphasized it's a cardiac arrest until proven otherwise. And I think that's so important and such a big takeaway, how fast things happen. She went from playing volleyball into cardiac arrest to being defibrillated all within about a 5-minute timeline. So what are some of the cardiac impacts of COVID? We know that it's causing myocarditis, which is an inflammation of the heart. It could cause pericarditis, which is an inflammation of the heart sac. And then some of the cardiomyopathy diseases of the heart may lead to heart failure. So these are some of the things that we have to look out for long COVID. And it's so important to help, to be aware of these symptoms and really to follow up with your doctors, your primary care doctors, your cardiologists. Get on that regimen, that plan of what, follow it to the best of your ability. But really, we want to prevent a cardiac arrest from happening. So important. So just in review, when seconds count, public's role is crucial in saving a life. We know that we have to have you recognize it before medical personnel get there. We have to have you recognize it, start CPR, get the AED to really make a huge impact on saving somebody's life. You have to be prepared. You have to have training and willing to deliver it. There's a lot of people out there that are trained, but are they willing to get in there and start CPR? Are they looking for somebody else to do it? But if you do something, remember, the only thing you can do wrong is not doing anything at all. So it's so important to do something. Whatever you do is going to help the victim. And then where's the AED? Can you get to it? Make sure you know where the AEDs are. You're all part of the AED family now. So when you're out traveling around, you have to find out where the AED is. I'm that person, when you're at a conference and they say, in case of bad weather, you need to exit here. In case of emergency, exit here. So I raised my hand at the American Nurses Association. So there's a room of 125, 150 nurses. I raised my hand and I asked the question to the lady at the podium, where's the nearest AED? And she, said, probably at the front desk. About 30 minutes later, we went to break. She came back and said, there's not an AED in this building. So we're going to have to do CPR for about 10 to 12 minutes because that's usually the normal response time of 911 getting to us. So we're going to have to do CPR for about 10 to 12 minutes before the AED gets there. And I always showed you what the survivability is as each minute passes. So you're going to be surprised where AEDs aren't that you think there should be. So, check at the grocery store, check at Target, check at any place you go, make sure at the community center, your church or place of worship, work, your schools, athletic leagues, all those things that I talked about earlier. And really, it's so important, time between onset arrest and the provision of care, that early CPR, early defibrillation. I know I'm saying that a lot, but I can't emphasize it enough. It's so important. So chain of survival, early recognition, don't let gasping, respiration, or seizure activity throw you off. Call 911. It's better to do CPR on somebody who doesn't need it than not do it on somebody who does. Early CPR, early defibrillation, effective and advanced care, and coordination of care in the hospitals. So make sure you're getting the victim to the right hospital, the one that has a cath lab that can do interventions, that can do, open heart surgery emergently. So those are the things that you really need to that chain of survival is so important. And then debriefing afterwards and making sure you follow up with the people to see how they're doing and how the responders are doing too. And then this is my contact information. If you have any questions, if you want to talk more about getting a plan in place for your facility, we're happy to help. My email address is here and also my cell phone number. People sometimes ask, well, how many people do you need to have a CPR class? My philosophy is if one person wants to learn CPR, I'll be more than happy to teach that one person, because that may be the person that needs to perform it in the coming weeks or months. So thank you again to the Planning Committee for allowing me to present this. Heart Safe Communities, anything I can do to help, anything Georgia Nurses Association can do to help to make sure you're prepared. And like I said, I hope and pray it never happens to you. But if it does, I want to make sure you give that victim the best chance of surviving. So thank you. Have a good day.
Hi, my name is Tasha, founder of Mode X Studio.
And my name is Orlando, head of operations at Mode X Studio.
And we are absolutely thrilled to have the Georgia Commission on Women's Summit here today at Mode X.
What is Mode X?
I don't know. Oh, tell me.
Mode X is a production studio and event rental space for live, on-demand, and streaming content. All right, we're a turnkey solution for master classes, TED Talks, entrepreneurship, conferences, mixers, film screenings, and more, all right? Our main studio features a 60-foot curved screen, floor to ceiling, making for an immersive viewing experience for all the attendees. Our mezzanine has a 30-foot wide screen, perfect for bringing creators together and bringing their ideas to life.
And we would love for you to do your production and event needs here at Mode X. To learn more, send us an email at hello@modexstudio.com. We look forward to hosting you soon.
I want to thank Tasha and Orlando for welcoming. Let's take this from the top. I'd like to thank Tasha and Orlando for welcoming us into their beautiful space, for making us feel so invited, and for allowing us to have such a beautiful state-of-the-art facility to be able to have the 30-year celebration for the second annual Georgia Commission on Women Wellness Summit. Let me tell you something, y'all. We have had phenomenal customer service today.
Thank you.
We have even had Mike over here, as you've seen him running in and out, trying to put people's, he's gonna run in again. Just do a run by, do a run by,
There
do
he
a
goes.
run by. We thank him so much for making sure that our sound is wonderful. And when I say state-of-the-art sound,
thank you. We
I
appreciate
feel
it.
like I'm truly on TV. Have we been on TV today?
We've been on TV today.
We've been on TV today, and we are so grateful. Tasha and Orlando, if you want to make a movie if you want to view a movie, if you want to see a movie, if you want to be in the movie, just movie. This is the place for
This
you.
is your place.
Modex.
Yes.
This is the
Synonymous
spot.
with movies.
It's synonymous.
Synonymous with movies.
Thank
Thank
you.
you so much for
We
having
appreciate
us.
it.
Thanks, Tasha.
So as we come to a close today, I'm
What a
telling
day.
you, we have planned,
Yes.
we have strategized, we have met, we've cried,
Yes.
we've prayed.
Boy, have we prayed.
Have we prayed to be able to make sure that we are delivering world-class content
And we
for
have.
our viewers? And I think we have accomplished that today, Janessa. What do you think?
And then some. I am just still in awe of all the topics that were presented today.
Yes, and
Right.
I really want to take the time to extend a very heartfelt thank you to our speakers,
Yes.
our attendees. We want to thank Brian Brown,
Yes.
who has done a
Yeoman's work.
yeoman's work on putting together a phenomenal event.
Yes.
I don't even want to call this an event anymore. You know what this is?
What is this?
This is an experience.
I like
This
that.
is the Georgia Commission on Women second annual wellness experience.
I like that, and I couldn't agree more, especially it being the 30th anniversary for the Georgia Commission on Women,
Absolutely.
right?
And to make sure that we are delivering content that has spanned a wide variety of offerings. We've heard about
Absolutely.
mental health, child sex trafficking. We talked about COVID-19 and gave
Yes.
them an update because COVID is not gone, y'all.
No, it's
we
still
even
here.
we even got monkeypox coming.
Yes, we
Okay?
do.
And we touched on that a little bit today. We talked about the HB 1013, the mental health parity bill.
So
And
important.
how that's really going to enable Georgians to be able to get the resources that they need
Yes.
to handle mental health issues. We have touched on the opioid epidemic, heart-safe communities. And we heard about entrepreneurship.
Yes.
And how to take your entrepreneurship efforts from a clinical standpoint to a nonprofit standpoint.
Yeah, we
So we're so grateful for the
Yeah.
depth and the breadth of experience and the
Yes.
speakers that we have had today that have been able to share their knowledge.
Yeah, you're absolutely right. And all the presenters today, they went above and beyond to offer content
Yes.
that support the three pillars of the Georgia Commission on Women, which is women's health, human trafficking, and maternal mortality. So much. And I know everyone can't view everything today. So what we're going to do is let this content live for the next month. That's July 10th. So if you weren't able to see all of the presenters, you have until July 10th to view those, right? And then once you view those, you'll be sent an email. All the participants will get an email, complete the survey in the email, and then we've partnered with the Georgia Nurses Association.
Yes.
And we will be giving, over 19 CEUs.
Yes.
How
also
important
known
is that?
Contact hours.
Contact hours.
Also known as CEUs.
Yes.
And it is so important for those of you out there who are providers, you are nurses, you know that you need these contact hours to be able to renew your license.
Yes.
It is very important that we understand and deliver content for you.
Absolutely.
To be able to do what you need to do to be the awesome providers that we know that you are.
I couldn't agree
Speaking
more.
of Georgia Nurses Association,
Yes.
we want to thank them for being one of our sponsors. Georgia Nurses Association.
They make it
GNA,
happen.
Always comes through for us.
Yes, they do.
As well as United Advanced Practice Registered Nurses of Georgia, the mighty, mighty UAPRN.
Yes.
We are so grateful for them and their quest to make sure that APRN roles as well as full practice authority is something that we can declare and decree that we are going to deliver for the
Absolutely.
citizens of Georgia through nurses, hopefully soon.
Yes.
We also want to say a very, very big thank you to Anthem AmeriGroup.
Oh, our title sponsor, absolutely. We thank them for their continued support and all of the initiatives, for the commission across this great state of Georgia.
Exactly. Also, the Atlanta Airport Chamber.
Yes.
We're very grateful to them and all that they're doing throughout all of Atlanta. They're a big group that has so many individuals that are part of the chamber.
Yes, they do.
Various organizations and companies, and most certainly you want to check them out. Maybe you want to think about joining them. How about the Atlanta Medical Association, the AMA?
Absolutely.
We're so
Another
grateful
favorite.
to them. We value and really thank our physicians.
Yes, we do.
For all of the years and the nights of studying and all that they do to keep us healthy. What about the Licensed Professional Counselors Association of Georgia?
Another great partner.
LPCA.
Yes.
They are our friends, the ones that keep us together when we need counseling.
Keep us
we
sane.
need those who are helping us with mental health issues. We're very
Yes.
grateful to them. And so it is incumbent upon us to thank our sponsors for
Absolutely.
always being there perpetually and for giving the commission the support it deserves and needs.
I absolutely agree. And before we end, I want to remind everyone that if you would like to take a look at all the content that was presented today, visit our summit website, which is georgiawellnesssummit.com, okay? And then also you can see this year's content as well as last year.
That's right.
Right? And if you're interested in becoming more engaged or active with the Georgia Commission on Women, visit our website at gacommissiononwomen.org. And also, if you're interested in attending a Zoom meeting, our next meeting is going to be on June 21st. Right? So visit the website, go on meetings, and click on the link, and we're happy to have you.
Okay? So just one more thing, Janessa. I am a nurse. I
Yes.
need contact hours.
Yes.
How do I get my contact hours again?
Okay, so you pretty much watch the Wellness Summit. That's going to be available to you all until the 10th of July. And then you'll be sent an email. In that email will be a survey. Complete that survey, and then the GNA will issue you a certificate for those 19-plus contact hours.
Phenomenal.
Right.
We're so grateful. And although we're proud, I'm a proud commissioner. And this is our proud executive director.
I am.
But we are absolutely humbled today.
Yeah.
To be able to bring this content to you. We look forward to engaging with you further throughout the rest of the year until our next amazing summit. There's a lot that is being planned and on the horizon for individuals that are excited about getting engaged with the commission.
Absolutely.
Okay?
Right.
So please make sure that you go on the website. Please make sure that you follow us on social media.
On social, we're on LinkedIn, Facebook, Instagram, Twitter.
Okay, and what is the Twitter handles? Are they all the same?
They're all the same. If you send a question to the Facebook, we'll get it on all three.
Okay, fantastic. So we want to wish you a wonderful Friday afternoon.
Absolutely.
And we look forward to seeing you again in the not-too-distant future for all of the amazing content that the commission has to offer.
Thank you again, everyone, for watching. Have a great afternoon.